Hello everyone, and welcome back to our multimodality imaging course. I'm Dr. William Zoghbi here, Houston Methodist. And good morning everyone in the Americas, and good afternoon in Europe, and good early evening in Asia. It's a pleasure having you, and I know we have more than 600 plus individuals who are watching one way or another. And the beauty of this also, in addition to getting us globally and sharing information with you, is that you could have it also at your leisure for about 2 months afterwards. Hope you enjoyed yesterday. And yesterday we focused pretty much on the latest in technology, what you should incorporate in your own setting. And we talked about coronary disease and applications of multimodality imaging and heart failure. And we enjoyed amazing case presentations with Dr. Tajik and our faculty. And today I think we have a special treat, talking about this whole sessions, the 2 sessions today on structural heart and valvular heart disease. And in the late afternoon here, at least, we'll be reading with the experts. And hopefully you'll have a chance to read with experts in echocardiography, CT, MRI, as well as nuclear and PET, and I think you'll enjoy these sessions. So to get us started, how best is to have 2 of the world experts in this field. One is Dr. Becky Hahn, who does not need an introduction. She's the director of structural heart at Columbia, and an amazing contributor to the field in all areas of valvular heart disease, and certainly tricuspid valve. And Dr. Gerald Lowry, professor of surgery here, and an amazing surgeon, multi-specialty surgeon, but certainly very focused on valve disease and valve repair, and a great contributor to the field with preservation techniques for the mitral valve. So with that, I'm gonna let you moderate the session and kick it off, and it's a pleasure having both of you here with us.
Well, thank you, Bill. And good morning to Rebecca. We're going to start off with a brief introduction to the anatomy of the mitral and tricuspid valve to provide an introductory process for people just getting started in their interventional career. So I think we can go ahead right now and proceed to roll with that, please.
So we've now removed the left atrium completely and the right atrium, and we're now going to rotate the heart forward: right ventricle anterior wall, left ventricle anterior wall, pulmonary artery, and aorta. And now we're going to start looking into the right atrium. And it's a little bit difficult to see with the pigmentation of the heart, but here we see the 3 leaflets: the septal leaflet, the anterior leaflet, and the posterior leaflet. The anterior leaflet being the largest of the 3, and posterior next smallest, and the septal the smallest.
Yeah.
It's important to remember the aortic root forms a direct relation with the septal leaflet and a small portion of the anterior leaflet, and we can demonstrate that by putting a finger through the aorta. And you can see here, right down in this area here, is the membranous septum and the central fibrous body of the heart. The His bundle would be passing through. This is the commissure between the anterior leaflet and the septal leaflet, and right in there is the AV node and the bundle of His in this anterior third of the septal leaflet.
Also, that relation is very important. Complications of the aortic root, like a ruptured sinus of Valsalva or endocarditis, can seep into the right atrium, and you may have some communications there, shunts. I think this is very important.
Yeah. So the tricuspid leaflets are very thin and redundant. They're less well organized in terms of chordal attachments than the mitral leaflets, more difficult to repair. Many of them are repairable, but certainly they're a little more of a challenge. And the papillary muscles are less well defined on the right side. Yeah, the tricuspid annulus is not completely planar. The septal leaflet is set down, and there's a little step up to the anterior leaflet as you come around. So right in this area here, the septal leaflet is a little lower than the anterior leaflet, and there's an actual little step up but you come onto this portion of the annulus to the anterior leaflet. So we're now going to completely rotate the heart around. So watch while we do this. The left ventricle, as you can see, is somewhat posterolaterally related to the right ventricle. So the right ventricle is the dominant structure in the normal anatomical arrangement. We're going to rotate it now. So the posterior wall of the ventricle is here, because this will allow you to look in straight at the anterior portion of the mitral apparatus, which is a much easier way to see it.
Notice the continuity of the aortic root, aortic valve to the mitral valve, to the anterior leaflet of the mitral valve.
And if we trim back the atrial wall here, you'll see as we go deeper and deeper, that continuity becomes more and more apparent. That's the line of the attachment of the left atrium coming up and over. The left atrium normally is up and over. So as we trim down here and get rid of the left atrial muscle, we identify the aortic mitral continuity, which joins the aortic root to the anterior leaflet of the mitral valve. And if we flip back to the aortic valve, the commissure between the left coronary and the non-coronary is located pretty much in the middle of that aortic mitral continuity. You can see here from the aortic lumen side, the left coronary leaflet, left coronary artery, non-coronary leaflet, and this lies pretty much in the midline of the aortic mitral continuity. And I think even on this dead pig's heart, you can see the change in the tissue here. There's a little fibrous triangle here that allows the root to expand in pre-ejection systole,
right,
isovolumic systole. Then we've got this rather fibrous aortic mitral continuity that joins to the triangle. And then we've got the mitral annulus, which continues down. You can actually see this on echo. This part here really all is functioning as part of this complex. But this area is less mobile on the echo. Then you see the real hinging occurring mostly in this area.
Yeah.
So that's the...
And the anterior horn of the annulus, right, is in this, elevated area.
Yes.
You remember the annulus?
Yes, the saddle.
The saddle portion.
The horn of the saddle is really this part coming up.
Because the annulus is not a planar structure, right? It is
correct.
It is a saddle shape. And also important from a clinical point of view and imaging point of view is that quite a few of the complications of endocarditis occur in this area. This is the mitral aortic intervalvular fibrosa. And, abscesses occur here,
yes,
shunts occur here. So I think
very common to have
important.
This area and the adjacent non-coronary and left coronary undermined and burrowed out. And that's usually the way you see that so-called false aneurysm, because this is rotted out, and then you have the wall of the left atrium behind here that contains it. So if we flip back to the inside of the left ventricle now with the posterior wall of the left ventricle over here, and here we're looking anteriorly. We now have the anterior mitral leaflet, which is more or less square and or rhomboidal shape. Some have likened it to a tongue, and it does most of the moving. Most of the motion of the mitral valve leaflets is in fact the anterior leaflet. The posterior leaflet is a more ribbon-like structure. You can see it here. It's a much thinner ribbon. It has 3 different sections, and those 3 are mounted around on the muscle. So this anterior leaflet's basically mounted on this aortic mitral continuity, which is all fibrous. Posterior leaflet is mounted on the muscle. You can see the annulus of it there, which posteriorly, you can pretty much see the true annulus. Anteriorly, this annulus is really hidden here. You can't see it very well, but that's where the muscle of the atrium ended. You can see the atrial muscle here, ending here, and then the leaflet itself continues up in humans about 4 or 5 millimeters to the aortic mitral continuity. The aorta basically flattens out. You see that rocking motion there. That's one of the motions like that.
Yeah.
Another motion is this pushing up and back, because the anterior portion of the mitral annulus here is actually pushed up like that. And so there's, when in diastole, this is concave in respect to the mitral annulus, and in systole, this is convex. So we get a semicircular shape to the leaflet here, and this convexity becomes more pronounced. And we'll show you how this is important in the setting of how we use annuloplasty rings and how we attach them, because if you push an annulus backwards and downwards like that, you can see you're going to get systolic anterior motion because the leaflet can't get out of the left ventricle. It's stuck there.
And Gerald, the annulus ring, the prosthetic rings that you just put them, if they are complete.
Yes.
They'll be put, right?
We've changed, as you know, we've done research on this ourselves using 3D echo, which we published in the Journal of American Society of Echocardiography. And what we've come to realize is that we should not put the ring across the anatomical annulus. We really should bring it up around the full saddle. Yeah. So our suture line now goes up into the aortic mitral continuity anteriorly, and that has enabled us to preserve this full motion
of it.
Our earlier method would go like that and limit the motion of the anterior leaflet in systole, and that's where we think a lot of SAM comes from in mitral surgery. So we're now going to cut down through the middle of the posterior leaflet, right through the middle of P2, and have a look at the papillary muscles, the chordae, and the leaflets in more detail. To note that the thickness of the left ventricle down towards the apex also gets very thin, and when you're doing what will be more and more interventions through or near the apex, you can see at the very apex, it's almost a millimeter thick like the right ventricle.
Indeed.
So this becomes, right at the very tip of the apex of the left ventricle, is a very thin area. So here we have a very nice view of the anterior mitral leaflet, or the aortic mitral leaflet, as some anatomists call it, and you can see it's attached primarily across the fibrous component. You can feel in here the central fibrous body of the heart and the left fibrous trigone, which is where the leaflets attach, and that's a little lump of fibrous tissue, and they're little extensions, little hair-like extensions, multiple hair-like extensions that go out of the muscle called the filii, F-I-L-A-E, of Henle, and that's what hooks the anterior mitral leaflet complex to the left ventricle, the right fibrous trigone and the left fibrous trigone, which is right down in here. And occasionally you can even see that on echo. There's so much fibrous tissue in these areas that you can actually sometimes see it. So now I have the anterior leaflet, and you can see this common pattern of chordae here where they come off the papillary muscles. There's typically a large thumb-like anterolateral papillary muscle, which you can see over here, which is usually solitary, and it will typically have the chordae coming up, and it's common for the chordae to come off a common trunk and then divide into a fan-like structure. So it's not at all uncommon to find a patient with a flail mitral leaflet with just one ruptured cord that's ruptured proximally, and this whole area, if you'd like to simulate a rupture, we get that ruptured, and then suddenly you've got a complete flail. So that's one of the disadvantages of having this fan-like structure. This is the posteromedial papillary muscle, and as you can see in this pig, it's got two heads. And the posteromedial papillary muscle typically has an anterior and a posterior head. The area of the anterior and posterior leaflets is similar. They're each about 4 to 5 square centimeters. And the posterior leaflet, you can see here, looks a lot less significant and looks like it has a lot less area because it is this more ribbon-like structure, but because it extends over such a longer circumference, the areas surprisingly are very similar. Another important thing to note is that the posterior leaflet is really not designed to move very much. The anterior leaflet is very mobile because it's only got these marginal chordae. These chordae right on the edge are called the marginal chordae. And then when we look underneath on the anterior leaflet, we find typically, and we'll just have to see what we got here, that there are strut chordae, and I think you can see a little bit of them here.
Yeah.
You see that line there? That is one of two strut chordae, and there are very few chordae on the back of the anterior leaflet. So that allows it to be very, very mobile and reach right across the orifice. Posterior leaflet has 3 rows of chordae. It has the marginal chordae, and then it has intermediate chordae that go under the belly of the leaflet to keep this area from bulging up too much. And then it has basal chordae, which less pronounced in this pig, but you'll often see chordae coming up in this area here, either from right in here or here. And they go to the annulus, and they keep the annular papillary muscle distance constant.
Wow, that was fantastic. It really helps, I think, a lot to visualize that in 3 dimensions with an open heart, so that echocardiographically, I think it really helps the imager, particularly when we're doing 3-dimensional imaging. So I really appreciated that. It was utterly fantastic. We should move on, I guess, to the first lecturer, and that will take it back to Bill Zoghbi. He'll talk about mitral regurgitation, the essentials of the new ASC SCMR guidelines. Bill?
Hello, everyone, and thank you for joining us. What I would like to address in the next few minutes is mitral regurgitation, the essentials of the new American Society of Echo and SCMR guidelines. For your reference, I think you should by now or be familiar with it. And this was published in 2017, addressing all valvular regurgitation native valves, and including among them is mitral regurgitation. So what's new in these guidelines? The emphasis on identification of the etiology and the mechanism, the use of a comprehensive approach, the importance of non-holosystolic MR, and we're going to emphasize that, the role of CMR and the methodology of CMR, and we will have a library of cases for you to brush up on and fine-tune, if you will, your skills regarding that. Well, the mitral valve apparatus is complex, so we're not talking about the valve itself. We're talking about all supporting structures of that allows coaptation of the valve. And the major 2 areas that we label as such is primary, which is the etiology is of the valve dysfunction itself. And you could see here a nice mitral valve prolapse, versus secondary, which is the valve is otherwise normal, but the abnormalities are either the left ventricle or the atrium that are deformed and causing the regurgitation. Our approach to identification and assessment of the severity of the regurgitation is to look at the pathology of the valve itself, the LV and LA size, Doppler with its 3 components, the flow dynamics, if you will, of the mitral E, pulmonary veins, regurgitant flow and fraction, and continuous wave Doppler. So you should have a systematic approach to that, from anatomy to color flow, pulse Doppler, and CW. These are the 3 components of the jet that everyone should be familiar and use in their evaluation, because at times the jet in the left atrium itself can be misleading because of eccentricity, particularly when you have abnormalities of the valve itself. So take a look at these. Severe regurgitation, one that is much more central as opposed to the eccentric regurgitation. The area in the left atrium itself may be much less impressive and a very eccentric with Coanda effect. So therefore, the recommendation for you is not to forget about the flow conversions and the vena contracta itself, and keep those in mind in your overall evaluation, because you may not see a very eccentric jet in the left atrium. So I think these are very important pointers for you. Flow conversions methodology, we're not going to go through the formulas themselves, but to keep in mind that I think this is an important component of evaluation of regurgitation severity. And at least I would use this semi-quantitatively always. And we know what the assumptions are for hemispheric geometry. The effective regurgitant orifice area may be underestimated in secondary MR. The most important thing, I think, as a message is be careful about eccentric jets. And last but not least is caution in non-holosystolic mitral regurgitation. If you have late systolic MR, color Doppler can be misleading in your evaluation of the severity of the regurgitation. You will likely overestimate that regurgitation because the regurgitation is not happening throughout systole. So therefore, you cannot use color Doppler measurement of severity, jet area, vena contracta area, of flow conversions, the effective regurgitant orifice area. This is a case example here in mid-systole. There is no regurgitation whatsoever. Late systole, you could see this regurgitation with its flow conversions. By CW, it's happening only late in systole. And I think this is very important. So you have to use other measures of it. Another way of quantitating regurgitation severity, which is the volumetric approach, comparing flow into the LV outflow tract versus the flow coming through the mitral valve at the mitral annulus, and comparing these flows. And the difference is the regurgitant volume and the regurgitant fraction can therefore be estimated. The advantages is that it's valid in multiple jets and in eccentric jets. However, the limitations that it needs training, it may be cumbersome, and particularly in low flow situations may be more variable, if you will. And you may not be able to use it if you have a lot of annular calcifications where it hinders the measurement of the annular area. So in the guideline, there is an algorithm for you to try to help you navigate the severity of regurgitation. On the left side, some specific criteria for mild mitral regurgitation: a small vena contracta width, a PISA radius that is very small, a mitral A wave dominance, and a normal LV and LA size in a chronic situation. On the other extreme of severe regurgitation, these are some specific signs that, if used collaboratively and together, like 4 or more of these, will give you a good idea that the mitral regurgitation is certainly significant and severe. Flail leaflet, a large vena contracta width, a large jet, pulmonary venous systolic flow reversal. I think that's going to be very important, and enlarged LV with normal function. In between, you may need some help of quantitation to try to help you navigate that from grade 1 all the way to grade 4 regurgitation. And importantly, from a significance point of view, grade 3 and above are important to consider clinically to address these valves. The note there at the bottom is that if you have a difficult transthoracic study or low confidence in the assessment, please use and refer these patients for either a transesophageal or a cardiac MRI. Let's go through some cases here. This is case 1, and you could see the pathology of the mitral valve. It's nice mitral valve prolapse. Notice that may not be evident to the eye that this is a late systolic mitral regurgitation, and therefore the concern of overestimation when you look at freeze frames or areas of color Doppler that you may overestimate. Notice that the PISA radius on the right side is 0.9, which is quite large, and therefore from the algorithm of the guidelines, you have some signs of mild regurgitation, and yet you have a PISA radius that's large. However, at the bottom, all values for effective regurgitant area by PISA assume holosystolic MR, and in this case, it is not holosystolic. You could actually quantitate it by usual volumetric method, and the regurgitant fraction is about 20 to 14%. If you use effective regurgitant orifice area, you will overestimate the severity. So please be careful about the late systolic MR. And the late systolic MR, you may have a little bit of regurgitation at the beginning, but I think the most impressive thing is later in systole. So be very careful about color Doppler in these situations. Case 2, a much more impressive regurgitation here, still eccentric with a mitral valve prolapse. Here, the regurgitation is holosystolic, and basically you have many of the criteria on the right side that tell you about severity of this lesion. The flail leaflet, the vena contracta width, the pulmonary vein systolic flow reversal, and enlarged LV with normal function. So basically, you could, yes, quantitate, and the quantitation shows you that the regurgitant volume is quite large, 70 to 85, depending on the methodology, regurgitant fraction between 59 and 70%, and an effective regurgitant orifice area of about 0.7, all of them pointing in that same direction of severity. And last but not least is this case of secondary mitral regurgitation. Not infrequently, you may have some eccentricity of this regurgitation. There is some flow conversions. You could see the PISA radius of about 0.6, which is somewhere in the moderate range, most likely. If you take a look at other views in short axis, you could see that the regurgitation is spanning the whole coaptation of the valve itself. And be careful also in the two-chamber view. It may be very impressive for you, the regurgitation extent, but because it is along the line of the coaptation of the leaflet, as opposed to when you see it here in the apical 4-chamber view. So if we take a look at our algorithm, these are intermediate values for regurgitations, probably in the moderate range. We could do some quantitation in this individual. And the quantitation tells us that the effective regurgitant orifice area is about almost 0.2, which is in the moderate range. Regurgitant volume 30 ml, a regurgitant fraction of about 40 to 50%, which is in the moderate range in secondary MR. So this is how you kind of put it together and come up with an assessment of moderate regurgitation in this individual with secondary mitral regurgitation. So in summary, a few things to remember regarding these guidelines and approach to mitral regurgitation: an emphasis on identifying the etiology and the mechanism. And if you need advanced imaging, please go ahead and do that. An integrative approach using the algorithm, hopefully that will help you. Importantly, beware of non-holosystolic mitral regurgitation. It can fool you for color Doppler. Role of CMR is very important in these individuals where you need more quantitation and you're not able to do that. And I would again refer you to a library of case studies on the web that can help you refine your overall assessment and evaluation. Thank you again for your attention.
Thank you very much, Bill. That was very important. I'd strongly endorse your comments about the importance of being aware of non-holosystolic MR and the need to further evaluate very eccentric jets. These are the two most common things we see for over or underestimation of MR in day-to-day practice. And that brings us on to the role of cardiac MRI in valvular regurgitation. And we're fortunate to have with us Dr. Dipan Shah, who over the last 15 years has established a nationally renowned CMRI laboratory here at Methodist, which has not only provided excellent clinical support to us, but has also been instrumental in new insights into the structure and function of the mitral valve, and has led to a number of quite important publications. Dr. Shah is the head of that lab and other imaging, and he's based here at Houston Methodist. And I'm very happy to introduce him to present his paper.
Hello, I'm going to speak with you today about the role of cardiac MRI in valvular regurgitation, and specifically in multi-valve disease. So here's a clinical case of a 77-year-old gentleman who presents with hypertension, atrial fibrillation, COPD, who has severe mitral regurgitation, and he's an outside referral for evaluation for mitral clip due to chronic heart failure symptoms. And here's what the CMR findings were on this gentleman. But let me kind of walk you through how we obtained these findings. And before I do that, let's just talk a little bit about how we approach isolated valve lesions by CMR. We'll talk about the basic techniques, talk about how we determine severity of the lesion, and then importantly also the consequences that the lesion has on the heart itself. And then we'll talk about how to approach multiple valve lesions in the same patient, talk a little bit about the pathophysiologic effects, and then some of the imaging caveats and pitfalls. So to start off with, I think first, and foremost, one of the basic things that we do in cardiology is assessment of LV size, volumes, and function. And CMR is an outstanding tool for this, as I think we've probably learned already in this conference, as it allows for direct ascertainment of left ventricular end-diastolic and end-systolic volume with very tight relationship for reproducibility as well as accuracy. In addition to the LV, CMR is also quite good for assessing the right ventricle, for assessing RV stroke volume as well as RV ejection fraction and RV end-diastolic and end-systolic volumes. And so we couple that with the use of the phase contrast CMR technique, which allows us to look at flow across a vessel, in this case, the ascending aorta, where we're able to measure the flow here is 93 mLs. And we can do the same thing by picking an imaging plane at the pulmonary artery to determine what the flow is across the pulmonary artery. And then using these techniques, the objective really is to try to solve for flow in all vessels and chambers within the heart. So the idea is to determine what is the RV stroke volume, the LV stroke volume, the pulmonary artery flow, and the LVOT or ascending aortic flow. And principle number one, I think, is that in the absence of regurgitation, all of these flows should be equivalent. So the LV stroke volume should equal the RV stroke volume, should equal the aortic flow, should equal the PA flow. And if there's valvular regurgitation, then there'll be a discordance in one of these measurements. And it's that discrepancy that we use to determine severity of regurgitation. So for aortic regurgitation, the preferred methodologies that we utilize is what we call a direct assessment of retrograde flow. So here we would actually do a phase contrast CMR technique in the aortic root, and then we're able to measure what the forward flow is across this location, as well as what the retrograde flow is diastole. And in this particular patient, there's about 70 cc's of reverse flow of aortic regurgitation. Now, there's other confirmatory methods that we can utilize. The other way is to actually compare what is the forward flow across the LVOT or the ascending aorta and compare that to the net pulmonary artery flow. Because again, in the setting of isolated aortic regurgitation, that difference should equate to AI severity. Or as a last resort, you could simply compare the LV to RV stroke volume differential, which could then give you an assessment of what isolated aortic regurgitation severity is. In addition to the quantitative methods that I described, there's also semi-quantitative methods that we can utilize as well. And so for aortic regurgitation, there's measurement of the anatomic regurgitant orifice area. So this is basically the size of the regurgitant orifice during diastole. And there's data suggesting that an ARO of more than 0.28 by CMR has fairly good sensitivity and specificity for identifying 3+ aortic regurgitation. In addition, we can also look for holodiastolic flow reversal in the descending aorta. And in this study, the presence of more than 10 milliliters per second of holodiastolic flow reversal was associated again with 3 or 4+ aortic regurgitation with fairly good specificity. For mitral regurgitation, we generally are going to use what we call the indirect method, where we would compare the LV stroke volume to the forward flow going out the ascending aorta or the left ventricular outflow tract. And we know again that if the LV is ejecting a certain amount of volume, if you subtract what's going forward across the ascending aorta, then that remainder in the absence of a VSD should be the flow that's going backward and represents mitral regurgitation. So in addition to that kind of primary methodology, there's secondary methods that can be utilized to compare the LV stroke volume to the pulmonary artery stroke volume, or again, as a last resort, to compare the LV stroke volume to the RV stroke volume. So, kind of semi-quantitative methods that can be utilized for mitral regurgitation is to, again, look at the direct anatomic regurgitant orifice area using these SSFP cine images. And in this study, an ARO of more than 0.4 centimeters squared had fairly high sensitivity and specificity for Seller's grade 3 or 4 regurgitation. So now let's move on to multivalve disease. And here I want to go over a couple of the basic principles again. One is the LV stroke volume, the LVOT forward flow or the aortic forward flow. What does that represent? That really represents both the systemic flow as well as any flow that's recirculating back that's aortic regurgitation. So what we measure here is a combination of the systemic flow plus the AI. The LV stroke volume, on the other hand, really represents the systemic flow plus any aortic regurgitation which comes back, and any mitral regurgitation, which is ultimately going to come back into the left ventricle again. And then the same way for the right side, the RVOT and the pulmonary artery forward flow really represents both your systemic flow as well as the PI. And then the RV stroke volume would represent your systemic flow plus any left-sided regurgitation, so PI and TR. So as long as we understand what our LV and RV stroke volumes represent, we can use this information, especially in the setting of multi-valve disease. So let's go back to our patient here. And again, this was a patient that was referred to you for severe MR, heart failure, for MitraClip evaluation. And in this patient, the way we approached it was to say, let's target one lesion at a time. And in this case, we said, let's look at the aortic regurgitation first. So we measured, using our phase contrast technique, the direct reverse flow that's occurring in diastole across the aortic root, just above the aortic valve level. And we measure here 70 cc's. And to determine what our forward flow is across the aortic valve, we measured flow in the LVOT, which measured 127 cc's. So this tells us now there's 70 cc's of AI with an aortic regurgitation fraction of 55%. So we're dealing with severe aortic regurgitation. So next, we corroborated this finding by also looking at the pulmonary artery flow. And in this case, there was some PI, and we can see some retrograde flow here in diastole. But the net pulmonary artery flow was 49 mLs. And so I could just compare the LVOT forward flow to the net pulmonary artery flow, because again, this will be a secondary check to say how much aortic regurgitation there should be. And in both scenarios, I get over 70 cc. So both of these data sets are pointing to severe aortic regurgitation. In addition to that, we could also look at the size of the aortic regurgitant orifice area. In this case, we measured out to 0.41 centimeters squared. And so that also is consistent with severe aortic regurgitation. So we've got concordance across multiple different parameters that we can utilize, which are all saying severe AI. Next, let's turn to our mitral regurgitation assessment for this patient with mixed valve disease. And in this case, if you remember, I said that the LV stroke volume is going to represent the systemic flow plus the aortic regurgitation plus the mitral regurgitation. So therefore, we can now, knowing that, we can know that if the LV stroke volume is 192 mLs, we could compare that to the forward flow across the aortic valve, which we saw before was 127 cc's, and therefore that difference is 65 mLs, again, suggesting severe MR. And then when we're calculating the mitral regurgitant fraction, we're going to divide that 65 cc's of mitral regurgitation over the forward flow coming across the mitral valve, which is basically the LV stroke volume minus the AI, and this gives us a regurgitant fraction of 50%. So really severe mitral regurgitation as well as severe aortic regurgitation. And that was this is our final report here, where we were able to look at the size of the LV. We can see there's significant LV enlargement. We can see there's significant RV enlargement as well. LV EF is mildly depressed. In this case, the RV was severely depressed, and you have severe aortic and mitral regurgitation. Now, let me skip forward here and just kind of wrap up. What are the kind of caveats that we look at? So one is that if you're dealing with aortic regurgitation in the setting of mixed AI and MR, your aortic regurgitant volume would be obtained by the standard method, which is the direct reverse flow across the aortic root. Your aortic regurgitant fraction, on the other hand, would be the aortic regurgitant volume divided by the LVOT forward flow. So again, that tells you what the AI severity is. Next, then, for the mitral regurgitation, the way we would compute that, again, would be to compare the LV stroke volume to the forward flow going out the left ventricular outflow tract. But then for the mitral regurgitant fraction, I think it's important here to subtract out the AI so that your mitral regurgitant fraction really represents the reverse flow across the mitral valve divided by what the antegrade or forward flow is across the mitral valve. Now, a couple of caveats to this, I think, are you need to keep in mind that the methods that I showed you here for assessing AI and MR would not be impacted by coexisting right-sided valve lesions. So if there was PI or TR, it would not have any effect at all. Another important thing to keep in mind is in the setting of atrial fibrillation, sometimes our direct aortic reverse flow, which again is our diastolic flow, may not be reliable if you have variable RR intervals like you do with AFib. And so in those cases, the preferred method would actually be to compare the LVOT forward flow to the net pulmonary artery flow, which I showed you was a kind of a secondary or indirect method, which could become a preferred method in the setting of AI with a lot of RR variability. And then what happens if all of our phase contrast techniques are not reliable at all? Well, ultimately, we can fall back on just comparing the LV and RV stroke volume. And by just comparing these two, if I know that the LV stroke volume is 192 and the RV stroke volume is 160, then I know that there's a significant left-sided regurgitant load. And oftentimes, if we have a difficulty in separating out what's MR and AI, we may just report a total regurgitant load, which in this patient is going to represent a very large amount of the total flow. So to kind of wrap up here, how do we approach valve lesions in general, as well as multi-valve lesions? I think the key is to try to solve for flow in all of the chambers, so the left side, the right side, as well as the aorta and pulmonary artery. And then I think the key is to systematically work through the equations, knowing what each of these flows represents. And I think when we do that, we're able to help quantify and determine severity of regurgitation in each individual valve. So with that, I thank you for your attention and look forward to having some discussion later today during the case sessions.
Thanks, Dipan. Just before I get Rebecca to introduce Dr. Bono, if you're getting ready to set up MRI, I think you can see that this type of analysis and data is really way beyond the capabilities of a non-cardiologist. And it's an existential fight you're going to have, but it's important to try to retain cardiac MRI as part of your department of cardiology and not let it drift off to the radiologists. We've had very bad experience with radiology-based MRI from outside hospitals. Thanks, Rebecca.
Great. Yeah, we couldn't agree more. I think, we need structural imagers that are actually expert in valvular heart disease, and that's what makes all the difference in these valvular heart disease centers of excellence. And speaking of which, it's really my great pleasure to introduce the next speaker, Bob Bono. He has his own Wikipedia entry. I don't know if any of you know that, but anyway, he is the Max and Lily Goldberg Distinguished Professor of Cardiology at the Northwestern University Feinberg School of Medicine, and also the editor-in-chief of the JAMA Cardiology Journal. And he has been the author or co-author on a number of guidelines as well as consensus documents. And today he'll speak to us on the new 2020 ACC-AHA valve guidelines, major changes in recommendations for primary and secondary MR.
Hello, this is Bob Bono coming to you from Chicago. Delighted to be invited back to be part of this symposium. I'd like to thank all of my colleagues at the Methodist DeBakey Heart Center allowing me to be with you. Bill has asked me to talk about the new recommendations for mitral regurgitation in the current guidelines. So we'll talk both about primary and secondary MR in the current guidelines. I have no relationships to disclose. Both the US and European guidelines have been published and updated, revised in the last 12 months. And so I'll be discussing the recommendations in both sets of guidelines as we go forward for both primary and secondary MR. And so for most of us, primary MR means patients with myxomatous valve disease, repairable valves for the most part. And we've made some important steps forward in recent years that have updated the guidelines appropriately. So the indications for mitral valve surgery for primary MR for both the US and European practitioners would be symptomatic patients. Class 1, of course, we recommend intervention to make patients less symptomatic. That also leads to not only improved quality of life, but also better longevity. For asymptomatic patients, left ventricular systolic function remains a class 1 indication for intervention. The difference is as follows. This has been set previously in the US as an ejection fraction of 60% or less, or a left ventricular end systolic dimension by echo of 40 millimeters or greater. That remains a class 1 indication for us. What's new is the European guidelines are now in sync, because previously they had set the cut point for systolic dimension at 45 millimeters. That's been reduced now to a lower value, which we feel is important and in keeping with what the US guidelines have been previously. So both guidelines now have a very similar end-systolic dimension threshold. For patients who are asymptomatic with normal systolic function, European recommendations have persisted in a 2A recommendation for patients who have atrial fibrillation or pulmonary hypertension to intervene in asymptomatic patients. Noticeably absent this year in the US guidelines, because that previously had been a 2A recommendation in the US guidelines as well. So why is that missing in 2021? Are we not seeing something here? Well, the reason it's missing here is because of the next recommendation, that mitral valve repair is a 2A recommendation in patients who are asymptomatic and have severe MR, if one can perform a successful and durable repair. So our thinking was that patients should undergo surgery because of severe MR. Why are we waiting for atrial fibrillation or pulmonary hypertension? The previous guidelines had been misinterpreted to suggest that we should wait until patients have AF or pulmonary hypertension. And the point is, we should be operating before they have those endpoints. And so clearly, if a patient comes in with atrial fibrillation, yeah, we should recommend surgery, but we probably should be recommending surgery because the patient has severe MR in the first place. So that's why that's missing in the upper recommendation, but very strongly stated in the current recommendations shown here. And further nuance here is in the US guidelines, intervene for asymptomatic patients in a center that can provide a durable repair without residual MR with a 95% likelihood in that particular patient with an expected mortality of 1% or less, whereas our European colleagues are looking for some other evidence of severity here in terms of left atrial enlargement, either using a left atrial volume index or a left atrial diameter by echocardiography. The further consideration in the US is if we're following a patient and there are progressive changes in left ventricular size or function on 3 or more serial echocardiographic studies, that's also a go-to point, at least at a 2B level of recommendation, to be considering intervening. It's reasonable to do that if we have serial changes, even if patients have not achieved the current thresholds that are relatively arbitrary. Indications for mitral valve surgery further for primary MR. Mitral valve repair is recommended strongly in preference to replacement when the anatomic cause is degenerative disease, if a successful and durable repair is possible, strongly stated in both sets of guidelines. Whereas, to make the point even stronger, in the US, we now have a class 3 recommendation. It is wrong not to perform repair, but to perform replacement, especially if the valve is totally suitable for repair. Leaflet pathology limited to less than 1/2 of the posterior leaflet. These patients should be sent to centers that can perform repair with a high likelihood of success at a primary or comprehensive valve center, and only consider replacement if even such a high quality center cannot perform a successful repair. The indication for a transcatheter approach with the transcatheter edge-to-edge repair device, the MitraClip, would be patients who are considered either prohibitive or very high surgical risk, favorable mitral valve anatomy, life expectancy less of greater than 1 year or greater, and have chronic severe primary MR. That's been upgraded from a 2B to a 2A in the US. It remains a 2B in Europe. Let's move on now to secondary MR, which is, as we've come to expect in most patients, a disease of the ventricle, of the myocardium. It's a primary myocardial disease in patients who have otherwise normal anatomic mitral valve leaflets. This creates, for all of us, important both diagnostic and therapeutic dilemmas. Can we really fully quantify severity of MR in these patients? And then what are our thresholds for intervention and therapy? Management of secondary MR. First and foremost is a strong recommendation that patients should first receive guidelines-directed medical therapy for heart failure, including CRT in appropriate patients, class 1 indication. European recommendation is similar, but somewhat nuanced. Mitral intervention in patients with LV systolic dysfunction only if symptomatic, despite guidelines-directed medical therapy, as determined by the multidisciplinary heart team. And then in the US, we also went one step further and indicated that a heart failure specialist should not only be involved as part of the multidisciplinary heart team, but should be the primary member of that team, responsible for implementing and managing guidelines-directed medical therapy and determining when we have exhausted all of the medical options, at which point intervention would be appropriate. So guidelines-directed medical therapy remains the keystone for managing patients with secondary MR due to LV systolic dysfunction. And as we all know, if GDMT is successful at reverse remodeling the ventricle favorably, that secondary MR will be significantly reduced or even eliminated. Now, what are the indications for transcatheter edge-to-edge repair if we have exhausted guidelines-directed medical therapy? TEER in selected patients with persistent symptoms on GDMT with appropriate anatomy by echo. It's a class 2A recommendation in both sets of guidelines. Now, in the US, we previously had no recommendation for this because we were waiting for the results of the COAP trial, which we now have. We have a new class 2A, and our European colleagues have upgraded that from a 2B to a 2A. In the US, we also have specified what those anatomic and functional considerations are. In addition to severe symptoms, patients should have an ejection fraction between 20 and 50%, a systolic dimension of 70 millimeters or less, and a PA systolic pressure of 70 millimeters of mercury or less. And of course, they need to have the appropriate anatomy of the mitral valve apparatus itself to allow for a successful repair. Further considerations, mitral valve surgery for severe MR in patients undergoing CABG. That's pretty straightforward. Class 1 or class 2A, depending on which guidelines we look at. And then surgery is still not prohibited. Surgery is still recommended, especially if patients do not have the appropriate anatomy for a transcatheter approach. So it should be considered in patients with LV systolic dysfunction, severe MR, if symptomatic despite GDMT. It's a 2B recommendation and usually only recommended in those patients where the transcatheter approach is not feasible. And then finally, we have a US recommendation that mitral valve surgery may be considered in patients with preserved LV systolic function, severe MR due to annular dilatation, if symptomatic despite GDMT, paying homage to the fact that we now have evidence of an atrial functional MR in some patients due to atrial enlargement and annular dilation, often associated with atrial fibrillation. So this is now creeping into our guidelines as well. We need more evidence to know exactly when and how to do this intervention, but it's a 2B recommendation at the current time. The final statement is that guidelines are just that. They are guidelines. They're a pathway to help us in our management of patients, but they are not legal documents. They are not mandatory edicts, and they're not cookbooks. We need to have flexibility to allow us for discussion with our patients, bringing in the patient's needs and wants into the consideration of our decision-making. We need shared decision-making. And then finally, and maybe most importantly, clinical judgment is really what drives our decisions. Clinical judgment is paramount. We need good judgment just to interpret the guidelines. And then we need good judgment to know how to implement them in treating the complex patients we now see with severe primary or secondary mitral regurgitation. Thank you very much for your attention. It's been great being with you. And I hope that next time we have this meeting, we'll do this face-to-face and not virtually. Thank you very much.
Well, thank you very much, Robert. That was an extremely clear and practical summary of a very complex situation. And that was an outstanding summary. We're going to move on now with my presentation on when to operate or replace the mitral valve surgically, and that will be integrated with Dr. Bono's talk, as you will see. Thank you. We're going to discuss the indications and timing for intervention, and the factors in the choice of type of valve therapy, repair versus replacement, surgical versus catheter-based. We have excellent up-to-date guidelines, as you can see here. We also have available a comprehensive survey of the state of mitral valve surgery in the United States from a recent review of STS database in a large number of patients. Now, in regard to indications for intervention, we do closely follow the guidelines that we just saw, and we place particular emphasis on change, such as the onset of symptoms or atrial fibrillation and progression in abnormalities. We also strongly support the recommendation for seeking out a center where high repair rate is routinely sustained. Now, the indications for selection of catheter therapy versus surgery are patients at high surgical risk, and these risks can relate to patient-related morbidities. Elevated pulmonary artery pressure, though, is usually not a problem. Procedure-related risks such as redos, other complexities, and the presence of severe calcification, and an inexperienced surgeon would also lean towards catheter. The magnitude of mitral leaf size, the extent of prolapse is not a problem and should never lead to replacement. Age is a relative contraindication. In our own experience in 2,300 repairs, elderly patients actually had quite a low mortality in these selected good risk people. The other major indication for catheter therapy is if it's superior to surgery. This has not been the case in elective primary MR surgery, but in the area of functional MR, especially in the setting of coronary artery disease and congestive heart failure and cardiomyopathy, some randomized controlled data suggests catheter therapy may ultimately prove to be the optimal approach. However, patients in all settings have an interest in catheter therapy because of no surgical incisions and rapid recovery. I think it's sobering to look at the most recent data from the STS ACC TVT registry, where they showed that persistent significant MR occurred in 8.7% of patients and significant mitral stenosis in a quarter of the patients, in addition to an 8% incidence of significant periprocedural morbidity. The indication for mitral valve repair versus mitral valve prosthetic replacement is not really very difficult. In patients with degenerative primary MR eligible for surgical treatment, timely well-performed surgical mitral valve repair is superior to mitral valve replacement in all aspects, especially the impact on early and late survival. The only exception to this is that myxomatous disease may cause MACC, and extensive MACC may require replacement. The survival penalty is particularly striking. From the MIDA study, we know that a prosthesis versus a repair leads to a 20% survival penalty at 10 and 20 years. Another group of considerations are the need for treatment of associated disease, most commonly coronary bypass or tricuspid valve repair. Most studies show that 15 to 20% of patients will require such adjunctive therapies. The tricuspid valve has been of particular interest in regard to whether it will resolve or needs repair. Usually it's functional and a simple ring is all that's needed. In the case of moderate TR, we have a randomized prospective trial just published that suggests that we should be more aggressive with the concomitant repair of moderate TR. Now, the timing of referral continues to be a very serious problem. In the STS database, only 10% of their patients had no symptoms of normal LV function. They commonly present with ventricular dysfunction, atrial fibrillation, and heart failure. In our own recently published data, 91% of patients had one or more risk factors related to delay in referral, and this carried a 10 to 20% survival penalty in the 10 to 15-year time frame. The Mayo Clinic reported on a group of patients who'd been seen at Mayo Clinic for an outpatient echo and then returned to the community. They did a follow-up and at 5 years, they found 64% of people had congestive heart failure, and only 15% had ever been referred for surgery. Medical therapy does not alter the natural history of mitral regurgitation and should not be used to delay intervention in whom it is the patient when the patient is eligible for such treatment. Now, mitral valve surgery is the fastest growing form of cardiac surgery in the United States, but at the same time, the repair rate is falling. The importance of experience is shown here. Only 4 centers had an experience of greater than 100 patients a year, of which we're one. Majority did 0 to 5. So the choice of surgical technique to use for mitral repair is very important. Our goal is 100% repair rate. And this should be rigorously defined by the definition of the STS database as number of repairs divided by repairs plus replacements. The classic Carpentier techniques are really obsolete, but are still the most widely used and taught techniques. Most inexperienced surgeons, unfortunately, have low repair rates using Carpentier techniques. The national repair rates of 63% and 82% for degenerative disease are unacceptable, given the 10-year survival penalty of 20%, as we just saw from the Midas study. This adds excessive mortality to about 11% of patients being treated surgically for mitral valve regurgitation in the United States. Now, the classic Carpentier technique developed in the 60s without benefit of echo consists of a rigid D-shaped ring and quadratic resection to remove the diseased segment of the mitral valve. Unfortunately, these techniques have very adverse pathological effects on the normal function of the heart. The rigid ring is sized to mid-systole, therefore always causes some degree of mitral stenosis. It flattens and immobilizes the saddle-shaped native annulus completely, and this impedes mitral valve leaflet closure. The rigid ring gets projected forward under the aorta, leading to steepening of the aortic mitral angle in systole, and this directs LV inflow towards the septum rather than the apex, causing SAM, and the rigid anterior edge of the ring compresses the posterior elbow T, which is primarily the anterior mitral leaflet of this level, and this also aggravates the risk of SAM. This is a highly stressed repair when completed. This can lead to ring dehiscence in 5 to 15% of people, and leaflet stress is also markedly elevated by the flattening and the resection. Suture dehiscence and calcification have been reported. Several groups of highly experienced surgeons have been able to mitigate a lot of these effects by extensive modification of the Carpentier technique. And Gilenoff has summarized these recently. Need expert intraoperative repair for accurate measurement of the leaflets, a suite of a variety of repair techniques which must be applied selectively, and the ability to apply these techniques, which they say requires a very experienced surgeon, to the point that they still feel that mitral repair is both an art and a science, not a rigorously reproducible therapy. The mitral valve is in fact highly dynamic. The anterior leaflet is attached directly through the aortic mitral continuity, the aortic root, which itself is also highly dynamic and is an integral, normal function of the dynamics of the aortic root are integral to the success of mitral valve repair. We have developed an approach which preserves all of these relationships and movements. We call this a physiological leaflet preserving restoration. It relies on dynamic simulation of end-diastolic and early systolic positions of the mitral leaflets, papillary muscles, and aortic root. No measurements of the leaflet height or width are performed. No leaflet resection is ever performed, and we totally reject the concept of excessive leaflet size. We do this by progressively distending the left ventricle, the left ventricular outflow tract, and the aortic root with normal saline at 4 liters a minute, and this simulates the isovolumic systolic state. We then, with the information derived from these simulations, we're able to choose the appropriately sized, flexible, adjustable annuloplasty ring and place neocordia of the correct length. This is how the repair looks. The annuloplasty ring completely flexible, and rather than going to trigone, it extends up to the aortic root. We've shown from 3D echo studies that the normal annulus is restored after this type of mitral annuloplasty. Here the postoperative TE shows the normal motion of the anterior mitral annulus with the aortic root expansion and systole, and the narrowing of the mitral annulus in systole by forward movement of the posterior annulus. Here's a very large, non-resected anterior leaflet, which has been repaired with cordia and a flexible ring, and you can see wide open preservation of the left ventricular outflow tract. We've recently reported our clinical outcomes in these people, and we've found that in the 10 to 15 year time frame, we have no significant MR in about 95% of patients. Reoperation rate, freedom from reoperation 95%, and freedom from prosthetic replacement of about 95%. Most importantly, we've demonstrated that the highly stressed damaged valve is restored to normal or lower than normal leaflet stress postoperatively. In the few numbers of patients who do recur, our first effort now is to repair them by transcatheter intervention. We found that in the presence of large unresected leaflets, this is an ideal setting for the MitraClip, and this is now our first line approach. We also might see mitral regurgitation in the setting of HOCM with SAM, producing dynamic outflow tract obstruction. While this usually responds to a comprehensive resection of the hypertroph, the anterior leaflet in these people is often larger than normal, and there are also other congenital anomalies of the cordia and papillary muscles. For these reasons, it is best to refer these people to a center experienced in both these diseases as identified by the Hypertrophic Cardiomyopathy Association. I'm proud to be able to say we have been designated as one of these centers of excellence for these conditions. So in conclusion, successful mitral valve repair is the optimal treatment for primary MR. Only a small minority of surgeons have achieved the skill and experience to achieve acceptable results using highly modified versions of an obsolete technique introduced in 1968 without benefit of any echocardiography. Newer techniques designed to preserve and restore normal mitral physiology are easy to learn, require minimal echo support, have a single main component, and produce high repair rates. Choice of surgeon is an important part of the care of these patients. Thank you.
That was a fantastic review, and really important for us to realize the options for our patients. And we'll move on then to interventional options. So Sachin Goel will do our next lecture, and he is the director of interventional structural heart program at Houston Methodist, and really an expert in all interventional devices, including the tricuspid. So hopefully he'll weigh in, obviously, on our next sessions after this. And he'll speak today about percutaneous techniques for mitral valve repair and replacement, state of the art.
Hi, good morning. My name is Sachin Goel. I'm an interventional cardiologist at Houston Methodist DeBakey Heart and Vascular Institute. My topic today is percutaneous techniques for mitral valve repair and replacement, state of the art. These are my disclosures. Mitral valve interventions, transcatheter, really started with percutaneous transvenous mitral commissurotomy, also known as balloon mitral valvuloplasty for rheumatic mitral stenosis. This was designed about 3 or 4 decades ago when Dr. Inoue first performed the transvenous transseptal balloon valvuloplasty for splitting the commissures, as you can see here in a case of rheumatic mitral stenosis with significant improvement in the mitral valve area. This really paved the way for transcatheter mitral interventions. This is a slide you've all seen. As our population is aging, the incidence and prevalence of structural heart disease, aortic and mitral is increasing. In fact, mitral valve has a higher prevalence compared to aortic valve disease. There's a huge unmet need for catheter-based interventions for mitral valve disease. These are recent statistics, over 4.6 million patients in the United States with greater than 2+ MR. On the other hand, only about 55,000 surgeries for mitral regurgitation annually, which is about 3% of the total number of patients that potentially are candidates for this. So there's a large and growing unmet need. We looked at this several years ago in a large data set from Cleveland Clinic, where 50% of the patients with severe mitral regurgitation were only medically managed. Of course, a lot of these were functional MR, but there was a proportion of patients with degenerative MR, severe MR, that was only medically managed. And patients with significant mitral regurgitation that are only medically managed have associated high mortality and morbidity, including heart failure hospitalizations, as demonstrated on this slide. The mitral valve anatomy, as you all know, is fairly complex compared to aortic valve. There's the mitral valve apparatus, which includes the leaflets, the chordae tendineae, the papillary muscle, as well as the ventricular wall. And pathology in any of these components could result in mitral regurgitation. For sake of nomenclature, you all know the anterior and the posterior scallops are divided into 3 scallops, A1, A2, A3, and P1, P2, P3 from lateral to medial, from the lateral commissure to the medial commissure. This is important when we talk about edge-to-edge repair. So broadly speaking, the causes of MR are primary, which is related to intrinsic involvement of the leaflets and chordae, and secondary, which is caused by left ventricular or increasingly recognized by left atrial pathology. This is the Carpentier classification, which you are familiar with. The type 1 or the type 3B are the typical functional mitral regurgitation, and the type 2 is the classic primary mitral regurgitation related to flail or myxomatous degeneration. Here's an example of degenerative MR in a case of flail posterior leaflet. It's a very degenerated myxomatous valve. Transesophageal echo image with a 3D image demonstrating multiple prolapsing segments with a posterior leaflet flail with resultant severe mitral regurgitation. Here is an example of functional mitral regurgitation resulting from LV dysfunction, apical tethering of the pap muscles and the leaflets, and tenting, and resulting central non-coaptation with severe mitral regurgitation. The edge-to-edge repair technique is based upon the Alfieri stitch technique, which was performed by Dr. Alfieri, Italian surgeon. And this is, as you know, a transvenous transseptal technique, whereby the mitral clip is advanced from the femoral vein across the septum into the LA, and the leaflets of the mitral valve are grasped typically in the A2P2 position, but this is not the only location where we can do this, as I will share in subsequent slides. The first major randomized study was the Everest-2 randomized trial, which randomized patients to surgery or percutaneous repair with a mitral clip. And the main findings were that although percutaneous repair was less effective at reducing MR than conventional surgery, the procedure was associated with superior safety and improvements in clinical outcomes. When you look at 5-year data, the Kaplan-Meier curves are essentially superimposed, meaning there's no difference in 5-year mortality in patients who are randomized to mitral clip versus surgery. Of course, there is the early hazard of severe mitral regurgitation requiring surgery in the first year, but beyond the first year, the curves are again superimposed, meaning there was no need for redo surgery or redo mitral clip or an intervention after the initial success of the procedure. And there were similar reductions in mitral regurgitation and VHA class over 5 years in both arms. Based upon the Everest study, the FDA granted approval to mitral clip in the treatment of severe mitral regurgitation secondary to a primary abnormality of mitral apparatus in patients who are prohibitive surgical risk, as determined by a heart valve team. This was the first time mitral clip made its way into the guidelines, which is the 2017 guidelines, and we'll talk about the latest guidelines shortly. But suffice to say, the mitral clip was granted a Class 2B indication for primary MR. Anatomic suitability criteria. These are broadly classified into optimal, conditional, and unsuitable. These are mainly determined by echocardiography, transesophageal echocardiography, and most of these patients in the early trials were optimal, but then we do treat a lot of patients who are not just optimal, but also some of these in this category. And then these patients who are unsuitable or even perhaps conditional are now being enrolled for transcatheter mitral valve replacement. We'll talk about that briefly. Here is an example, some examples of MitraClip in primary or degenerative MR. This was the same case we showed earlier with P2 flail. This patient was treated with 2 clips in the A2P2 scallop region with resultant trace mitral regurgitation. That was central pathology. Here is an example of non-central pathology in a patient with A1 flail, as you can see on this bottom right image with the 3D TEE, which shows the flail in the A1 scallop region with severe eccentric mitral regurgitation. This patient was successfully treated with 1 clip with essentially complete abolishment of mitral regurgitation. Another example of a non-central pathology. Again, TEE images are critical in not only diagnosing this, but also guiding the procedure. And you can see the medial scallop, the medial commissure here. This is a very commissural flail, successfully treated with 1 clip. The hemodynamics are really pretty amazing here. And when we see this, we know this patient is clinically going to feel better. Here's a V wave of almost 90, which is reduced to a V wave of about 25 in that particular example. There are next generation MitraClip devices which have longer arms and broader clips. So we now have 4 different devices, the NT, NTW, XT, and XTW, which allow us to tailor therapy based on patient anatomy and valve area and so on. And we are using a different combination of these devices and learning more about this. Of course, with the COVID, we've like other centers have the opportunity to treat some patients on an urgent or emergent basis during the COVID pandemic with success. The next group of patients that can be successfully treated is the functional MR. And as you all know, the COAPT trial was a landmark trial which randomized patients with functional MR 1-to-1 to MitraClip and GDMT versus GDMT alone. This was the main finding. The primary effectiveness endpoint, which was all hospitalizations for heart failure, was clearly in favor of MitraClip in addition to GDMT, with a hazard ratio of 0.53 and p-value of less than 0.001. The number needed to treat was 3. These were pretty remarkable results. All-cause mortality, similar story, statistically significant in favor of MitraClip on top of GDMT with a number needed to treat of 6. Death or heart failure hospitalization, same story, number needed to treat of 4.5. This is just a quick slide showing you the number needed to treat when we look at heart failure population and secondary MR. The number needed to treat for different treatment modalities, ACE inhibitors, beta blockers, CRT, ARNIs, the relative risk reduction and the number needed to treat, is in the 20s or 30s. But with MitraClip, the number needed to treat to reduce 1 death is 6. So these are important to remember when taking care of these patients. Here is a quick example of functional MR, typical cardiomyopathy patient with central broad jet in the A2P2 predominantly that was successfully treated with edge-to-edge repair. This was a patient whose anatomy was suitable and met the COAPT criteria. The pre-MitraClip V wave was 64 millimeters of mercury, and post-MitraClip V wave was reduced to 20 millimeters of mercury. And we like to see this. Patient has clinically significantly improved in terms of quality of life. We looked at whether edge-to-edge repair in patients with ischemic or non-ischemic cardiomyopathy has any difference, and it doesn't appear to be based on this national database. Based upon the COAPT data, the FDA granted approval to MitraClip in functional MR back in March of 2019. And these are the most recent 2020 valve disease guidelines. And the main message here is the mitral edge-to-edge repair is of benefit to patients with severe symptomatic primary MR who are at high or prohibitive risk for surgery, and to treat a select subset of patients with secondary MR who remain symptomatic despite guideline-directed medical therapy for heart failure. So MitraClip, the new terminology now is TEER, or transcatheter edge-to-edge repair. And here's the timeline briefly. The Everest study was published back in 2011. The FDA granted approval for primary MR in 2013. 5-year results of Everest was published in 2015. The COAPT was presented in 2018, followed by approval in 2019, and guideline recommendations and NCD back in 2020. So the TIER is now upgraded to a class 2A recommendation from class 2B in the previous iteration of guidelines for higher prohibitive risk primary MR patients. In addition, for secondary MR, the new guideline, this is important to remember, is now 2A for MitraClip. In patients with chronic severe secondary MR related to LV dysfunction, EF less than 50%, who have persistent symptoms and YHA class 2, 3, or 4, while on optimal GDMT for heart failure, TIER is reasonable in patients with appropriate anatomy defined on TEE with EF between 20 and 50%, LVESD less than 70%, and pulmonary systolic pressure less than or equal to 70 millimeter mercury. These are the criteria, the inclusion criteria in COAPT, and these are what the guidelines reflect. So it's important to remember that these are now class 2A recommendations for both primary and secondary MR. The REPAIR MR trial is an ongoing new trial, which is evaluating the safety and efficacy of MitraClip in severe primary mitral regurgitation in patients who are intermediate risk for surgery. So these patients have to be symptomatic or asymptomatic with EF less than 60, PA pressure more than 40, or LV and systolic dimension more than 40. Or if they are more than 75 years of age, they automatically meet the criteria. If they are younger, they have to have a STS-PROM score of more than 2% and other comorbidities, which may introduce a potential surgical impediment. These patients are being randomized 1-to-1 to MitraClip or surgery. This is a very exciting trial that is currently enrolling. Moving on from edge-to-edge repair, the other mitral repair, transcatheter mitral repair techniques include coronary sinus-based devices, such as the Carillon device, which has this nitinol anchor that is inserted via catheter techniques into the coronary sinus. These techniques use the relationship of the coronary sinus with the mitral annulus, and by cinching the coronary sinus, this leads to a better coaptation of the mitral valve and reduction in mitral regurgitation. Neocords are extensively used by surgeons. This is a transcatheter technique whereby neocords can be inserted from the apical axis, and this is now being studied. The Gore pipeline device, which is now acquired by Gore, is a study which is evaluating the safety and efficacy of septal transcatheter-based neocords for treatment of primary mitral regurgitation. Pascal device is an edge-to-edge repair technique. This is similar to the MitraClip with important differences. It has a spacer in the middle, and this is being evaluated in the CLASPS group of studies, the CLASPS 2D for degenerative MR and CLASPS 2F for functional MR. The 2-year outcomes of the CLASP study so far appear to be very favorable, and these patients are being studied long-term. The Edwards Cardioband mitral reconstruction system is again a indirect annuloplasty-based device whereby anchors are placed on the mitral annulus via transseptal transfemoral technique, and these are being evaluated for mitral regurgitation by improving the coaptation by cinching these anchors after placement of these anchors in the mitral annulus. The next big category is transcatheter mitral valve replacement. These are the various devices that are being studied actively as we speak in the treatment of mitral regurgitation, both primary and secondary. The Tendyne valve by Abbott probably has the most data so far. And based upon the first 100 patients that have been reported a couple of years ago, the technical success was 96% with a 30-day rate of death of 6%, with very significant and sustained improvements in mitral regurgitation after implantation of the Tendyne device. This is only an apical system at this time. The Intrepid global study, Intrepid is the Medtronic valve. This is a dual stent design. In the early experience, there have been device implant success rate of 98%. And this is being evaluated in the large-scale Apollo trial, which has a primary cohort, either primary or secondary MR, and then a MACC cohort, which is evaluating patients with MACC and significant mitral regurgitation. So who are candidates for TMVR? So the patients, those who are not great candidates for edge-to-edge repair due to anatomic reasons, may be good candidates for TMVR. And these are the kinds of patients that are currently being enrolled for TMVR. In addition, patients who are not good candidates or poor candidates for surgery due to frailty or comorbidities are also potential candidates for TMVR. The surgical planning is important. These are currently being performed by transapical access, and also several devices have been introduced which have transseptal access. Here is an example of a patient that we treated recently. Patient had very severe mitral regurgitation, secondary to A3 and P3 prolapse. This was all the way in the medial commissure. When we did not have TMVR, we potentially would have considered clipping this procedure, but there is risk of suboptimal result or complication, because of getting stuck in the medial commissure where there are a lot of chordae. Now that we have TMVR, we think that these patients may be more suitable for TMVR. They're not prohibitive for MitraClip, but perhaps suboptimal for MitraClip. And this patient was, evaluated and underwent a CT, and the anatomy was found to be suitable for TMVR. And this patient underwent transapical access and TMVR with the Intrepid valve. And here's the final fluoroscopic appearance of the Intrepid valve, which is seated very, very nicely in the mitral annulus. And we should have some TEE images. Here are the TEE images from the procedure. Excellent result, excellent placement and positioning of the valve. Here's a 3D en-face view with excellent result with no regurgitation post-deployment. And here's the color Doppler demonstrating excellent result, and trace central regurgitation with a gradient of 3 millimeters of mercury and improvement in the pulmonary vein flow. So the next stage is the transfemoral transeptal, which we are starting, and we are going to enroll patients in this. And this is obviously more exciting to be able to do the TMVR without apical access. The Alta valve is another valve, which is a supraannular valve. The main advantage of this valve appears to be reduction in risk of LVOT obstruction, which is the Achilles heel, so to speak, for TMVR. There is a whole spectrum of interventions. We've used the Sapien valve, the catheter-based valve that we use for TAVR for indications such as valve and ring for degenerated prosthetic rings, degenerated prosthetic valves for patients with MACC. These are a whole spectrum of mitral interventions that can be performed via transeptal transfemoral access. Here is a case of TAVR and TMVR that was performed simultaneously. This was a case of valve and MACC. Again, excellent TEE guidance during these procedures is critical for success and safe execution of these procedures. Lastly, the category of interventions that we do for mitral regurgitation is paravalvular leak closure. This is a very special and sophisticated procedure which involves multimodality imaging with the help of CT, echo, sometimes fusion. And this is an example where this was performed successfully with a closure device, as you can see on the bottom right, with complete abolishment of the mitral regurgitation from the paravalvular position. So in conclusion, transcatheter mitral interventions are a therapeutic breakthrough, providing treatment options for high surgical risk patients. MitraClip or TEER is a good option for high surgical risk patients with DMR, and for optimally medically managed patients with FMR continue to be symptomatic and have 3+ or more MR. Multimodality imaging is key for patient selection. Echo, CT, and possibly MRI for pre-procedural assessment is critical. TEE and fluoroscopy are key for intra-procedural guidance, and TMVR is currently being studied actively and has a huge potential role going forward in the management of these patients. Thank you very much.
Thank you very much, Sachin. It's now my pleasure to ask Dr. Rebecca Hahn, who is a professor of medicine in the Department of Cardiology at Columbia University and a very prominent figure in interventional cardiology, to present her paper on tricuspid valve regurgitation and catheter-based interventions, the new frontier. Rebecca.
Great. Thank you so much. I really want to thank conference organizers and Bill for inviting me to speak today at the conference. And I will, in hopefully 15 to 20 minutes, cover all the same topics as was covered for the mitral valve over the last hour. So I'm going to speak kind of fast. So the state-of-the-art article was just published. This comes out of the PCR tricuspid valve working group, and I was privileged to be a part of that. And so we'll discuss a lot of the data that was covered in that review, but I do highly recommend it. When you're looking at either the European or the US guidelines, you can see that in order to go through the algorithm for treatment, you need to determine the TR etiology, the severity, and then look at the right heart. So it's both right ventricular size and function, also right atrial, and then determine the severity of pulmonary hypertension. And what we used to know was that you could divide the etiologies of TR into primary and secondary, with secondary by far being the majority of patients that we end up seeing, and valvulopathy of the left side being the main etiology. But we now know that the CIED-related patients are a larger patient population than we previously thought. And these are patients that are coming to us for transcatheter device therapy, and roughly about 30% of the patients, 25-30% of the patients coming into our clinic have a CID, what is thought to be CID related or caused by impingement of the leaflet or the subvalvular apparatus or even leaflet perforation. So primary, although CID used to be put into the category of primary disease, which is the primary leaflet abnormalities such as prolapse or in this case a flail, we do believe that CID may be somewhat separate. Now, when you are talking about functional disease, we used to lump that all together, but we now know from this beautiful three-dimensional echo study by Denisa Muraru that all functional disease is indeed associated with tricuspid annular dilatation and much larger right atrial volumes than in patients that have no tricuspid disease. And that when you're talking about ventricular functional disease, those patients have more primary RV dysfunction, RV dilatation, and therefore pulling away of the papillary muscles toward the apex, causing tethering of the leaflets. And so you see in these green volumes that the leaflets are quite tethered, the tethering volume is high. And in atrial functional disease, also considered functional, and typically in the setting of atrial fibrillation, we now have even more massive dilatation of the right atrium and the tricuspid annulus, but relatively normal RV volumes and shape, and therefore the tricuspid leaflets close at the annular plane. Remembering that in this study, right atrial volumes and tricuspid annular areas are what actually predicted severity of disease. And so the PCR working group has proposed a novel classification of tricuspid regurgitation by the valve and right heart morphology, dividing it into not only primary disease and secondary disease, but also separating out CIED-related disease, and within functional, separating out atrial versus ventricular functional with the different morphologies as you see here. Now, the reason that becomes important is that we know that the etiologies actually determine outcomes, so that the isolated, which is now known as atrial functional disease, tends to have better outcomes than primary, and certainly better outcomes than those patients with ventricular functional tricuspid regurgitation, which have the worst outcomes. When we determine the severity, which is kind of step 2 of our algorithm, then we, as Bill has talked about for mitral valve disease, we have qualitative, semi-quantitative, and quantitative measures. But I want to go through some of our standard measures and tell you the limitations in particularly deciding the severity of tricuspid regurgitation. And the first is the limitations of color flow jet area. So we know that because the color Doppler flow area is dependent on momentum, that in a low pressure site such as the right heart, that color Doppler jet area may be much smaller for the same amount of regurgitation. So using the same criteria or even the visual gestalt of severity is going to be really underestimating the disease severity. This patient has no coaptation at all, and yet the color Doppler jet area barely fills a quarter of the size of the right atrial volume. And therefore, in the European guidelines, color Doppler flow area of the regurgitant jet is not recommended to quantify the severity of TR. It should only be used to diagnose the presence of TR, and then a more quantitative approach should be performed. Now, what about color Doppler contour and shape of the jet? Well, we know that in a recent study that the density and triangular shape of the jet has been suggested as an accurate way of measuring severity, but we know that density can be very dependent on the alignment of the continuous wave Doppler sample volume, and that there's much overlap between moderate and severe. And in addition, the pitfalls of contour are many. These patients that you see here on your right-hand side all have torrential disease, and yet they have a parabolic shape up until the time that you have really horrific amounts of regurgitation. And so we've learned that from this beautiful study from Philip Lurtz, where he looked at invasive and echocardiographic measures of pulmonary artery systolic pressure. And in those, 23%, so about roughly a quarter, will have discordance between invasive and echocardiographic estimates of pulmonary artery systolic pressure. And it is indeed these patients with the triangular shape of the jet that have the most most severe valvular disease as well as ventricular disease. And it is the discordance between echo and invasive measures that actually determines outcomes. So again, be careful about making judgments about the contour and the density of the jet. What about reversal of flow? This is felt to be a very specific sign for severe tricuspid regurgitation. However, I'm going to show you later a case where reversal depends on the compliance of the right atrium. And therefore, sometimes we will see indeed late systolic reversal, which does not indicate severe disease. Now, the vena contracta is also problematic for the tricuspid valve because we know that in the setting of either a trileaflet or even more complex valve, that the vena contracta is not a circle. And therefore, you can see here that it is actually a triangle, and that when we measure the vena contracta from a septolateral view, which is the apical forechamber, we're going to underestimate the dimension in the AP view. And therefore, there are many who have suggested that vena contracta widths averaged from orthogonal views with a cutoff of 9 millimeters are associated with outcomes and should be considered severe. Now, PISA is our standard measure of quantitative severity. And when you can see the PISA well, then obviously we would all recommend that you use PISA to quantify tricuspid regurgitation. But I think the thing one needs to understand is that, again, because of the shape of the jet, PISA has many, many pitfalls. And so it's clearly not validated for multiple jets to add together the radii. It underestimates in the setting of a hemispheric, or you saw that triangular shaped orifice. It's inaccurate without an angle correction for the functional disease, which has tethered leaflets. It underestimates the severity of disease without a flow correction. Remember, we're dealing with low velocity flow on the right heart. And indeed, it is temporally variable, just like the mitral valve. And so this is just a graph of the different radii that we can get throughout the systolic time interval in a very time variable functional jet. In addition, we know that we can not measure regurgitant fraction without using other modalities. But since 2017, there's a lot of data regarding the quantitation and outcomes based on quantitation. These are just 4 of those studies that look at the severity of disease based on PISA quantification and the outcomes, which are clearly somewhat linearly related to severity. And therefore, we want to quantify all patients by PISA. But remember that in many of the studies, the outcomes begin to be adverse starting in the moderate range of 30 to 35 millimeters squared uncorrected. Now, three-dimensional vena contracta has become one of our standard measures in our lab, and there's a lot more data, although the European guidelines suggest that it is reserved for research purposes. I'd like to somewhat disagree. We obviously can do it on transthoracic. This is a transthoracic view as well as TEE. And the advantages are that it's a direct measure of the vena contracta with no geometric assumptions. It can also be used following device placement. Importantly, because again, we have time varying and multiple jets, we like to use an integrated both PISA and 3D vena contracta area, which has also been validated against quantitative measures. And so multiple studies now showing the utility of three-dimensional vena contracta area and comparing it to PISA, showing again that the evidence for clinical utility is clearly growing and that PISA underestimates 3D vena contracta area by about 40%, depending on the regurgitant orifice shape. And so the PCR working group, again, in that review article has advocated not only for looking at the systolic flow reversal with the pitfall that I just mentioned, but also averaging the vena contracta widths, performing your PISA measurement, and doing your quantification with 3D vena contracta area. Now, there is one other method, which is the volumetric Doppler method, similar to what Dr. Zoghbi reviewed for the mitral valve. And we've actually developed an algorithm for performing quantitative Doppler using either the orthogonal views in order to better calculate the elliptical orifice area of the annulus, or using direct planimetry by three-dimensional imaging. And that is actually our preferred method. And therefore, the advantages of quantitative Doppler are similar to mitral valve. We can perform it with multiple and temporally varying jets. And the disadvantage is obviously the assumption, particularly in the torrential diseases, of a constant flow across the annulus with a number of measurements that are required with geometric assumptions unless you do the 3D tricuspid annular direct planimetry. And so in our core lab, we've been able to show that PISA EROA that would correlate with an integrative severe disease is a cutoff of 34 millimeters squared, whereas the cutoff for a Doppler EROA is 65 and for 3D VCA is 60. So again, roughly a 40% underestimation of the other two methods by PISA. We also know that the patients coming to us with right heart failure have much more than severe disease. And so we've, Pepe Zamorano and myself suggested that we increase the severe grading scheme to massive and torrential, so adding 2 additional grades. And this is somewhat supported by multiple studies that have since shown that there is indeed a plateau of outcomes associated with vena contracta, but no plateau at all for PISA. And therefore, there is a continuous hazard associated with even greater and greater amounts of tricuspid regurgitation. This has indeed, the grading scheme has made it into the ESC, EACTS guidelines, and just presented at EuroEcho are the new EACVI regurgitation guidelines in press, where again, they suggest that further categorization into severe, massive, and torrential is particularly relevant for those patients who are being considered for intervention. Don't forget, this is indeed a multimodality endeavor, just as has been already shown for mitral regurgitation by Dipan. This is going to involve CT AROAs, 4D flows, CMR volumes. Already we have documentation that the AROA correlates well with 3D vena contracta area, and by CMR, we do have cutoffs that suggest adverse prognosis. And so this will indeed be a multimodality endeavor, as I've mentioned, but remember that the lessons learned from MR should also apply, which is that prognosis does not equal severity. We know that prognosis begins to, adverse prognosis climbs starting at moderate disease, but our cutoffs for severity should remain. Remember, we also want to look at structural abnormalities. And so when you do look at structural abnormalities, becomes clear also when you have severe disease. This is marked RA dilatation, marked tethering of the tricuspid valve leaflets with very large coaptation gaps, and marked dilatation of the RV with reduced RV function. Denise Moraro has taken RV volumes one step further in order to quantify regurgitant fraction using PISA. Otherwise, you're not able to do that. And so in that setting has shown that both averaging the vena contracta widths as well as calculating the regurgitant orifice by PISA and the regurgitant volume by PISA, adding the 3D total stroke volume of the RV to get regurgitant fraction, all has outcomes associated with it. Now, the two guidelines are indeed a little bit different, particularly for this last parameter here, which is transcatheter treatment of severe TR. In Europe, they now have 3 different devices that have been approved, and therefore there is a 2B recommendation for transcatheter devices for tricuspid valve. But for both guidelines, looking at the tricuspid annular dimension, and I venture to say that will be changed to area soon, as well as progressive RV dilatation and dysfunction remains an important part of the assessment of tricuspid regurgitation. And I won't go through the assessment since this was actually covered on the first day of this conference, but I do want to show you the outcomes that have already been shown to be associated with RV strain, and which has been an additional benefit to looking at strain over FACC, or fractional area change, and TAPSE, and then RVEF by CMR. So TAPSE alone, not predictive, but RV ejection fraction by CMR is indeed predictive of adverse outcomes. The newest study is the 3D RVEF by Echo. And so this study again shows that the cutoff of 45%, absolutely important for determining outcomes in the patients with tricuspid regurgitation, and that a decrease in the 3D RVEF after transcatheter interventions was not associated with outcomes. Now, determining the severity of pulmonary hypertension, equally important, because we now know that those patients with precapillary pulmonary hypertension have the worst outcomes, and therefore that will indeed determine trial design and exclusion criteria. But the new kid on the block is RVPA coupling. And so we now know that when we look at RV function as it's responding to increasing afterload, and that's what RVPA coupling does, this index of TAPSE over PASP, then it indeed can predict outcomes in natural history studies. And so this is the study coming out of Fortuny, showing that a cutoff of 0.31 of TAPSE over PASP actually determined outcomes in those patients. But we've also looked at the TriValve registry to look at RVPA coupling in the transcatheter patients, and have shown, and this is in press in JACC, so hopefully you'll see it soon, that again, RVPA coupling does indeed predict mortality at baseline, and that the change in RVPA coupling with a reduction versus no change in RVPA coupling is actually beneficial. So those patients start off with some RV reserve. And so when their RVPA coupling goes down, they show that they've had the reserve and therefore have better outcomes. And the main thing that we don't understand is how to predict recovery. And so I apologize for going over. I'm just going to show you a couple of the transcatheter devices and their therapy. And the Cardioband is the annular device, which has shown excellent safety and efficacy, and in addition, functional and quality of life improvements, and was approved in Europe in 2018 with durable results just reported this past February. There are new devices that are in development, the Da Vinci system, and we hope to see those soon. But the annulus obviously is a very difficult structure, and imaging is going to play a huge role, where we think that three-dimensional ICE is going to actually help us with all procedures on the right side. The leaflet devices of TriClip, also approved in 2020, and Pascal similarly showed excellent safety and efficacy, also approved 1 month later. And so Europe then has those devices available to them. The leaflet devices are tough. The morphology will play a role. So if you have a 4-leaflet valve, you probably won't get as good a result. If you have a large gap, you won't get as good a result. If you have a pacemaker wire that's impinging on placement of the device, you will not get a good result. And so there are multiple different pitfalls. We do believe that there are other devices as well coming into trials, such as the Mistral device. And so leaflet coaptation devices are still being developed, as are spacers, since the Forma device is no longer being used. But the greatest amount of advances are going to occur in the transcatheter tricuspid valve replacement sphere. And so the Evoke valve is a transcatheter tricuspid valve replacement device, which has already shown excellent safety and efficacy, as well as functional improvement, and is now in pivotal trials. The new replacement devices are being rapidly developed. There are multiple new devices out there. But as always, annular size becomes an issue. RV function and what happens to the RV with an increase in afterload is unknown. Conduction disturbances are not trivial. And then leaflet thrombosis becomes an issue, with anticoagulation probably recommended after the device placement. We also have heterotopic valve implantations that are also in trials. And so when we think about the new therapies, some will no longer go forward. 3 are in pivotal trials, multiple new valves in early feasibility. And what we really want to know is who to treat anatomically. And this is just one of the tables from the new review, and how to choose, so a proposed algorithm also from that review. And can we improve outcomes? We believe we can. This is from the Tri-Valve Registry with a propensity matched medical treatment arm. And so the future goals are to obviously increase awareness of tricuspid regurg, improve the quantification tools, determine the most appropriate management strategies, and the appropriate timing and type of intervention. Thanks for your attention.
Thank you very much for that. Really excellent, particularly the information on risk factor cutoffs for the right ventricle. That's really very important, newer information. Is Dr. Zoghbi with us?
Can you hear me there?
Yeah.
Okay. This was fascinating, Becky, for all the new things that really have happened within like 3 years in the tricuspid valve space. And So if you don't mind, before we go through the cases, there are a few questions that the audience have sent, and I'm going to read them to you, so at least the panel, I want to welcome the panel of speakers with us today. I think it would be great to answer that. One is, where is Dr. Shah with us? I don't know. Yes, I see him. It's for all of us, actually. What is the gold standard for assessment of valve regurgitation? Which one is 100% accurate?
I think there is nothing that's 100% accurate. I mean, the reality is I think all modalities have pitfalls. And the key, I think, is as a practitioner is you need to be able to recognize when you're encountering pitfalls and when you need to stop and say, I can't answer this question.
Yes, but I think, I mean, I really want to mention that among the most reproducible is obviously CMR for quantitation of regurgitant volume and regurgitant fraction. And not a CMR expert, but certainly have worked with you quite often, Dipan, that there are still some issues that we have to address with CMR, particularly if patients have atrial fibrillation or a lot of ectopy that is not filtered in a way, and if there is a lot of variability, I think that's important. Two is if the ventricle size is very large, choice of the last cut in short axis would be very important because that changes the variability. So there is some variability among investigators and people who quantitate with CMR. So, but overall, more reproducible than echocardiography for quantitation of regurgitant volume and regurgitant fraction. Do you guys agree with that?
Well, I guess I'm going to take maybe a slight exception to that, but yes, probably perhaps more reproducible, but in an expert hands in echo, and I think that's the important message for me, is that both sides, the echo and the CMR, need to work together and need to correlate with each other. And so we take every opportunity we can to compare ourselves to CMR and for CMR to do the same. And it's really important to, in the valve team, to have that expert structural imager to make that correlation, because it becomes important for follow-up. We're not going to get CMRs every 6 months on these patients, and some of them have devices in, et cetera. And so we are going to have methods by echocardiography that we can rely upon, and therefore attempting to have reproducibility within your center using the methodology that you have perfected, I think is an important aspect, particularly of a comprehensive valve center.
Fully agree with you, and I think knowing the advantages and limitations for each one of the parameters that you mentioned, and then I mentioned in the mitral regurgitation talk, is don't stretch it beyond of what you could do. If you have a very eccentric jet, and I think you see that, and if you have a non-holosystolic MR, you're going to overestimate the severity, and I think I would caution that regarding what has been published in the literature. So I think know what your limitations are and know when to ask for help. I think that's going to be very important, or use other methodologies. All right, another question here is the indication for MVR includes an LV systolic dimension that's for mitral valve greater than 40 millimeters. Are we adjusting for small or large patients?
Is Bob on? Probably not.
Bob is not on, but I think you can handle that, Becky.
Yeah, you know, I think that's one of the pitfalls right now. I mean, we do have indexed dimensions for some things, but it's not been mentioned yet in the guidelines. And an article we just wrote on sex differences in valvular heart disease that actually brings up one of these points as well, because the chamber guidelines clearly show that the cutoffs for normal are very, very different for males and females, for end systolic diameters and end diastolic diameters and volumes as well. And so I think it is one of the pitfalls that we have of some of our current guidelines where we are not indexing for body size. And similarly, as new data comes up with indexed dimensions, such as for aortic regurgitation, we need to embrace those new cutoffs for outcomes and prognosis.
And one thing I'll also kind of echo on that, I think, is also, I think maybe, you know, as our imaging modalities get better, maybe we're going to move beyond linear dimensions, because I think there's probably more variability in linear dimensions and look more at volumes, because oftentimes these ventricles are more globular shaped. So just depending upon where you do your linear dimensions in the same patient, you can get different values.
Yes, that's very true.
Very important.
Yes, I think it's important to recognize that guidelines aren't a series of individual triggers. As Robert said, you've got to look at the whole picture. And 40 millimeters is really the upper limit in a 6'4" tall man or a 5 foot tall man. It's just more urgent in the 5 foot one. But it really, we're really more comfortable these days operating around 3.5 to us is starting to be a concern, because there's increasing evidence that histological changes start occurring quite early in mitral regurgitation in the left ventricle. And this is what affects these tremendous depressions of 10 to 20% survival at 10 years. Just the onset of mild heart failure means you've got a 20% less risk, even though you have a perfectly functional mitral valve going forward. Your death rate's already fixed by the time you get to surgery.
Becky, a quick question for you regarding estimation of PA pressure when you have severe TR. The person is questioning, you know, some of the accuracy because Bernoulli equation doesn't work as well, and you have equalization. How do you kind of do that? And some of the pitfalls conceivably. A quick answer.
Yeah. Yeah, so, you know, we look at the contour of the jet to see whether or not we can trust perhaps our PASP. And when it's more parabolic, we're pretty sure that it's going to correlate pretty well. When it's more triangular, then we start to worry about TAPSE over PASP. And that's where invasive measurements, because most of our patients are getting right heart caths as well, could indeed be used and has been validated also out of the Philip Lurtz's lab. And so, again, I think you're absolutely right. You have to know the limitations of your methodology, obviously, and we've learned a lot about when we're going to be discordant.
Gerald, maybe a question for you. How do you apply management guidelines in patients with mixed disease? So it's not secondary, it's obviously there's some issues there. I guess you have to work as a team with your imagers as well as the surgeons and see if it can be repaired or the interventionalist. Well, how do you do that?
Yes, the mixed lesions, particularly when there's a mixture of stenosis and like aortic stenosis and mitral regurgitation or tricuspid regurgitation, are really extremely difficult to sort out. These are the ones where, as Rebecca had said, you've got to get everyone together in the same room, the imagers and the clinicians. And obviously, if you have someone with critical aortic stenosis, then you know you're going to be doing something, and then you've got to decide if it's surgical, what you're going to do intraoperatively. But if it's interventional, sometimes the interventionist can fix the worst lesion and wait and see and come back. But these are a very, very challenging group. And I would just say that the old rule is that generally 2 miles doesn't just mean the patient's got mild valve disease. 2 miles can equal a severe problem for the patient, especially if they have some left ventricular function. These are people that really benefit most from being referred to a heart center for a heart conference about the patient.
I see also we have Dr. Hinahora here with us. Tim, I just want to introduce him. He's one of our interventional structural advanced fellows, so I think it's great to have you, and I know most likely you're going to be involved in a case presentation. But a question for you, as well as Dr. Sachin Goel, is about TMVR. If you do it from the apical approach, what happens to the LV apex with such a large introduction into the apex, functionally maybe as well as echocardiography or imaging-wise? Do we see any major changes, or is this a silent area of the heart?
Yeah, that's a good question. I mean, we've learned from the TAVR experience, several years ago that, going through the apex, of course, is not benign. These patients in the TAVR world, the reason to go transapical is because they have, increased burden of comorbidities and peripheral vascular disease. And as a result, they have associated higher risk of mortality. In the TMVR field, it also depends on the underlying pathology. If the left ventricular apex is viable or not viable, for instance, in functional MR, the patient may have a non-viable apex to begin with, as opposed to a patient with degenerative MR, where typically these patients have close to normal or normal ejection fractions, and they may have a much more sort of an insult to the apical axis. These apical axis catheters are large at this time, but more excitingly, we are also exploring and moving into the transseptal transfemoral space for TMVR, which I think is very exciting, and that's where the field is moving towards. To get away from transapical axis and doing these cases via transseptal transfemoral approach.
You guys have prepared, but let's do that. I'll send it back to you, Gerald and Becky.
Great. I think we're on to cases. So I thought I saw Tim maybe flash one of his cases up. If you want to go ahead and present that would be great. And maybe depending on the time, because we're already at 11, we may not get to other cases, but go ahead, Tim, and don't forget you're on mute.
Okay, I'll get started now. Thank you all for having me. And can you all see my screen?
Yes.
Okay. So I'll be presenting an interesting complex mitral valve disease case. Our case is a 92-year-old female with hypertension, AFib, a remote history of breast cancer, who presented to the ER with several weeks of progressive dyspnea and lower extremity edema. She has no known coronary or valvular heart disease. Despite her age, she's actually quite active and even played tennis until a year ago. And she was admitted to our hospital for decompensated heart failure. She had an echo which showed severe MR and subsequently had a TEE. Here we see Barlow's disease with severe MR due to a flail anterior leaflet. You can also see ruptured cords and bileaflet prolapse. The mean gradient across that valve was 3. This 3D image shows an impressive A2 flail with the ruptured cords coming towards us. And then there's bileaflet prolapse involving multiple scallops. On the right, we can see that the MR jet is very big. It's central and posteriorly directed. A cardiac MRI was also done. And I'm showing 2 representative images here, which beautifully show the bileaflet prolapse. The regurgitant volume was 60 mils and the regurgitant fraction was 67%. Her STS score was calculated, and for both MV repair and MV replacement, it was very high at about 10%. So in summary, we have a 92-year-old active female admitted with heart failure due to severe MR with A2 flail, multiple prolapsing scallops, and Barlow's disease. She was aggressively diuresed with clinical improvement, but still remained quite dyspneic with minimal activity. So what is the best treatment option for her MR? Surgery, transcatheter edge-to-edge repair, TMVR, or because of her age and comorbidities, should we just plan to treat her medically? So I would like to open it up now to the panelists and for a little discussion on this topic and how you would approach this patient.
Do you mind if I start with asking Dr. Lowry to comment? If this patient wasn't 92 years old, and didn't have a risk score as you saw, but was a younger patient, is that a repairable valve? Because for me, that's the first thing that we would try to decide in a younger patient that didn't have these comorbidities, and it might be an interesting conversation with our surgeon.
Yes, this is one of the points we're really trying to make. The Carpentier technique simply is not designed to handle these kind of situations where you've got whole leaflets flail. There's no limit to the number of chordae we can put in and get a line and to get an annuloplasty ring on. We've also demonstrated the extreme importance of getting the annulus properly sized and preserving annular function in people with Barlow's. In fact, when there's no flail, the most severe Barlow's can often be repaired with just a simple annuloplasty ring if it's flexible and the correct size. So with the modern techniques, as I said in my presentation, the extent of flail or prolapse and the size of the leaflets is never a contraindication to repair. So the only limitation on this lady would be her comorbidities, not the anatomy. Her anatomy is completely suitable for repair, and we don't believe that large leaflets have anything to do with SAM whatsoever, as we've demonstrated over and over. And so if she was 92 and she had no comorbidities, we'd be happy to operate on her and get a successful repair. And we've had a large experience with Barlow's, we've reported, and they do equally well in the long term as the other patients.
Excellent. Thank you so much. Maybe to Dipan, can I, if you go to the MRI slide, just to ask you, from these images, can you help us
so
determine?
I think this.
Not only the severity, but
the.
CT. I'm sorry, a CT.
This
says cardiac MRI, but.
Yeah, so I think this is actually a cardiac CT, but I think the few things on the MRI that you would look at. One obviously is to quantify the severity of the regurgitation, which in this case, I mean, it's not as much of an issue, but oftentimes in some of these Barlow's cases where they have kind of this non-holosystolic MR jet, where the jet, starts out almost nothing and then it progressively builds up. The MRI gives you kind of an integrated assessment of what the total volume of regurgitation is throughout the cardiac cycle. The other thing I think in some of these cases that I think is still kind of emerging data, but in these Barlow's patients, is the MRI is able to assess the ventricle itself. And oftentimes you're finding that there's fibrosis in these patients. And again, is that actionable intelligence at this point? I'm not quite sure yet, but I think we're gaining more and more information that those patients with mitral valve prolapse who have fibrosis may be an increased arrhythmic risk down the road. So I think that's kind of an additional piece of data that it provides you with. And then from a mechanism standpoint, if you did a kind of a series of short, long axis views, you could actually try to look at which leaflets or which scallops are being affected, just like you would do on TE as well.
Excellent. The one other thing from a CT, so we'll just call it a CT, that we might want to know is access route for a transcatheter device. So this was an acute flail. Obviously, she was asymptomatic until recently. So right side looks pretty, unfortunately, great, normal, but it also means that the height of the interatrial septum doesn't look so good. So what are the various things that you would, go through? What's your algorithm for trying to help us decide what would be the most appropriate transcatheter device?
So I think this is an important question. If this patient is not a great surgical candidate for various reasons, the next step is to evaluate for edge-to-edge repair or TMVR. In terms of edge-to-edge repair, of course, we look at the transesophageal echo very closely to assess the origin of the regurgitation. In this case, it appears mostly to be in the central region, in the A2P2 scallop region. This is a A2 flail, but these Barlow's cases can be pretty complex, as you know, with multiple prolapsing scallops, and the main concern is, are we going to be able to deploy a clip in the A2P2 scallop region or clips in that region and get a successful result, which is reduction in MR from severe to mild or less. And the second question is, are there going to be other areas of regurgitant that potentially are going to open up and create regurgitation, in a non-central location? In addition to that, of course, in a case with acute flail, the concern is that the left atrium is not going to be large. And as you said, Becky, what the distance from the septum to the mitral coaptation is going to be. We typically favor, a distance of about 4, typically about 4 to 4.5 is ideal in order to be able to maneuver and advance and grasp the leaflet successally. So that certainly was a concern. And then in terms of transcatheter mitral valve replacement, of course, the apical axis is important, and the two Achilles heels, so to speak, of TMVR. One is the sizing, the annular sizing, and of course, the important one is LVOT obstruction. So these are the things that sort of went through our mind, typical algorithm that we have. If patients are suitable candidates for edge-to-edge repair, then of course, we treat them with edge-to-edge repair. But if they are suboptimal candidates for edge-to-edge repair due to anatomic reasons or small valve area or risk of, inducing stenosis or risk of not adequately treating the MR, then we evaluate them for transcatheter mitral valve replacement. So that is sort of the discussion points here that we had with our team. And that's one of the reasons we obtained all this multimodality imaging after the transesophageal echo, to see what the anatomy is, whether TMVR is feasible, what the LVOT looks like, and what should be the next step. So yes, this patient, if the patient was younger, in the hands of a very capable surgeon such as Dr. Lowry, this would be a perfect valve for a repair. But this patient was 92 with an STS score of 9% or 10%. I think this, suffice to say that, this patient is not a great surgical candidate. And in fact, she did not want surgery. We had extensive discussions with her and her family. So this was a decision-making point, so to speak, as to, edge-to-edge repair versus TMVR. So Tim, I think you have some slides on how we went through this and how we made a decision.
Yeah. So as you mentioned, her anatomy is suboptimal for edge-to-edge repair. She's not a great surgical candidate. She's actually a poor surgical candidate. So we evaluated her for TMVR. This is the CT TMVR done to evaluate her for the Intrepid valve. On the left, you can see a virtual valve placed here. And you can see that the valve almost abuts the septum here. And the neo-LVOT is just 70, which is extremely small. So because of the small neo-LVOT, she was at high risk for LVOT obstruction, and therefore was not a candidate for TMVR.
So yeah, this was a very challenging situation. As you know, the LVOT here is prohibitively small. If there are no other candidates, then the options here would be to perform an alcohol septal ablation to try and shrink that septum and increase the LVOT with or without possibly a lampoon procedure to lacerate the anterior leaflet. We've done these cases in some other situations with success, and performed TMVR. But in this 92-year-old frail lady, this was felt to be a very, very high-risk situation with such a small, prohibitively small neo-LVOT. So we went back and reviewed the TEE, And, while the anatomy was felt to be, not optimal, we did not think that, this was a prohibitive case for edge-to-edge repair, especially since most of the regurgitation appeared to be in the central scallop region.
Excellent. Let me ask you a couple questions. So I don't know if you got to see the open sesame case at TCT, where they did a laceration down the middle of the LV outflow tract, of the septal bulge, in order to basically open up the septum. And I don't know what you think about that. That seemed crazy to us, but it actually looked great during the procedure. And the other question is the Intrepid the correct transcatheter device? If you used the Tendyne device, where you could actually position to tilt the valve a little away from the LV outflow tract, could you feasibly perform that instead of an Intrepid device?
Yeah, those are great points, Becky. I think the first technique, again, if there was no other option, then, we would consider doing those things, or, referring her to a center that would do those, or perform a septal ablation and a lampoon and do the TMVR. But, again, in a 92-year-old, we have always weighed the pros and cons of, the different techniques and their risks. The Tendyne valve, I think, is a good valve. We do not have access to the Tendyne valve as part of the trial, but we do have access to the Intrepid valve as part of the Apollo study, and we also have access to Alta valve and another valve. So we thought about all these various options, and I think that certainly could be a consideration. But again, at this time, all these are apical access as well. Yeah. And in a 92-year-old, we were also a bit leery about apical access, even though her ejection fraction seems to be preserved. So, after putting all these things together, we went back and looked at this transesophageal echo very carefully. And we had a conversation with the family that, look, your anatomy is not the most ideal for a edge-to-edge repair, but it is not prohibitive. We and others have performed mitral clip in cases of Barlow's mitral valve in the past with varying degrees of success. And, again, in a 92-year-old, we're not looking for a perfect result here. If we can get the mitral regurgitation down from 4+ to 2+, that would probably get her out of heart failure and, hopefully give her a good quality of life to the point that she can stay out of the hospital.
I think that's a great point, Sachin. I think setting expectations for the patient, with the patient for the procedure, and having that discussion with the family is it is such a key part to helping decide what to do. Hopefully we'll get to see the results before too long, since we've run almost out of time now.
Yeah, let's go ahead and look at Tim, go ahead and present the next slides, please.
If I could just make one very quick comment on the septal anatomy. Particularly on the elderly, we see completely normal thickness septums, which are sigmoid. Mm-hmm. And at first glance, it looks like there's a bulge in the LVOT, but it's really an 8 or 10 millimeter septum that's elongated and is bulging. On the other hand, we do occasionally see completely previously undiagnosed thickening of the basal septum. So if you're going to make a cut into that area, just be 100% sure that you have really looked carefully at what is there, whether it's true thickening or whether it's just a thin septum that's got a little curve in it, which is very easy to go through.
That's a very good point, Doug.
Good point.
Tim, go ahead and show us.
All right, so here are the intraprocedural TE. After transeptal access, we advanced the guide and the clip delivery system under 3D, and you can see on the right side that we positioned it at right above A2P2 with the aim to grasp the flail segment. The grasp is done in this LVOT long axis view. On the left, we see we see both clip arms and both leaflets bouncing on top of the clip arms.
Sorry, Tim, this looks like an XT. Did you use XTW?
Yeah, we use the XTW in this case. So we lowered the grippers. On the right, you can see that the leaflet is now grasped. And one XTW was placed at A2P2. On the left, you see a nice tissue bridge suggesting a good grasp. And then there is really trace MR afterwards. The mean grading across the mitral valve was 3. Evaluation of the pulmonary vein flow showed that prior to the procedure, there was S-wave reversal, which is now upright and also larger than D. And then these are the hemodynamics after the procedure. We had a really impressive reduction in the LAV wave from 66 to 19 millimeters. Typically, we like to see at least a 50% reduction, but in this case, we actually had closer to 75% reduction. She did very well after the procedure and was discharged a few days later. And we just saw her in clinic follow up, and she's doing very well, and all of her dyspnea has resolved.
Wow, playing tennis again, I'm assuming?
I'm not sure about that.
Actually, watching tennis. When she was in the hospital, there was the French Open tournament going on. Watched the entire tournament.
That is quite impressive. I would say that this is amazing, actually. Can you guys hear me? Yes.
Yes.
This is amazing and much better than even expected, Dr. Goel.
Yes, we were actually pleasantly surprised, with how successful this procedure was.
Yes.
And we've talked about Barlow's. We've done these cases, and coincidentally, just recently, there is a multi-center registry which looked at this particular pathology. Small number of patients, but important paper, which demonstrated the outcomes of edge-to-edge repair in patients with Barlow's. And as you can see, these are all Barlow's patients with good procedural success compared to non-Barlow's disease here.
Well, I think I'm mindful also of time of our second, session on valvular heart disease, particularly aortic and prosthetic valves. Cannot thank you enough, Becky and Gerald, for an amazing first session on Sunday. So informative, and our speakers just phenomenal to, give an up-to-date, state-of-the-art where we are in mitral and tricuspid valve disease. I'd like to remind our audience also that all these would be available to you if you registered, and if you're not, I think you should by now. And you'll have those available for you at your leisure for the next 2 months or so. So cannot thank you enough for spending your Sunday morning or afternoon or evening with us. And we'll take about 10-minute break and come back half of the hour to get us back into the aortic and prosthetic valves. Thanks again.
Okay, everybody, welcome back. My name is Stephen Little. We're back for session 6, which is valvular heart disease 2. This section will focus on aortic and prosthetic valves. Joining me as a co-moderator virtually in a moment will be Dr. Michael Reardon, the Allison Chair of Cardiovascular Surgery, also at Houston Methodist. So this session is organized in a similar way. We have several talks on the topic. Then we'll have some question and answer and some cases, I think, that will bring us all together for us. So without further ado, it's my pleasure to introduce Dr. Michael Reardon for the first talk. Dr. Reardon is going to talk to us about TAVR frontiers, the latest in choice and in patient management. Over to Dr. Reardon's talk, please.
I'd like to thank you this morning for allowing me the opportunity to talk to you about TAVR, the latest frontiers in optimizing the choice of prosthesis and patients to be treated. These are my TAVR conflicts of interest. I've been involved in most of the trials at a national level. I'm also a cardiac surgeon, and I still like operating. I think it's important for us to understand the clinical outcomes from the randomized trials, for the extreme risk trials for both partner 1B and for the core valve extreme risk. We see excellent results for TAVR. TAVR was approved for extreme risk. For the randomized high-risk trials, the primary endpoint of all-cause mortality over 5 years for partner 1A, there's no difference. For the high-risk core valve, TAVR was superior for years 1 and 2, but with 5 years, there's no difference. For intermediate risk for partner 2A and for SIR-TAVR, we moved to a primary endpoint of all-cause mortality or disabling stroke. We see there's no difference. It is a little worse when you look at the partner 2A trial that the curves cross halfway through, numerically moving in favor of surgery over TAVR, but these are not statistically significant. It's only a small crossing. But the lines in SIR-TAVR are absolutely parallel. We have 2 low-risk trials. The partner 3 trial had a 1-year endpoint. We'd have 2-year data. The numerically is still better for TAVR, although you see the curves narrowing already. We have 2-year complete data for the low-risk trial, and we see that the early advantage of TAVR is maintained parallel all the way through. We also have the NOTION trial, which is the Nordic trial of patients 70 or above, low and intermediate risk, and we see that over 8 years, there's no decrement in the primary endpoint of all-cause mortality, stroke, or myocardial infarction. One of the advantages of this trial is we still have 50% of the patients still alive at 8 years because it was a younger group, so this is some pretty good data. It's important to understand the 2 low-risk trials, particularly you start choosing younger, lower-risk patients. Partner 3 randomized TAVR against surgery. It's kind of a 7-year follow-up and has a CT sub-study, required transfemoral access. For the low-risk trial, TAVR versus surgery, we also stratified by the need for revascularization, also a 10-year trial with the CT sub-study. It's also important to know that in the partner 3 trial, the SAPIEN 3 valve was already out, so all the planners already had experience with this valve and used it all the way through the trial. Whereas in the low-risk trial, we're still 3.6% first-generation core valve, about 3/4 second-generation Evolut R, and less than 1/4 current-generation Evolut Pro. Even though transfemoral wasn't required, 99% were done transfemorally. Partner trial used a composite endpoint of all-cause mortality, all stroke, rehospitalization. We chose in the low risk to use what we thought a more rigorous endpoint of all-cause mortality, disabling stroke, but use a Bayesian analysis for an early look. So the primary endpoint was statistically superior for TAVR at 1 year in the partner 3 trial, and the Bayesian predicted endpoint at 2 years was statistically strongly non-inferior for TAVR in the low-risk trial. Now we can look at some 1-year all-cause mortality numbers. We look at 30 days, the mortality for TAVR was 0.4%, and for surgery 1%, 1.2%. We go to 1 year, still numerically lower for TAVR in both groups. Both numbers are lower in the partner trial because they chose a lower risk or a lower end of the low risk scale. Look at all strokes, statistically superior for TAVR in both trials. Now, embolic protection devices only became available halfway through the trial. We did not allow them, but a few were used, and most of this is done without embolic protection. If you look at rehospitalization, strongly superior for TAVR in both groups. So if I take the low risk and make a composite endpoint of all-cause mortality, disabling stroke, or hospitalization, similar to the partner trial, we have a statistically superior trial to 0.002 for TAVR. Now, what were the differences in the trial? There's really only 2. One is pacemakers. There were numerically more pacemakers for TAVR partner 3, but this was not statistically significant. And in the Evolut trial, there were numerically and statistically more pacemakers in the TAVR arm. Now, we did look at this as the number of implants your site did versus the pacemaker rate. Way out here is my lead implanter, Al-Mallah, with 1.9. Our pacemaker rate was 5.6%. This is largely because many of us started using what we call the double cusp overlap, which gives us a more accurate depth at the non-coronary right coronary junction where the conduction tissue is, and it keeps us from implanting too deep. And in fact, when we use this in a recent paper from Sky, we see that the overall pacemaker rate was 8.8%. In fact, going to the TVT registry in the last quarter recorded, the pacemaker rate for the Evolut Pro is 8.5%. Our pacemaker rate year in, year out for this valve runs between 5 and 8.5%. Another thing that was different was the hemodynamics. For the first time ever, surgery actually has superior hemodynamics in the PARTNER 3 trial with larger EOAs and lower gradients. And for the Evolut low risk trial, statistically superior at all time points, as it has been in all trials. This, of course, leads us to our current guidelines. Dr. Bono is one of the writers of these guidelines. And what these guidelines say, if you're 65 or less, you'll live 20 years or more, you probably ought to have surgery. If you're 80 or older, you live 10 years or less, and you're anatomically a good candidate for transfemoral TAVR, you should have TAVR. In between, we'll balance the risk, the physiologic risk of surgery and the anatomic risk of TAVR and the patient's wishes in deciding what is best. This, of course, has led to the explosion of TAVR that we see in this country right now. The black line is the rising number of TAVRs. The horizontal blue line is isolated aortic valves, which were passed in 2015. The red line is all aortic valve procedures, which were passed in 2019. In our institution, we do more TAVRs now than all aortic valve procedures combined. So how do we optimize the patient? Well, we need to remember that these randomized trials only apply to those that were tested. So who wasn't tested? Bicuspid valve, significant coronary disease, unfavorable anatomy, associated procedures, anybody appropriate for mechanical valve. For bicuspid valves, we use the Sievers classification based on the number of Raphe, 0, 1, or 2. The most common is Sievers 1 with left-right fusion. And even for our 80-year-olds and older, 20% of what we see will be bicuspid. But when we move down to the 65 to 75% range, half the patients we see are going to be bicuspid valves. Union McCarr have done a lot of work looking at the anatomy of valves and the distribution of calcium. And what they have shown us is if you don't have a calcified Raphe or heavily calcified leaflet, your mortality at 2 years is 5.9%. If you have a heavily calcified Raphe or a heavily calcified opposite leaflet, at 2 years it's 9.5%. If you have a heavily calcified Raphe and heavily calcified opposite leaflet, it's 25.7%. So not all bicuspid valves are created equal in the eyes of TAVR, even they really are from the standpoint of surgery. This is the low-risk bicuspid trial that we ran. This had a 30-day endpoint. You notice the hemodynamics are excellent, and there's nothing more than mild paravalvular leak. And we've also followed this out to 1 year, showing that the bicuspid and tricuspid valve have equal hemodynamics all the way to a year. And in fact, the bicuspid valves actually have less paravalvular leak than the tricuspid valves. Age less than 65, PARTNER 3 only had 7% less than 65. Evolut only had 6% less than 65. We really didn't treat young people. Anatomy, too big or too small, bicuspid valves, and excessive LVOT calcification, which is hard to define, but people did get screened out for this, clearly choosing for patients that were better for TAVR. In fact, these patients were all screened locally by expert heart teams and deemed anatomically appropriate for TAVR. And yet, at the national level, 34% of PARTNER 3 patients were screened out, and 14.8% of Evolut low risk were screened out. So these were heavily selected patients. Significant coronary disease, the protocol eliminated syntax over 32 in PARTNER and over 22 in Evolut. But in Evolut was stratified by the need for revascularization. That arm only had a mean syntax of 7. We really weren't treating significant coronary disease. We need to talk about durability as we decide how we optimize this for particular younger patients. So PARTNER 1B, 5-year durability, good. 1A, good. Core valve extreme, 5-year, good. High risk, good. Intermediate PARTNER, good. And TAVI at 5 years, good. And in fact, if we go to the NOTION trial at 8 years, TAVR and surgery still seem to be holding up exactly the same. So far, the indications are that these valves are doing just as well as surgical valves. Now, Becky Hahn did an interesting paper at JACC Cardiovascular Imaging where she looked at the core lab echoes of both the PARTNER trial and the CoreMove Evolut trial. What she found was for SAPIEN 3, the mean OA was 1.6. For Evolut, it was 2.01. She created these charts. If you look at the SAPIEN 3, I'd ask you to focus on the Doppler velocity index. It stays pretty much the same across valve sizes. It's about 0.42. And for the Evolut R, it's about 0.61. This, of course, is important is that the Doppler velocity index actually physically represents a ratio of that patient's aortic valve area to that patient's LVOT and that patient's flow status. So one of these valves on average gives you a aortic valve area that's 42% of your LVOT. The other one gives you a valve area that's 61% of your LVOT. They're different designs. And of course, we need to bear in mind the severity of patient prosthetic mismatch of between 0.65 and 0.85 centimeters squared per meter squared is moderate. Anything less than 0.65 is considered severe. Howie Herman has shown us from TVT that if you have severe patient prosthetic mismatch in TAVR, it's a marker for increased mortality even at a year. Fallon's done some really good work in the surgical valve in the STS database with almost 60,000 patients, 65 or older getting an isolated aortic valve, showed that any degree of patient prosthetic mismatch decreased long-term survival and increased readmission for both heart failure and reoperation for AVR. TAVR valves should behave the same since they see the same hemodynamics. And Fleming showed that if you had patient prosthetic mismatch, it was a marker for early structural valve deterioration. And in fact, showed that although there are a number of markers for early structural valve deterioration, only patient prosthetic mismatch was a marker both for early mortality and early structural valve deterioration. In fact, in the low risk trial, if you got assigned to surgery, your risk of patient prosthetic mismatch was 5 times higher than the TAVR arm. And if you compare the Evolut low risk versus the partner, you can see there's a marked difference in the amount of patient prosthetic mismatch. And one of the unique things about particularly the self-expanding valve is you go from a large to small annulus based on CT sizing. For surgery, that markedly increases the amount of patient prosthetic mismatch, but it does not for the TAVR valve. TAVR valves have an advantage over surgery for the self-expanding valve at all levels. This advantage grows as the annulus gets smaller, making this a great valve for small people, particularly like small women. This is Gorland's original work from working out the flow across obstructed orifices, looking at aortic flow in the vertical axis versus mean gradient on the horizontal axis. It fixed openings, the blue lines, and fixed cardiac work from normal flow to high flow. And what you can see is until you get to an EOA of about 2, you really can't increase your flow without increasing your gradient significantly. That may be why in Surtavi, when we did a 6-minute walk before treatment, 30 days, 1 year, 2 years, TAVR beat surgery at 30 days, no surprise, but was still statistically superior at 1 year and 2 year. And it may be because with this valve, the mean EOA was 2, whereas surgery, the mean EOA is 1.8. And we also looked at leaflet thickening and immobility and hypoattenuation. And if we look at thickening of 50% or more as being severe, if you look in the Evolut trial, you see there's more in surgery than there is in TAVR, and this increases in both arms by 1 year. And if you look at the partner 3, it's the exact opposite. There's more in TAVR than there is surgery, again, both increasing at 1 year. Now, the other thing that's really interesting that we need to bear in mind is there's a number of reports of early failures of surgical valves. And for those of us doing long enough, we know it's not just how long, but different valves have different survivals. Each valve will behave differently. When I start thinking about this, and I know I think about which surgical valve I'm going to use, when I'm thinking about tissue surgical valves, I look at the life table analysis, orange bars, and then I look at what the pericardial valves do, which are probably the best studied surgical valves. Going from age 80 to 50, the older you are, not only do you die earlier, but these valves last longer. So if you're 80, you're likely to live about 10 years. The risk of your surgical pericardial valve wearing out is about 4 or 5% in your lifetime, and our TAVR valves seem to be doing the same. TAVR makes a lot of sense, as the guidelines say. 75, 13 years, about 6 to 7%. Yeah, TAVR still makes a lot of sense. You've done 65, the lower end of the guidelines. Now you're going to live over 20 years. The risk is going to be about 18% for surgical valve, probably the same for TAVR. There's a pretty good chance you'll end up with a second valve. If you go to 60, now you're going to live almost 25 years and you're off the chart. Now you're probably going to get 2 valves. You could even get 3 valves. So as we move into these younger patients, we need to be thinking about coronary access, reducing number of pacemakers, eliminating PVL, and commissure alignment, because having the commissures lined up like we line up surgical valves allows us more freedom in the future as to maintaining coronary access with new valves. We need to decide in these patients that are younger, is TAVR appropriate for the first valve? How many valves are they likely to get in their lifetime? And how do we sequence these valves? These are the valves we currently really have available. The blue expanded valve was approved first by the FDA, followed by the Evolut core valve, followed by the Portico valve, and the Lotus valve. The Lotus valve has been taken off the market, and the one that's not surgical is the Accurate Neo2. We're currently running that trial, and we're about half or a little over halfway through here in the US. The other valve we're using right now is the Jenna valve. It has these little feet that sit down in the cusp and grasp the leaflets, designed specifically for pure aortic insufficiency. And I think this will be another great addition as we look for new frontiers in treatment of aortic disease. Now, there is a little bit of warning out there. If you do a TAVR first and then need to do surgery, the risk ratio for mortality seems to be 2 to 3 times that of just doing an aortic valve. We've done 19 of these here. This is more difficult than just doing an aortic valve, getting these things out. We only had to replace one root, but about a third end up with annular enlargements to get an adequate sized surgical valve in. But putting a TAVR valve in and then doing an AVR is not like doing a virgin just AVR. Doing surgery first, followed by TAVR, works pretty well as long as the surgical valve size implanted is adequate. It should be 23 or bigger, generally 23 or bigger for a female and 25 or bigger for a male. I'd like to thank you for this opportunity to speak with you about our TAVR program and where we see TAVR now and where we see it going in the future.
All right. Well, thank you, Dr. Reardon. That was a great talk. I think Dr. Reardon's joined us via Zoom. If we could see Dr. Reardon, he's going to introduce the next speaker. There he is. Good morning, Mike.
And welcome for everybody on the meeting today. Our next speaker is my good friend Bob Bono. Bob helped write our guidelines. Bob is the editor of JAMA Cardiology. He's going to talk to us about one of the things that we're faced with every day in our clinic, and that's paradoxical low-flow aortic stenosis and the role of CT. So, Bob?
All right, this is Bob Bono coming back to you from Chicago virtually. And in this session, we're going to be talking about a real complex issue that's made our lives really complicated in managing our patients with aortic stenosis. Bill has asked me to talk about paradoxic low flow, low gradient aortic stenosis and the role of CT and perhaps other imaging in evaluating these patients. I have no relationship to disclose other than, like you, this is a real dilemma for me and all of us. You know, it's straightforward and understandable as to why some patients have low flow, low gradient aortic stenosis when they have left ventricular systolic dysfunction. Yeah, this is where we recommend echocardiography. These are complex patients, but at least we understand, we believe, why there's a low flow state when you've got such afterload excess that you have left ventricular systolic dysfunction. But how about all of the patients we now see who have normal ejection fraction with low flow, low gradient, paradoxic, low flow aortic stenosis? These are problematic patients. Now, why does that occur? It may occur because some patients, especially older women, will have severe hypertrophy, impinging on the left ventricular end diastolic volume. So even though the ejection fraction is normal, they have a low stroke volume and therefore low flow. That's one cause. Another cause could be a patient who has hypertension. Because then we have an extra impedance to ejection. So in that case, we would treat the hypertension and restudy the patient once blood pressure has been more normalized. Finally, we shouldn't rely only on non-invasive tests. Let's also consider a direct cardiac catheterization to assess the hemodynamics and confirm our non-invasive findings. But even when we do that, we still find many patients who have this phenomenon, this physiology. In fact, there's an excellent study from Germany in which patients underwent both echocardiography and cardiac catheterization in 325 patients studied by Minners and co-workers in 2010. So here we see plotted the aortic valve area as a function of the mean pressure gradient using both the cardiac catheterization in orange and echocardiography in blue. So over here on the right, where we have patients who have a mean gradient greater than 40 millimeters of mercury and an aortic valve area less than 1. This is severe aortic stenosis. In the upper left, we have the patients who have the opposite. They have an elevated valve area and a low gradient. These patients do not have severe aortic stenosis. Our problem is in the lower left, where we find that 25% of the patients by cardiac catheterization and 34% by echocardiography sit down here. Where they have this low valve area, but a mean pressure gradient that's also low. So they do not have a high gradient, even though they have a significant reduction in valve area. So this is not a problem just with echo. We find this very similarly with cardiac catheterization as well. Now, Bill Zoghbi has a terrific editorial in Circulation around this time, pointing out that perhaps our cut point of valve area of 1 square centimeters is too high. Let's drop this down to 0.8, because that's where these curvilinear relationships actually cross that line of 40 millimeters of mercury. That makes sense. But if we do that, we find that we have fewer patients in the lower left, but we got more patients in the upper right. What do they have? They've got a pressure gradient greater than 40. That sounds like it's pretty severe aortic stenosis. So none of this is perfect. We got to bring in all of our particular tools to help demonstrate what these patients may have. Even if we index the valve area, we still have this very similar problem. If anything, even more patients fit into this lower left quadrant if we do a valve area index. And so what else do we need to do besides cardiac catheterization? It kind of gets into what I was asked to discuss, and that is, well, let's do some advanced imaging. Let's do CT scans, maybe MRI. And the CT scan would be important in determining whether or not there's associated valve calcification. Because if the aortic valve is not calcified, it's unlikely, highly unlikely, and probably impossible to have this be severe aortic stenosis in an adult. And so that's important. Now, what's most important is that you and I need to be good clinicians. We need to use clinical judgment as to whether this patient looks and feels as someone who could really have true aortic stenosis. We used to miss these patients. It was undiagnosed. We thought the patient couldn't have aortic stenosis because the gradient was so low. Now we run the risk of overdiagnosing this because it's out there. Every month we see another publication somewhere in our medical literature about this. And so we tend to overdiagnose this. Let's keep our thinking caps on, because some patients may have other diseases. For example, Castaño and co-workers working with a group at Columbia, a hotbed of TAVR, identified 151 patients undergoing or referred for TAVR, where they did pyrophosphate scans. And they found that a sizable number of these patients, 16%, actually had amyloidosis. It was mostly important in the men compared to the women. In the men in this series, 22% had amyloidosis. And what were the characteristics? It looks like severe aortic stenosis, but instead it's amyloid. They had greater wall thickness, greater LV mass, lower stroke volume index, greater diastolic dysfunction, lower ejection fractions, and more abnormal global longitudinal strain. And so got to be careful, because these patients may not have severe aortic stenosis at all. And we don't want to be intervening inappropriately. Now, the GLS could be important because it may give us a very characteristic finding of apical sparing. So let's not only consider pyrophosphate scans, but look at our longitudinal strain maps as well. Very similar data come from Scully and co-workers in a series of 200 patients with aortic stenosis referred for TAVR. They found that 16% of those patients have amyloidosis, somewhat older, somewhat worse wall thickness and increased mass compared to those without amyloidosis. Very similar hemodynamics. But most importantly, they found that, if anything, there was more paradoxic low flow, low gradient paradoxic findings in the amyloid patients. And 16% of the patients who have paradoxic low flow, low gradient physiology in this series have amyloidosis. So let's keep that in mind. One more finding comes from the work of Mark Dweck and his colleagues, in this case, a paper by Chin and co-workers, in which they subdivided patients who had aortic stenosis, not amyloidosis, into 3 groups by MRI. Those with normal myocardium, those with extracellular expansion in the middle, and those with such increase in interstitial connective tissue that they now had coalesced scar in terms of replacement fibrosis. These were 3 groups of patients who were being followed. The group with the greater extracellular expansion and replacement fibrosis did have a higher gradient. They had more severe aortic stenosis, but if we look at where the cut line is here at severity, the most of these patients in this series, even those who have frank replacement fibrosis, many of them have this paradoxic low gradient, despite having severe aortic stenosis. And so even in those patients who've got significant replacement fibrosis and extracellular expansion, we're seeing a lot of patients here who have paradoxic low flow states. These patients have left ventricular mass, which is higher. They therefore have greater diastolic dysfunction as well. It goes along with the increase in mass. But what's most interesting to me is that there's also a troponin leak seen in many of these patients. Those who have the more severe AS, the more severe fibrosis, also are leaking troponin. Maybe the troponin is a marker of why they develop fibrosis in the first place, because they got myocardial damage. This suggests that there may be important abnormalities in the microcirculatory system of these patients. And confirming that is a paper in a small number of patients reported by Shah and DeCarli and co-workers at the Brigham very recently, where they did PET studies to look at myocardial blood flow and blood flow reserve. And this is a plot of the stress myocardial blood flow in these patients with aortic stenosis. And here we find that indeed there is a higher troponin level in the patients who have the more severe reduction of stress myocardial blood flow. These patients also have an elevation of N-terminal pro-BNP. So putting this together, patients who have left ventricular hypertrophy with aortic stenosis develop left ventricular diastolic dysfunction associated with hypertrophy, but they also develop interstitial and replacement myocardial fibrosis, which contributes to the diastolic dysfunction. But importantly, there could be a microvascular effect here as well, perhaps capillary rarefaction, or extracellular compressive effects, or perivascular fibrosis leading to myocardial ischemia, which further potentiates both fibrosis and diastolic dysfunction. So finally, what do the guidelines tell us to do in our patients who have paradoxic low flow aortic stenosis? It's a class 1 recommendation in our current US guidelines to consider surgery for these patients. Well, only if AS is the most likely cause of symptoms. Well, great. You know, the guidelines tell us that, but they don't tell us how to do that. These are complex patients. How do we tease out who has true aortic stenosis or not? We need to keep our thinking caps on. Let's use clinical judgment again as a paramount tool to evaluate these patients. Consider the presence and severity of aortic valve calcification, but also consider non-valve conditions such as amyloidosis, which may be driving much of the physiology we see. Thank you very much for your attention. Again, it's been a delight to be with you, and hopefully next time we do this, we'll do this in person. Thank you.
Thank you, Dr. Bono. As expected, a terrific talk. The implications of strain imaging and some of the ancillary, multimodality imaging is really important as it pertains to aortic stenosis and its workup. We're going to keep moving with the next lecture. Dr. Neil Kleiman, who really needs no introduction, but I'll try. He's the director of our cath lab. He's the director of our interventional and structural fellowships. And Dr. Kleiman is going to talk to us about what is needed from the imager for TAVR decision making, in particular the image fusion concept. So over to Dr. Kleiman.
Good morning. My name is Neil Kleiman. I'm an interventional cardiologist, and I'm going to try to tell you what we need from the imager for TAVR planning. So here are my disclosures. I've got a number of research grants. I'm on steering committees for 2 clinical trials for these sponsors. And I would point out that we interventional cardiologists are imagers too. We use photons, we're concerned about radiation, and we like to make pictures. Sometimes they're good, sometimes they're not so good. So what do we need from the full-time imagers? Well, first and foremost, obviously we need images. And we'll talk about that. But second of all, I think it's very important that we need to share a collaborative approach. Imagers are an integral part of the team. We cannot run a TAVR program without direct and deep involvement of the imagers. Shown here is one of our meetings. You'll notice there are 3 surgeons. There are 2 imagers present, one of whom is also our boss. And you'll notice there is a portion of an interventional cardiologist shown here. You have to realize that imaging is a service. You're providing something that's needed for a sick patient to get better. Often we're told that patient's health status is marginal to undergo imaging. But again, we don't usually do these procedures on perfectly healthy patients. If there's a question, please ask what information is needed. Neither Dr. Reardon nor I bite. We need access to the images in a manipulable format. We are going to play with the images when we speak specifically of CT scans. We are going to take your interpretations. We're going to digest those. The more information you give us, the better. But we're also going to play with the images in various planes. So let me show you a few examples. So this is an elderly patient with critical aortic stenosis. He's symptomatic. He's got a fairly calcified valve. The calcification is eccentric. We had some concerns that some of the calcification extended down into the left ventricular outflow tract. As we manipulated the images, cut up and down the aortic root and LV outflow, we determined that we could perform a TAVR in this patient. Here's another patient. This is a young guy. He's in his late 60s. He's physically active. He's got symptomatic disease. As you can see, he's got a bicuspid aortic valve with a lot of calcium in it. And as we cut up and down this valve, you can see that both leaflets are heavily calcified. So there were some serious considerations here. Now, we can do TAVR in patients with bicuspid valves. We didn't when we started, but it's been done. This is an analysis of the TVT registry. Obviously, there is selection bias in choosing the bicuspid patients, but you can see the outcomes are fairly similar, albeit with a slightly higher stroke rate. However, when one looks at characteristics of bicuspid aortic valves, two things that do stand out are the degree of leaflet calcification and the presence of a calcified raphe, which is going to make it very difficult to expand a TAVR prosthesis. So as we look at this guy, he is heavily calcified. I can perhaps convince myself that there's calcification along the raphe. As we put the clinical package together, the answer was no. So this fellow underwent surgery. Finally, here's another patient. This patient has a pre-existing trifecta valve. And in fact, as we performed multiple cuts through the valve, we were concerned about impingement on the coronary arteries when we put in a new valve. So the answer here was yes, but we needed special techniques, and we'll come back to those. So these are the standard measurements. By now, everyone who's performed measurements for TAVR patients understand these, and these varying measurements are useful when we decide which valve to use, and among valves, which size valve to use. So every valve made, either commercial valve or experimental valve, has a sizing chart that contains these parameters. And we use these again to determine which valve to use. Some valves we don't like to place in eccentric orifices. Some valves we don't like to place in heavily calcified valves. Some valves are more flexible. We also try to go as big as possible to reduce the risk of paravalvular leak, possibly increase the effective orifice area, as shown in this study by Drs. Popma and Reardon. But again, we are often limited by the sizing constraints of various portions of the aortic root that imaging provides for us. Finally, there's the highway. How do we get valves up from the leg to the aortic root? And so we need to know about the iliofemoral vessels. We need to know dimensions. We need to know tortuosity. Often, if a vessel is tortuous, our stiff wires will straighten it out unless the vessel is heavily calcified. We need to know that. We need to know if there are protruding atheromata in the aorta or even in the iliacs, because as we try to get sheaths and catheters around these atheromata, we run a risk of perforating the vessel. Finally, in virtually every patient now, we need to know carotid and subclavian artery diameters, tortuosity, and calcification status. As this slide shows you, the frequency of TAVR using the subclavian and carotid approaches has increased in the last 3 years. We've decreased the use of direct aortic and virtually eliminated transapical approaches. So in about 7% of patients, we do use non-iliofemoral access, and we need to know the dimensions of the carotids and subclavians, particularly those on the left side. And these are now performed very easily in experienced centers. What other information do we need? We need to know bicuspid versus tricuspid anatomy. We need to know aortic root angulation. Some valves are more easily placed in aortic root that are severely angulated than others. The Sapient delivery system, for example, has an adjustable flex feature that somewhat facilitates this. We need to know about septal anatomy. We need to know whether there's a bulge that's going to make it difficult to place a valve, or that may run the risk of pushing the valve out during its placement or even afterwards. We need to know about eccentricity of the aortic annulus. There are some annular valves that we're very loath to place in eccentric annuli. We need to know about calcification within the left ventricular outflow tract. This often influences our valve size selection, tells us how aggressively we can post-dilate a valve. And very importantly, from the CT scan, we need to know coronary anatomy. About half the patients we do no longer undergo invasive coronary angiography because the CT tells us that the amount of disease there may be minimal, or the patient may have patent bypass grafts that take away our worry of coronary obstruction. There are newer things we need also. We are concerned about length of the native leaflets, calcification. When we prop that leaflet up, will a calcium nodule sit right in front of a coronary artery? As I'll show you, we're now performing electrocautery techniques to lacerate valve leaflets intentionally so that the valve leaflet wraps around the valve and doesn't, around the new valve, doesn't obstruct the coronary. We need to know the location of potential obstructions. And finally, there's the field of growing importance of leaflet thrombosis. Does this affect valve longevity? Is there an association with stroke? Is the use of anticoagulants indicated? So let's show you a couple of things about valve in valve and some of the things we need from imagers. This patient is 96 years old, presented with congestive heart failure, had a 12-year-old Mosaic 25 millimeter valve. As you can see, he's got what turned out to be a flail leaflet. There was nothing to indicate that this was endocarditis. Here are his Doppler tracings. Pretty clearly, he's got severe aortic regurgitation, confirmed by his hemodynamic tracings. As we looked at his CT scan, this is something we need to manipulate as we cut up and down the level of the prosthetic valves. Here you see the top of the valve posts. And in fact, as you go above the valve, you find the coronary ostia. So this is not a patient in whom we were concerned about propping the valve leaflets open, forming a tube graft that would obstruct the coronaries. Here's another case. This lady's 82. She's quite frail, wheelchair bound, presented with congestive heart failure in the setting of a Lotus valve placed 6 years previously. She's got a high gradient across it. On CT scan, she actually has pannus at the inflow portion of the valve. What I'd like you to notice, though, is that there's virtually no clearance between the valve frame and the coronary ostia. And in fact, as we cut through perpendicular to the valve axis, we can see the valve to coronary distance is close to zero. Placing a new prosthetic valve inside this valve would almost certainly obstruct the coronary arteries. So that case is a no-go. Here's another patient. This lady's 81. She's got exertional dyspnea. She's got a 10-year-old 21 millimeter trifecta valve. What you can see is that as we look at the valve itself, there is reasonable valve to coronary distance on the left, But it turns out that on the right side, the valve to coronary distance is relatively small. And as you look at the leaflets, as they come up, they threaten to obstruct the right coronary artery. So in fact, this patient underwent an electrocautery procedure known as a basilica. We perforate the leaflet with an electrified wire. We then snare the wire, put tension on it, and apply another electrocautery current that actually lacerates the leaflet from outside to in. We then go ahead and place a prosthetic TAVR valve, and what happens? The lacerated leaflets now wrap around the prosthetic valve. We place the laceration directly on FASE against the coronary ostium, so that as the leaflets wrap around the prosthetic valve, that area is left open. And we can do cases like this without causing coronary obstruction. Okay, newer stuff, things we don't have. I like to come back to this point. I've done it ever since we've had this conference. Predictors of stroke. We don't have any other than knowing that patients have had prior stroke and or fail. We don't have an image that can tell us who's at risk for stroke. Calcium score. We often use that in patients with low flow, low gradient situations where we aren't sure whether the aortic stenosis is critical or not. We tend to use the published cutoffs, but again, they're not very solidly validated. We would like to see that confirmed. We need your help doing that. Leaflet thrombosis. I've talked with you about this before. What I've added and underlined is the fact that we need guidance. Hypoattenuated leaflet thickening, hypoattenuation with reduced leaflet motion. Granted, we see these when there's a gradient. We understand there's an indication to anticoagulate the patient and hope that the thrombus resolves. But as far as the association with stroke, what do we do when we see a hypoattenuated leaflet? Thrombus is present. Is there a benefit to anticoagulation or not? The data thus far are mixed. The observational studies are mixed, even though they're prospective, they're not randomized. Some studies tell us that anticoagulants benefit and reduce the risk of stroke. Some don't. As of now, there is a single randomized trial that says, yes, you do reduce the finding of hypoattenuated leaflet thickening. However, this is at the cost of more bleeding, and actually the stroke risk turns out to be the same. So again, stroke risk, we presented this paper several years ago. We've since published it. We looked at the early core valve experience, the first 3,100 patients in the randomized clinical trial. So no valve in valve, no bicuspid here. To make a long story short, yes, stroke's a bad thing to have, no kidding. But we found no significant imaging predictors of early or late stroke. Interestingly, the partner investigators did a similar investigation at the same time, published it in the same issue of Circ Interventions. Interestingly, their paper was immediately in front of ours, but that's the way things work. But they found the exact same things. Our conclusion was that these findings indicate that further refinement of imaging techniques is desirable and may aid in stroke prediction. Unfortunately, that hasn't occurred yet. And since that time, if you look at stroke incidence, there's been almost zero progress in stroke prevention. So I'd like to leave you with that. I'd tell you we have some significant needs. We need your help. Thank you very much.
That's great. Thank you, Neil. I appreciate that talk, and hopefully you'll be able to join us in a few minutes for the cases and question and answer period. We'll keep the agenda moving. Next up is our own Dr. Zoghbi. Dr. Zoghbi is going to talk to us about prosthetic valve evaluation, both TAVR and SAVR valves, and in particular in relation to the 2019 guideline. Over to you, Dr. Zoghbi.
To evaluate valve function after catheter-based interventions, a field that has grown so much over the past few years, from a replacement of an aortic valve or edge-to-edge repair of a mitral valve. These have different issues compared to surgical interventions and replacement of valves. And these have been summarized. This approach has been summarized over the past year in the guidelines that I was privileged to share among many members of the American Society of Echocardiography. I'd like to share also with you that it's important for you to review two other guidelines that relate to these evaluations, one regarding prosthetic valves back 2009 and still very valid, and the other is relating assessment of valvular regurgitation after native valves in 2017. So I think if you take a look at these guidelines, you will be very well equipped in evaluating these lesions. What is covered in the guideline is how to evaluate aortic regurgitation after TAVR and residual regurg. You have some limited views during the procedure. I think the importance of integrating this with hemodynamics. Out of the catheterization laboratory, it's important to use an integrative approach, and a role of transesophageal NCMR, I think, is definitely there in cases that are difficult to evaluate. So what is unique about aortic regurgitation in TAVR compared to after surgical replacement? In TAVR, AR arises not infrequently from multiple sites with variable degrees as opposed to a SAVR, paravalvular leak. TAVR valve is in a long metallic frame as opposed to a narrow surgical annulus, and therefore the challenge to identify and define the site and the course of the AR jets. Lastly, I think there are many factors that contribute to AR after TAVR, including calcifications, which may make the course of AR eccentric and serpiginous, as well as the other etiologies of valve undersizing or valve design, which actually has improved significantly the incidence of AR, which is minimal at this time. So overall, assessing severity, we look at 2D, 3D of the valve itself, stent. A color Doppler, it's important to note here that jets are frequently eccentric, so the height over LVOT width cannot be really used in this situation. We always look at diastolic flow reversal in the aorta. If you're so able, you can quantitate volumetrically the regurgitant volume and fraction, and we take a look at the CW Doppler pressure half time to tell us about the hemodynamic evaluation. So take a look at this case here. You have multiple areas of small regurgitations, and probably this is the most important one here, but you could see these punctate small areas going in the long axis. You may not see all of them, you see a little bit here, but if you go off axis because the regurgitation is occurring here, then you will be able to see where that regurgitation is from the long axis view of the aorta. So it's important to evaluate all these areas to come up with the detection as well assessment of its severity. In this case, as opposed to the first one, is there is significant malapposition because of a gap. The valve is underexpanded and actually it may be hindered because of some calcifications. And you could see actually the flow convergence of flow coming in through where the regurgitation is coming into the left ventricular outflow tract. A nice depiction here that you can have eccentric jets that are so eccentric that go almost across the LVOT. So you cannot really use this, how much does the jet fill the LVOT, because it will certainly overestimate the severity of regurgitation. Also, it's important to know what the methodology, the approach you're doing with echocardiography, because depending on the approach, with a transthoracic approach, you can see nicely the anterior portion of the valve, but posteriorly there is attenuation, so you don't see well, and therefore you're not going to be able to evaluate well with Doppler. Conversely, with transesophageal, posteriorly much better visualized, attenuation much more anterior. So we use the two approaches complementing each other for you to evaluate valve regurgitation. Now, during a TAVR procedure, you're limited from a Windows point of view. So if you're doing a transesophageal as opposed to a transthoracic, use the transgastric approach in addition to the esophageal approach. Most often nowadays we use transthoracic approach with a nice sweep in the aortic valve to see whether there is AR. In cases that are difficult and indeterminate, we always use hemodynamics in addition to an aortography to take a look at that and come up with an answer as to what to do further in the catheterization laboratory. The concept of a sweep through the valve is crucial, particularly in the TAVR procedure. And the reason for it is you want to identify where the leak is exactly there, because if you do it too high, you may not actually see the regurgitation. If you do it too low, you may overestimate and exaggerate the aortic regurgitation because of its eccentricity. And here is at the level of the regurgitation, this is where you see the leak as a very small area there, as opposed to if you go further down into the LV outflow tract, the aortic regurgitation may be overemphasized and falsely larger. So a sweep through the valve is really crucial to do this. And what are some of the quantitative or semi-quantitative parameters that we use? Vena contracta width at the area of smallest dimension. Basically, we use that similar to native aortic regurgitation. Also, in short axis, the vena contracta area, in addition to the circumferential extent. We use them together as opposed to singularly, and the reason for it is at times you can have a large area that doesn't expand so much into the circumference, and therefore using these two together, the circumferential extent, in addition to the area itself, that tells you about the severity. Mild, less than 0.1 centimeter squared with a circumference less than 10%, and severe, as you could see, greater than 0.3 and greater than 30%. Pressure half time tells us something about the hemodynamic differences between pressures in the aorta and the ventricle. Remember, these ventricles are usually less compliant, so a shorter pressure half time does not necessarily mean severe regurgitation, so you have to be very careful about that. We always look at diastolic flow reversal. It's in the aorta. It's important to have a baseline before an intervention because not infrequently, you may have significant reversal early on in diastole. It may not be holodiastolic, but at a higher velocity towards diastole. Therefore, having a baseline would be really important. From a quantitation point of view, yes, you can quantitate flows in the LV outflow tract. Compare that to RVOT or mitral inflow. But a caveat here is depends where you measure the diameter. For cross-sectional area, you have to put your pulse sample volume. If it is outer edge to outer edge, pulse sample volume just before the valve. If it is inner edge to inner edge, inside the funnel, because the VTIs will be different. Here it will be larger than is just before the valve itself. So I think these are important. From an algorithm point of view, to help you decipher whether this is severe or mild, we have some specific criteria similar to native aortic regurgitation. We don't include the ventricular size and function because usually these are short-lived, if you will. Regurgitation didn't have the chronic aortic regurgitation, but most of the others also are important. Similarly, in the mild, they are various parameters, including vena contracta area and width and diastolic reversal. In situations where it's indeterminate, we ask you, if you can, to do some quantitation, particularly for regurgitant volume and regurgitant fraction. And in difficult situations, certainly you may need a TEE or CMR to quantitate it. And I think these two are really very important to help you. Switching now to mitral repair, edge-to-edge repair, certainly very popular nowadays with the expanded indications for such a procedure. It is rather difficult at times because some of these jets may be multiple, maybe one much more prominent than others, or at times crisscrossing, adding to the difficulty in the evaluation. What we look at obviously the 2D, 3D, if there is still a flail component or prolapse. Color Doppler, be careful about PSAC calculation. It is not valid after edge-to-edge repair because of the deformation of the angulation of where this regurgitation is going with the presence of the clip itself. Pulmonary venous flow pattern, very important as to the change from baseline. Mitral inflow pattern with an A dominance, more specific for mild regurgitation. you could do some quantitation, and CW Doppler evaluation is important. This is an example of a pre at baseline with non-coaptation of the valve, regurgitation that is significant, VC area about 0.45, which is very large, reversal, systolic reversal in the pulmonary veins, and after 2 clips, regurgitation is much milder, area is much smaller, and a much more prominent systolic wave, which was completely absent and reversed. So from a color Doppler, obviously we use the usual criteria for regurgitation, VC width less than 0.3. And in case you have 2 moderate jets, you can add them up. VC area, the same thing, greater than 0.4 centimeter squared for severe regurgitation. And if you have 2 moderate jets, you could add either the width or the area together. This is an example for you, just to illustrate what we're talking about. Severe regurgitation at baseline, look at the flow convergence that is occurring even without a baseline shift. And this is the 3D to evaluate the valve itself, and notice the amount of regurgitation after 2 clips there at A2P2 and A3P3, significant reduction in valve regurgitation by 3D as well as 2D. And importantly, what happened to pulmonary venous flow, resurgence of the systolic wave as opposed to a reversal here. Also importantly, an increase in LVOT, VTI, systemic flow increased compared to before from 9 to almost 15, and some appearance of spontaneous contrast, meaning lower flow in the left atrium compared to what it was before. So for spectral Doppler, the 2 at least main features, we look for systolic flow reversal in the pulmonary veins for severe MR, and mitral A dominance suggests mild mitral regurgitation. 2 quick ones from the guidelines here: a mild MR, A dominance, preservance of the systolic forward flow. Compare that to a moderate MR, at least moderate MR, more impressive color Doppler, E dominance here, either reversal or contamination by the MR jet, telling us that we need more information and maybe more quantitation. Remember, we cannot use PISA calculation for effective regurgitant orifice area after edge-to-edge repair. You could use volumetric flows. And for volumetric flows, please use contrast if you want to have a better estimate of LV diastolic volume and systolic volume, and therefore total stroke volume, because otherwise you will underestimate what the total output of this ventricle is. And by way of algorithm, we have that in the guidelines for you, some severe criteria for severe mitral regurgitation based on these measurements, specific criteria for mild mitral regurgitation, and when in doubt, please use other methodologies, transesophageal echocardiography or CMR for quantitation, because CMR can truly quantitate this total output of the ventricle, systemic output through the aorta, and therefore the difference would be your regurgitant volume, and you can calculate regurgitant fraction. And for your availability on handheld devices, these actually can be in a pocket guide at the American Society of Echocardiography or a poster in your laboratory. Thank you again for your attention.
Well, I'd like to thank Dr. Zoghbi for a great demonstration of what we need in this imaging for leaks on our valvular repairs. We're going to move on to the last lecture before we go into an interesting case with my good friend, clinical partner, and co-moderator, Steve Little, is going to talk to us about the interventional imager, the needed training, and the role involving the heart team. I'll start off by saying the role is crucial, Steve. We can't do what we do without a good interventional imager. So on to Dr. Little.
Great. Thank you, Mike. Appreciate that. Okay, so this is a version of a lecture I've given before, but I like to give it because it changes every year, and I think that's the entire topic. So this is an older slide. This is what we used to do as interventional imaging. This was us taking pictures during a balloon valvuloplasty. This was satisfying, but no device was left behind. And I think that's the fundamental change in this field, is that we are very much involved in guiding devices that are left behind. So just a quick overview of representation of some of the activity: ASD closures, PVL repair, appendage occlusion, TAVR, edge-to-edge repair, TMVR, tricuspid repair, and even more recently, transcatheter LV enhancement, sort of hybrid surgical procedure and the guidance for those. So it's a very large field. In this short talk, we don't have the time to go through all of these procedures, so I'll try to give you some general principles that are important for the imager or the emerging imager. So one thing to understand is that the heart valve team imager has several different roles. And these are sort of grouped into a cluster of activity in selection, a cluster of activity in the form of guidance, and then some activity in the form of evaluation. But each of those clusters have different focus as well. So under selection, you've got to help select the severity of the lesion, mild, moderate, severe typically, the best procedure, and even often the device size. In guidance, you're focused on safety, efficiency, and efficacy, all of those things at the same time. And then in evaluation, how did the device function and how does the heart responding to that device? These are all within the purview of the imager. So in short, the imager is fully embedded in the structural heart team, at least in an effective team. So one of the basic concepts is that you have to be very sort of competent in transesophageal imaging. This is just a normal mitral valve as viewed from the left atrium on the left and from the left ventricle on the right, and just recognize how close the structures are, what the normal structures are, and start to understand what abnormal looks like. On the left is a mildly thickened mitral valve. On the right is a significant P2 prolapse, and just sort of recognizing quickly the difference and how these sort of versions of fibroelastic deficiency can manifest. We've seen a version of this slide. And this is important, again, the nomenclature the interventional imager must be competent in. So, this is a central illustration of the Carpentier classification, really just demonstrating a group of primary MR groups and secondary MR groups, and sort of a reference chart for what is type 1, type 2, type 3, type 3B. The imager has to be, familiar with these because the nomenclature of the literature uses these terms. Some applications I'll focus on just for the sake of examples. TMVR is sort of a grab bag term, but it can be divided into two procedures for prosthetic valves, the valve in prosthetic valve or the valve in ring, and then two procedures for native valves, a valve in native valve and a valve in MACC. So an example of what was referred to as a valve in ring. So this is the 3D image of a dysfunctional mitral repair. It was referred as a valve in ring, but of course when you look closely, immediately you can see that it's actually a valve in band. It's an incomplete ring in that it does not traverse sort of trigone to trigone across the anterior. There's an A2 flail and some significant MR, and this is in a gentleman with prior bypass as well as the repair. So the discussion was, how do we resolve this? There had been a posterior resection, so mitral clip was never going to be an option. So this was, can we do a mitral clip procedure, or can we do a valve in band? A valve in ring is the rough term. Sort of looking, we see there is no posterior leaflet visible. There's also a heavily calcified chordae. This is not an edge-to-edge repair option, but it is a valve in band option. So sort of recognizing and helping in that decision-making, what are the possibilities for this particular patient-specific anatomy? This is the procedure. So this is a TAVR device sort of loaded up and put in the mitral position. It's a balloon expandable device. It's sort of repurposed in the mitral position. Some of the imager concerns are when a device like this goes in, where are the potential problems? So not just recognizing them after they happen, but also anticipating where can problems arise if you're putting a circular device that's balloon expandable into an incomplete ring. Well, this is a courtesy of Vinny Bapat and some of the graphics he's described, showing that where paravalvular leaks are likely to occur, and then also how do you deal with them. So recognizing that that could happen, we see that it in fact did happen. This is a sapien valve deployed. We can see here that there is a little bit of paravalvular leak along this posterior lateral quadrant. Then the challenge is, well, is that a hemodynamically important amount of leak? Probably not, but is it important from an etiology of Lysis? Yes, it probably is, right? That's the sort of the blender scenario. We've got prosthetic material on both sides of a high velocity jet that gives you lysis and hemolytic anemia. So this was a discussion that quickly ensued, and it's, well, let's reballoon this a little more. This is the reballoon, and then the paravalvular leak was gone. We see a very nice hemodynamic result. No more paravalvular leak. A tiny LVOT gradient of 20 millimeters mercury, acceptable in this procedure. And this is sort of the quick before and after description. So a relatively simple procedure after, the team has done several of them, but there are several sort of highlights for the imager and things to be aware of in those cases. Switching gears to a valve in native valve procedure. Currently, these are generally performed within research studies and at least today still transapical in delivery. This is one particular device. This is a self-expanding nitinol-based frame that sits inside the native valve. One of the most exciting things from an imager's perspective is we get to tell the surgeon where to put his finger. So that's the surgical finger poking at the apex. We help identify the true apex. There's a small surgical incision in the chest in a beating heart procedure. There it is. I believe this is Dr. Reardon's hands with a small apical procedure. That's definitely Dr. Reardon with a fairly large sheath through the apex. But then after that, a device is delivered directly into the native mitral valve. And there's a whole host of imaging concerns and guidance that occurs during that procedure. Hopefully you get a final result that looks like this with 2 pixels of central MR only and an impressive hemodynamic result. Recognizing the imager needs to be aware of not just echo. So this is the CT before and after this case. You can see before, and you can immediately see that there is an LV systolic impairment. But in the setting of significant MR, you can almost eyeball the ejection fraction. After you deploy this large device within the mitral annulus, you get rid of the MR, but you also potentially directly impact papillary muscle traction and the synchrony of the ventricle, and you have an immediate reduction in EF. So sort of recognizing and being aware of the multimodality tools that are available. And this is the final before and after of that case. So it's a complex area with all of these various procedures that are now available. This is a review I was happy to contribute to earlier this year, looking at the imaging guidance for transcatheter valve in rings and prosthetic valves. And the take-home message in relation to this lecture is that you've got to know several things if you're going to be the embedded imager. You have to know the patient, you have to know the treatment options, the plan. What is the plan for this procedure and how might you have to adapt it on the fly? What's this particular patient outcome, and importantly, what are the team outcomes? How did the patient do, how did a similar patient do last time, and are there lessons there that you're going to bring forward into this case? So edge-to-edge repair, which we still commonly refer to as MitraClip, has very much evolved. It's been almost 20 years since the first enrollment in the Everest study. At that time, we had very targeted and simple approaches. The MitraClip goes down the middle, A2, P2 only back in that day, which is your chordal free zone. So understanding the anatomy was very important. Nowadays, we have much more complicated and complex devices and also treatment options and patient selection algorithms. So these are the devices that are currently available both in Europe and North America. The Pascal system at the bottom is in clinical trial in the United States. The MitraClip system is commercially available. But we've got a lot of choices now. We've got 2 different widths, 2 different lengths. Even the Pascal system now comes with 2 different sizes. So you have to know what these are, and you have to consider the grasping length for this particular patient, the width, and even the mechanism of closure and the targeted deployment site. And you do definitely have a say in which device for which patient. This was a recent review that sort of highlighted some of the complex cases and decision making that is now available, and the graphic indicates that we don't simply go down the middle of A2, P2 anymore. We are often dealing with commissural disease and even disease in calcific landing zones. This is one such case. This was a retired physician. He had a lot of dyspnea, and he's an example of truly a mixed etiology. So we can see he's got a calcium shelf below his valve. He's got prolapse. He's also got some regional LV dysfunction. He's got significant MR. And if you look at the 3D en face, that's a fairly ugly valve. It's not attractive for any form of repair, surgical or catheter-based. But in this particular case, the team decided collectively that it was doable, or at least to the expectation of a significant functional improvement from an edge-to-edge repair. So this is sort of the classification. This was largely a Carpentier type 3A valve. And here's what happened. So this is the baseline. We have systolic flow reversal in the pulmonary vein. One MitraClip deployed right here. The valve still looks terrible. The color coming off of this valve was fairly complex. There was residual MR. It was thought to be mild to moderate in color quantitation, but very importantly, there was a resurrection of the antegrade flow of the pulmonary vein, and this patient had a tremendous clinical response. So recognizing again the importance of the hemodynamic evaluation for the imager. So patient selection for edge-to-edge repair, and I like this slide because it sort of is a nice summary of where we are today. There are multiple factors, and this is very germane for the imager to be aware of. There are clinical factors in terms of the clinical presentation and the options for the patient. There are a lot of implications of operator experience, and that really should largely dictate whether you're a beginner case, intermediate case team, or an expert case team. And then there's the anatomy itself, and there's a collection of anatomy that is optimal, typically reflecting the initial trial data, the Everest trial 20 years ago almost now. There's the challenging, and then there's the advanced, complex, bordering on prohibitive. And I would say a valve area less than 3 centimeters is still very much prohibitive. And I think it's important to recognize that the patient selection is an important role for the imager, and being aware of these sorts of algorithms are important. Training is complicated in this, and this is an evolving sort of recommendation series. This is an important document to be aware of. This is the advanced training statement of the ACC-AHA with ASE endorsement that came out just a couple of years ago. And it does talk about level 3. This is really a sort of a description of what does level 3 echo mean, what are the competencies that should include. It does reference that if you're going to do structural guidance, you should have a minimum number, perhaps as many as 75 cases. But then importantly down here, these are for training in particular procedures, and you don't need all of these to be level 3. So this gets to the issue of, should level 3 echo have a specific grouping if you're going to do structural imaging guidance. And this is sort of an editorial consensus statement that Dr. Hahn and I and others were happy to put together just a couple of years ago, proposing that perhaps there should be another group of level 3I, really a specific set of competencies to be able to guide these procedures. And that's actually a guideline that's now in the works. So in closing, the heart team valve imager has multiple challenges. You've got to know the job, and that really is the patient scenario before, during, and after the intervention. There are certain operator characteristics, cautious, flexible, and a selective leader, knowing when to speak up and when not to. The training, you've got to definitely know the disease, you've got to be good at TE, and you've got to be very comfortable in manipulating 3D volume sets. And then finally, there's a commitment to the structural program, knowing the patient, knowing the procedure expectations, and knowing all of the other options available to this patient. And I think I'll stop on time. Thank you. All right.
Thank you, Steve. Great talk. It looks like now we're going to move to our clinical case. Steve, are you going to introduce this case to us?
I will. I think we have two of our extraordinary fellows. We have Dr. Roa Attar and Dr. Tim Hinohara, who's our structural fellow. They are going to take us through a case, a fairly recent case, that touches upon many of the elements that we've talked about in this session. So do we have Roa and Tim available for us? I see a waving. We'll just see what's happening.
They're coming in. Just give me 1 second.
Okay, they're just coming in.
Maybe I could take, I don't know. There is a question while they come on board. There's a question about pulmonary veins and regurgitation and diastolic function. Caution for pulmonary vein if your mitral regurgitation is hitting that vein itself. You should not use it for neither diastology nor for assessment of regurgitation severity, so you got to be careful about that. And implied in the question also from the audience is how do you use it for diastolic function assessment, knowing that the guidelines do not mention it directly into their algorithm. We always use it to support our assessment of whether the filling pressures are elevated, yes or no. Got to be careful about it in normal hearts and normal ventricular diastolic function. Also, we use it for LVEDP if the duration of AR wave is long compared to the mitral A wave coming into the ventricle. All right, Steve.
Okay, thank you, Bill. I think we're doing a technical change over here. We've got Dr. Roa Attar, who I'm happy to introduce. Roa is one of our advanced imaging fellows, most recently from the west coast of Canada, from UBC, and soon to be going back to Saudi Arabia. And Tim is, you met earlier in the case presentation, presented an excellent mitral case. He's our current structural interventional fellow. All right, you guys, are you ready to roll with your case presentation?
Yeah, I'll start sharing my screen. So thank you, Dr. Little, for the kind introduction. All right. So I'm going to be presenting an interesting multi-valve case that we had seen in Valve Clinic. So our patient is a 67-year-old male that was seen in Valve Clinic with symptoms of acute decompensated heart failure. He has had worsening shortness of breath for 2 months prior to his review. He had some orthopnea, PND, and increased in lower extremity swelling, and his weight had gone up by about 10 pounds. So his past medical history, he has the usual comorbid conditions. So he has hypertension, dyslipidemia, and he was basically born in India and had a history of rheumatic fever that was very remote as a child. So in terms of his cardiac history, he has a history of atrial fibrillation. He has a reduced ejection fraction with an EF that had ranged between 30 and 40% on serial echocardiograms during his follow-up, and had undergone a primary prevention ICD in 2017. With regards to his valvular heart disease, so he had severe rheumatic MR that was fortunately repairable in 2008. So he had undergone a mitral annuloplasty ring in 2008. During that same surgery, he had also undergone surgical resection of his left atrial appendage and had atrial reduction therapy. More recently, just in the context of his presentation, he had undergone also a coronary angiogram, and he was found to have one hemodynamically significant lesion in his circumflex with some moderate disease in his LAD and RCA. So I'm going to start off by showing some of his baseline echoes. So this is his initial transthoracic that we were seeing right now, and parasternal long axis view. We're seeing that the RV appears a bit generous. There's some mild RV dysfunction, and we're also seeing that his LV is at least moderately depressed, with his LV size being at the upper limits of normal. But what we can also appreciate is that you're seeing a mitral annuloplasty ring that's well seated. We're seeing a very restricted posterior mitral leaflet with very minimal motion of the anterior mitral leaflet. We can also appreciate that there's also some thickening and calcification of the aortic valve and very minimal excursion of the aortic valve. The right image here shows some mild MR, at least on these views, with some trace AR. And now here we're looking again at short axis views of this patient's aortic valve, and I think what we can appreciate here is that there is a significant amount of thickening, but the calcification is not as impressive as the amount of aortic excursion that we're seeing. And I think the other thing that I'd like to point out is that this seems to be more commissural stenosis rather than our typical calcific aortic stenosis patients, which points towards perhaps an etiology of rheumatic aortic stenosis over calcific. And here we're seeing again some biplane imaging of the aortic valve. We're seeing the left image shows the aortic valve in short axis. We're seeing again thickening, calcification, and minimal opening of the aortic valve. And on the long axis view, we're seeing very similar images. So this is the gradient we were able to elicit across this aortic valve. So the gradients we were able to elicit were not beyond 28 millimeters at rest. And on repeat testing, the aortic valve area had ranged between 0.7 and 0.9 centimeters square. So collectively, the findings were suggestive of low flow, low gradient aortic stenosis. The other valve that was concerning to us in this patient was the mitral valve. So to better evaluate this mitral valve and to determine if there was a need for intervention, we got a TEE, which showed, again, we're seeing very significant thickening, calcification of the leaflets and the annuloplasty ring. And here you can appreciate that the posterior leaflet is completely immobile, and the anterior leaflet seems to have very minimal movement. So these are 3D en face views of this patient's same mitral valve. So here we're seeing the mitral valve, the anterior mitral leaflet here at about 12 o'clock, and we use the aorta to orient ourselves. And again, we're seeing a very restricted posterior leaflet, and the image on the right basically shows some mild MR, mild to moderate at most. To assess this patient's hemodynamics, CW basically shows a mean gradient of 9 across this very stenotic valve. And again, here we are seeing the extent of the regurgitation. And again, both 3D and 2D imaging were suggestive of this being a transvalvular process, and we weren't seeing any dehiscence of the valve ring. With that in mind, just seeing how significantly stenosed that mitral valve was, there was no doubt in anyone's mind that that was definitely a valve that needed intervention and may have been playing a role in this patient's presentation of acute decompensated heart failure. But the question was, how severe was this aortic valve? So we ended up getting a dobutamine stress echo, just given that this patient had a reduced ejection fraction. That would be what the guidelines would recommend, and that would be what most of us would be doing clinically. So the mean gradient increased from 28 to 35. The aortic valve area increased from 0.7 to 1. So anyone that does these frequently, I mean, everything's kind of in the gray zone. The patient had a poor contractile reserve. So that led to us using a second modality of imaging to help clarify severity of this patient's stenosis. And what we can see here is, again, we were able to take another second look at the mitral valve, and we can see very restricted valve opening, thickening, calcification of the valve ring. And on the right, we're seeing short axis views of the aortic valve. And again, there's minimal opening, but the interesting thing about this patient is that his calcium score was 1,300, which is a little lower than what you'd expect for severe ES, and we're not seeing that degree of calcification. But I'd like to highlight that that's with the caveat that this patient is a patient that has rheumatic heart disease and not true calcific disease. So just a brief review for everyone. So some of the reasons patients may have a low flow state are the more classical low flow, low gradient AS patients, if you have an EF of less than 50%, which this patient does, or our patient had. But there are other causes of low flow states, such as significant valve regurg, or if you have a very small ventricle that is going to have a restrictive filling pattern, or if you have other valvular disease. So this patient, for us, he basically had a depressed ejection fraction and his stroke volume index was way below normal. The other thing was this patient also had MS. Now, whether MS is truly a low flow state is a debate. It's a debatable area. So some would argue that though mitral stenosis does decrease your flow, it is a high pressure state. And then there was some MR, and this patient, though I haven't shown the images, had moderate tricuspid regurgitation, which would also cause him to lose flow to the left side. So some of the imaging challenges in our patient, so the presence of multi-valve disease, in addition to the depressed ejection fraction, really doesn't make assessing severity of AS in this patient easy. We had an equivocal dobutamine stress test, and then the fact that calcium score may be less helpful in determining AS in patients that have rheumatic heart disease as opposed to our more classical calcific patients. So with that, I'm going to pause here and I will see what our experts have to say.
Great, thank you, Roa. Okay, great, thanks, Roa. That was an interesting case, and I actually know this case quite well. So I'll pose a question perhaps to Dr. Zoghbi, who's here beside me, and I think he's not familiar with this case. I'll summarize some of the unique element here, and I'll add a little history that I think you probably didn't know. So 67 years old, clear history of rheumatic dysfunction. He did have a very interesting chest scar. So he has a scar on his left chest that goes from midline almost out to the axilla. That I believe was a surgical commissurotomy. He has no details. It was when he was a young man. He nor his wife know the details, but presumably it was performed in India. So then he went for several decades before he had another surgical repair in 2008, where he had the ring implanted. So I think he was rheumatic, predominantly MR in 2008. But in the time since, had slightly progressive, slow and steady progressive stenosis, so mean gradients now of the mitral, varying on the study, but between sort of 8 and 12. In addition, the slow development of aortic stenosis. And as you rightly pointed out, one of the interesting discussion points was, we don't see a lot of rheumatic aortic stenosis. And our CT thresholds for sensitivity and specificity are sort of we're used to using a cutoff Gaston score of 2,000 for men and 1,200 for women, but there are really no rheumatic, or at least none that we know of, rheumatic cases in that derivation publication. So what is the right number for somebody with rheumatic aortic stenosis? We don't know. So the challenges for this case, we're trying to ascertain what's the dominant lesion. Is it He's now got heart failure. Is it MS? Is it MR? Is it AS? Is it all three? And what might be the diagnostic pathway that obviously would precede the treatment pathway? So it's a different case. Question for you, I guess, Bill, is from what you've heard so far, would you be thinking the mitral valve or the aortic valve as a primary target?
I think obviously we have two valve disease. The question is, do we have one more predominant than the other? From what you showed me, the mitral valve structurally as well as hemodynamically seems to be a predominant lesion. The question is the aortic, and here, just like you mentioned, a CT calcium scoring really does not apply in this situation. What you want to look at is, do we have fusion of the commissures? Usually you don't have much calcifications in a rheumatic etiology. The hemodynamics are a bit borderline from an aortic valve status point of view. The question is, can you do them simultaneously, or should you do them sequentially? Now, The question is, what's causing the symptoms of shortness of breath, et cetera, et cetera? Obviously, has a reduction in ventricular function. That could be not related to valve disease, unless you tell me historically it is. Could be a myocarditis that has occurred during his rheumatic etiologies, or is this a pressure load on the ventricle from aortic stenosis? Hard to tell at this stage of the game. The mitral valve should be a bit more protective, but we don't know what his ventricular function was like before a mitral valve intervention that he had before. So bottom line, I mean, it's interesting, just a question for you and for the audience, is why did you decide on a dobutamine as opposed to an exercise? Because I would have loved to see an exercise if he could do a bicycle exercise for hemodynamics for two reasons. One, to see whether the mitral valve that you see the gradient heart rate was on the low side. I would have loved to see what he would do hemodynamically, physiologically, without dobutamine. What happens to the gradient? What happens to heart rate? Because at times you'll be surprised that you may get a significant tachycardia, and that could be the rate limiting step in somebody like him. And then, yes, you could go to the aortic valve and see what happened to the gradient. I know the contractile function is low, and I think it leaves you in a quandary as to what the situation of the aortic valve, but ultimately has some aortic valve disease. I would say that the culprit is predominantly the mitral, but certainly there is a component of the aortic.
Thank you. I think you've nicely encapsulated a lot of the discussion points and some of the uncertainties that many of us felt with this case. Our take home was he's got significant dysfunction of two valves in the left heart, and it's very hard to tease apart which one is dominant in terms of the responsibility for his symptoms. But then we sort of fast forward a bit, and we're thankful that we're in an era where we have treatments for both of those conditions. So maybe, Tim, you can take us into how we address that, thinking that we wanted to treat both valves with the mindset that they're both at least moderate in their dysfunction. He's got at least moderate AS, possibly severe, and he's got clearly at least moderate functional mitral stenosis based on the combination of a surgical ring and ongoing leaflet thickening in the decades since then. So do two moderates make a target combined? That was part of the discussion. So Tim, why don't you take us through in the next few minutes what happened? Tim, you're muted.
The final decision was that we did think that both valves were likely severe, especially the mitral for sure. And the decision was to fix both percutaneously as long as the anatomy was suitable. So we ordered both a CT TAVR and a TMVR. Here's the CT TAVR. We see an annular area of 687. He has large sinuses and high coronary heights, so the risk of coronary obstruction was low. His anatomy was suitable for TAVR with a 29 millimeter sapien valve by a transfemoral approach. On the CT TAVR, CT TMVR, this also showed that his anatomy was suitable for mitral valve and ring with a 29 millimeter sapien valve. The figure on the right shows the neo-LVOT after implanting a virtual valve. And this neo-LVOT was very large, and the risk of developing LVOT obstruction was low. So we decided to perform both procedures together rather than staged. By combining the procedures, we would consolidate and minimize the risks associated with two separate procedures, including bleeding from obtaining vascular access again, and also repeated exposure to sedation. When we fix two valves at once, the general rule is to fix the outflow first. This is because improving outflow allows for better blood pressure support and quicker ischemic recovery, especially after rapid pacing, which is required for TMVR. So our game plan was to do the TAVR first, followed by TMVR. After obtaining vascular access for both the TAVR and TMVR, on the left, we took an aortic root shot in the coplanar view, which is what we use to deploy the sapien valves. And once we were satisfied with the valve location, we deployed the valve with rapid ventricular pacing, which is shown on the right. Afterwards, we recorded simultaneous LV and aortic pressure tracings, and this shows pre and post TAVR. We see that after the TAVR, we were able to reduce the mean gradient from 25 millimeters mercury to 0. We then moved on to the valve and ring TMVR, and I just want to speak a little bit about this, since this is actually a very technically demanding and challenging procedure, especially compared to valve and valve TMVR. So valve and ring requires a circular valve, which is the sapien valve, to fit into a non-circular ring to anchor securely and without PVL. The annuloplasty ring provides a small landing zone and little geometric constraint during deployment, in contrast to if there was a pre-existing valve there, a pre-existing bioprosthetic valve there. So valve and ring requires controlling both the longitudinal position, or the depth, and also the angulation of the sapien valve to make sure it's not canted. Procedure planning includes evaluating the landing zone geometry to figure out what size valve we need, as well as the risk for LVOT obstruction, and also trajectory planning. And this is to ensure that we are able to implant the valve coaxially, and it should be orthogonal to the annular plane. And one of the ways we can modify the trajectory is by a good transeptal puncture location. And then afterwards, there are different maneuvers you can do to try to shift the valve anterior, posterior, or medial, lateral. Here is an angio of the TMVR deployment. I don't know if you could see my cursor, but in the red is the annuloplasty ring. It's just we're looking at it without parallax, so it's just this straight line right here. And here you see it deployed under ventricular pacing. And this was done after we were satisfied with the depth of the valve implantation, as well as the coaxiality. And we can see that the valve is implanted about 80% ventricular, which ensures that the valve skirt is in contact with the ring to provide a good seal and minimize PVL. Afterwards, we checked hemodynamics, and these are the LA-LV tracings. Prior to the procedure, the transmitral gradient was 9, and following the TMVR, it was reduced to 2. The next day, we performed a transthoracic echo. Interestingly, his EF had improved from about 30% to about 50%. And this does, to me, suggest that the AS was actually very severe, since fixing the MS would not lead to improvement in LV function. On the right, we see that the valve has minimal or trace paravalvular AI. Here are the LVOT and AV Doppler tracings. The TAVR DVI was 0.68, and the mean gradient across the valve was 4.7. Here we see the mitral prosthesis here. There's no PVL, MR, and the mean gradient was 6 millimeters of mercury. The patient did very well after the procedure. In fact, just 6 hours after the procedure, he was able to walk around the hallways, and he was discharged the following day. So in conclusion, the assessment of valvular lesion severity is challenging in multivalvular disease, and multimodality imaging is often needed to determine the severity of, or is needed for accurate diagnosis, and also to inform treatment options. And in this case, we used a variety of imaging modalities to determine the severity of his aortic stenosis and to plan the intervention.
Tim, thank you, Roa. It's a nice summary of a very complex case, which with a very nice outcome. I think, Mike, you're still with us on the call. A question for you, if you're there, and that is, this is one of our first single procedure double valve interventions. Obviously, and thankfully, rheumatic presentations like this aren't very common, but the senile calcific is increasingly. Do you see this as something we're going to start doing more often, the combined sitting mitral aortics for appropriate patients?
I think we will, Steve, particularly as we move into more transeptal total mitral valve replacements. The newer ones are being designed as transeptal. Of course, in the Apollo trial with Intrepid Valve, we're moving into transeptal. I think it's going to be very important when we think about how we stage these. Tim said, of course, do the outflow first. But that's not only for the physiologic reason, it's also for the technical reason, is that if you put in a balloon expanded aortic valve and then came back to put in a balloon expanded mitral valve, the balloon would interfere with, if it the mitral in first and then came back to put in an aortic, the balloon would interfere with the mitral valve. And so we could put in a self-expanding after we put a balloon expanded in the mitral, but we couldn't put a balloon expanded in. And doing a post-BAV would be difficult. So understanding which valves you want to use and how you want to sequence it, only the balloon expandable is available for the mitral, but how you do the aortic would change a little bit. This is going to become more and more common as we move forward. And then we'll add the tricuspid to this, that it's a third valve.
Yeah, a drive-by tricuspid intervention, add another 5 minutes. Yeah, thanks, Mike. That's great. It was a great case and one of the first.
The amazing thing to me is a lot of thought, going and technicality to deploy these valves, but I'm just thinking from a patient's perspective. This individual was walking the hall the second day and going home the second day. And this is really amazing.
I think we have to bear in mind, Bill, is that this guy's younger than I am, and I would not have operated on him because once you looked at this man, you were not going to touch him. He was too frail. And the fact that he did this well when he really wasn't even a surgical candidate is really quite astounding.
I mean, walking 6 hours after a double valve implant where the cardiology ward is starting to look like an orthopedics ward. Everybody get up and move right away. In just a couple of minutes, I have a question for Dr. Zoghbi, not related to this case, but please stay and opine. So it was the issue of strain imaging for aortic stenosis, in particular in the TAVR population. And I can speak anecdotally, I can consider two patients that we've had who've had abnormal LV longitudinal strain with aortic stenosis, went for TAVR. In one patient, the strain got better after TAVR, and the other patient, the strain got worse after TAVR. So maybe, Bill, your thoughts on how might we use strain in this prognostic form, and maybe what data do we need to answer these questions better?
I mean, strain is a very interesting quantitative parameter. We know it is in a way better from a prognostic point of view for LV function, better than ejection fraction. And I think the best example for that is in the hyperdynamic ventricular function with hypertension or aortic stenosis. When you still have a hyperdynamic situation, global longitudinal strain, or GLS, could be reduced because the myocardial fibers that are much more in the endocardial situation are much more affected. So although you may have traditionally a normal ejection fraction, GLS may tell you something about prognosis, because we know also when you pair it with LV hypertrophy and prognosis, individuals with significant LV hypertrophy that is pathologic have a worse prognosis. So if we translate this into an aortic stenosis situation, I think most people with significant aortic stenosis will have an impaired GLS, will have a GLS that is lower than normal. And part of it is because of either the LV pressure that is generated in this individual, be it normal LV function or abnormal LV function. Or it could be at a later stage from an aortic stenosis where you have ventricular dysfunction, and we know this ventricular dysfunction can be at the cellular level. It's not only load related. So with that complex background, different background, I'm not surprised that you're going to have some patients with improved GLS after relief of the obstruction, and some patients may have some reduction in GLS. I don't know if it is procedure related or loading related. Remember, all these are load related. But I think what would be very interesting to see whether we can impact also prognosis, particularly if GLS improves after such situations. So I would study that personally to see what the implications are from a prognosis point of view, heart failure, etc.
That's great. Okay. Well, thank you, Bill. Well, we're actually exactly on time. So we'll go ahead and wrap up this morning session and the second session on valves. My thanks again to Roa and Tim for putting together that very interesting case. Mike for obviously performing the case and getting us these terrific outcomes to talk about. So on behalf of my co-moderator, Mike Reardon, thank you for all joining us for this session. A quick reminder of what happens next. We have a lunch break. I encourage you to all visit the exhibitors. They will be available to you on the Zoom, on the link that you're currently on. And then join us back in half an hour. So at 1 o'clock, we have our Read with the Experts session. That'll start off with 3D echo and quantitative case studies in echo. So please go have lunch, take a quick break, and we'll see you back in half an hour. Thanks, everybody.
Thank you.
Good afternoon, and welcome back to our multimodality imaging sessions. I hope you had a great lunch. I'm Mike Quiñones, and this afternoon between 1 and 3 o'clock, we're going to have the reading with the expert session. Every 30 minutes, we switch from one modality to the other one. So we're starting with echocardiography, in essence trying to show some cases to emphasize quantitation and also the role of 3D in selected situations. So we're going to start with Dr. Naga, who's going to present some cases emphasizing more diastolic function.
Hello, I'm Sharif Naga. We'll go today through a couple of cases on assessment of diastolic function. This was a patient who presented with dyspnea, no previous cardiac history really, not taking any medicines, and blood pressure was 110/60. There is the parasternal long axis view. Perhaps one of the notable observations on this is despite the normal blood pressure and the absence of history of hypertension, you see increase in the wall thickness of the septum and the posterior wall. We also appreciate an increased anteroposterior diameter of the left atrium, as well as some thickening of the aortic valve and perhaps some as well of the right ventricle, though RV wall thickness is best assessed in subcostal views. We go to the short axis views and we confirm the increase in left ventricular wall thickness, and it's a symmetric increase, a concentric increase all around, so to speak. If we go to the apical views, we appreciate the rather preserved ejection fraction, but you can also notice that the long axis excursion of that mitral annulus visually is very minimal. Both atria are enlarged, and the right ventricle is at the upper limits of normal. So if we are putting things together, we have noticed the increased wall thickness that was concentric, the big atria, left and right, and some brightness that is notable here in the septum, though I would caution upon relying on this brightness too much. We do apical two-chamber views, similar findings, ejection fraction preserved with a big left atrium, perhaps some thickening of the mitral leaflets. We see mild mitral regurgitation, some degree of tricuspid regurg by color Doppler, and then we see a restrictive filling pattern with marked reduction in the A velocity, both amplitude, very short duration, and very steep deceleration. These findings are indicative of increased not just early diastolic pressures, but also left ventricular and diastolic pressure. We look at the annular velocities and you see that they are markedly reduced, diastolic and systolic. The reduction in the systolic velocities matches our observations when we were looking at the 2D images and noted very little excursion of the mitral annular plane. So if you apply the E to E prime ratio, you will end up with very high values. So if I go back to the guidelines, I would say this is a patient with clear diastolic dysfunction abnormalities, grade 3. How about the right ventricular function? Taking a quick look at the tissue Doppler signal, we see also a reduction in the systolic velocity as well as the early diastolic velocity of the tricuspid annulus, confirming the presence of systolic and diastolic abnormalities for the right ventricle. How about right atrial pressure? There is a subcostal view. You see the IVC, and not only the IVC, but the hepatic veins that are markedly dilated. No change in the diameter of the IVC with spontaneous respiration, indicative of a marked increase in right atrial pressure. I've stayed away from the diagnosis so far, but let's take another look at another finding in this case, and you see here the global strain polar map with strain reduced everywhere with some sparing of strain in the apex. Putting things together, I believe most of you have already arrived at the diagnosis that this is a case of cardiac amyloidosis, and this was indeed the case for this patient. Let's look at another patient who presented also with dyspnea, lower extremity edema, a blood pressure of 100/60, but again, not on any medications. Starting with the parasternal lung axis view, we appreciate a normal ventricular shortening fraction for the left ventricle. Many of you probably have already noticed some septal shifting, albeit every third cycle or so. When we did the M mode, even though many may sort of pass over the M mode quickly, the M mode in this case is very helpful. If we start at the far left, you can see that the right ventricular size in comparison to the left ventricular cavity size, so there is the right ventricle dimension in comparison to the left. Right is more than left. As we go with the other cardiac cycles and as respiratory phases change, we see the right ventricle becoming smaller, but the left ventricle becoming larger. And again, towards the end, the RV is getting larger, but the LV is getting smaller. So there are changes in ventricular dimensions secondary to changes in ventricular filling. The last sentence of changes in ventricular filling, we will show it with Doppler, but it is clear that there are changes, reciprocal changes in ventricular dimensions that you see here. Tricuspid regurg signal is recorded. You can see some beat-to-beat variation, but it is not indicative of an increase in the RV-RA pressure gradient. So that's something to keep in mind for now. We'll see how to put it together with other findings. There are the apical views, and here the septal shift is very clear, and the variations in the size of the right ventricle and the left ventricle is very apparent. As the left ventricle gets larger, the right ventricle is noted to be smaller, and vice versa. The apical two-chamber view is showing us here a normal ejection fraction. And if we take a look at the flows through the left ventricular outflow tract, you can see that there is also variation. Even though the location has not changed much, you can see beat-to-beat variation. Clearly, this beat is much smaller time velocity integral and peak velocity than the earlier beats. So the stroke volume is showing some variation beat to beat, and this slide takes us to the reason behind the variation in the ventricular end diastolic dimension and the stroke volume. It's the variation in the mitral inflow. Even though we don't have a spirometer, if you look at the group of cycles noted here in this circle, we start with higher velocities and we end up with much lower velocities, a wide margin of variation in excess of 30%. How about looking at the annular velocities? You see the septal velocities, early diastolic velocity close to 10, and a lower lateral velocity. That is not the normal setting, and also not the usual finding in patients with, say, infiltrative cardiomyopathy or just plain heart failure preserved EF. The lateral velocities usually exceed the septal. Here you see the septal higher than the lateral, a finding referred to as annulus reversus. Last quick case we will, so the findings in the case presented so far are consistent with pericardial constriction. This is somebody who presented with hypotension on no medications, shortness of breath. We do parasternal lung axis views. We notice preserved ventricular function, rather normal right ventricular function. Color Doppler doesn't show much of a valvular lesion. Short axis confirms the presence of a normal function. But once we go to the apical views, you clearly see this infiltrative material that is filling almost a third of the ventricular cavity. Again, you see it in the two-chamber view. And this is a subcostal view showing us the atria, the valves. We do not appreciate that clearly, the membrane that we saw in the apical views, but you get a hint that there may be something in the right ventricular apex. inferior vena cava showing us a dilated, non-collapsing inferior vena cava consistent with an increased right atrial pressure. This patient was breathing spontaneously, not on mechanical ventilation. A mitral inflow pattern that is consistent with pseudo-normal filling and increased left atrial pressure, and a small time velocity integral indicating the presence of a small stroke volume despite a preserved ejection fraction. The reason is the reduced ventricular cavity size and reduced ventricular filling with increased chamber stiffness. Annular velocities are reduced, markedly so, indicative along with the mitral E velocity of an increased left atrial pressure. So that's the hepatic venous flow showing forward flow only in diastole, the large velocity that you see below the baseline. So we conclude that this patient had increased both right atrial and left atrial pressures with evidence of restrictive cardiomyopathy, most likely secondary to a degree of eosinophilic infiltrative disease. Thank you.
Okay, thank you, Sharif. Those are great cases in the quantification of diastolic function. We'll change gears a little bit. I'll take you through a few cases of 3D TEE and show you how we optimize that for some of the cases and diagnostics that we do. Okay, so if you show my slides. Here we are. So one of the first messages is good 2D equals good 3D. And you can't take a data set that is unclear in 2D and hope that you'll have some clarity or magic imparted by going into the third dimension. It doesn't happen. So when the 2D is good, the 3D can be good. That's the first message. This is a little graphic to go through, particularly in the mitral valve, and that's where a lot of the effort is these days, is in the mitral evaluation. The message there is that you really have to set up the volume to capture just the mitral valve. So think of this more as being pre-cropped as opposed to being post-cropped. And this little blue box sort of demonstrates that. You have to set up the area of interest just in what you're interested in. And if you do that, then you get a volume data set that's there. You initially tip it forward, as this graphic displays, and then you have to correct it typically to put the aortic valve at 12 o'clock. So now it's at 3 o'clock, simply rotating it to 12 o'clock. And that's a preset on some of the vendor software. You can change that if you like, but that's it. And that graphic is just to demonstrate that the days of sort of crop till you drop are over. It's pre-crop, set up the shot, and then the rest of the effort is fairly easy. So you've seen this several times already throughout this conference. This is sort of the surgeon's view of the mitral valve. This is what you're trying to get to. And this is how you get it. So this is just a slide to sort of some tips on how to set up the shot. The first thing is the very far left image. What you need to do there is make the mitral annulus horizontal. Okay, and that means the apex is at the bottom. So really the goal is to make the ventricle as vertical as you can. That will make the annulus perpendicular to where the ultrasound crystals are. And if you do that, then almost always the image on the right, when you X-plane it, will be usually almost also 90. So it's not quite there, but it's very close. And this generally takes a little effort. This is slight manipulations of the probe depth within the esophagus, sometimes using the small wheel or the big wheel. In the interventional realm and with our imaging fellows, we spend a fair bit of time doing this. So the important thing is step number one, make a vertical ventricle and make the annulus perpendicular. That's 90% of the effort to get a good 3D. Once you've got that set up, you simply create the box. You have to determine the height and you have to determine the width. And that's just the box manipulation like we've always done with color boxes, but now you're setting up an area of interest. The image on the right already has its height defined by the image on the left. So now all you have to do is define its width. One of the important messages is the wider you make that, the lower your frame rate, or actually your volume rate, because it's a volume of data. So be very thoughtful in how tall your total data set is and how wide your data set is. That'll have a big impact on your volume rate. But that's really it. Those are 3 steps. Sort of 1, 2, 3. And that's how you get a shot set up for a 3D TE of the mitral valve. These are 2 different examples, a very normal valve on the left and a severely abnormal valve that doesn't matter if it plays. This is a severe rheumatic MS. The point of it is there's no cropping involved, right? That was the setup. you simply rotate the data set, spin it, and look down the gun barrel of the mitral valve. You can adjust if you need to the aortic valve position a little bit with a Z rotate button or with the trackball if you're comfortable with that. And that's how we do the valve imaging. Equally important for color. So if you're turning color on, it's exactly the same. You set up all the same things. Again, you make the ventricle as vertical as you can. You add the color, and so it's the same idea. That way, if you decide to go to 3D and then turn the color on or off once you're in 3D, it's very easy because you've set up the entire shot as if in one play. And this is really our working angle when we're doing, hours of mitral intervention. It's this. It's sort of 60-degree view, make the annulus horizontal, and then we hardly touch the probe. We simply toggle on color, toggle on 3D, and that's it. So be thoughtful about the total depth of your sector, and obviously the width affects frame rate of color and volume rate of a volume sector. And this is just a Z rotate to put the aortic valve at 12. One thing I haven't mentioned so far is that there is a gain setting you can adjust. If you have this sort of cloud of sort of blood mud or brown stuff in a chamber, you can just turn that down with the gain button. One thing to recognize is sometimes the color, as image on the right, can be a bit overwhelming. You don't know where it is. It's just far too much color. And this is a machine setting that's often overlooked, and that's simply adjusting the filter of the color. So this is just a different example of unadjusted filter. So the default tends to be fairly low filter on the left. It's a bit overwhelming. You're not quite sure what's going on. And all we do is go to the button, turn up the filter setting just a little bit, and now we can see enough detail to know that this is a mechanical mitral valve with a paravalvular plug that's been deployed. There's a tiny little area of residual PVL by the plug, and a couple of very small little washing jets down here. You could argue about the value of the quantitation of the color for things like vena contracta and whether the filter would affect that. It almost certainly would. But most of the time when we add 3D color, we're trying to localize jets, understand directions of jets, and separate how many jets are there. And there, the color filter setting can be very important. The valve area assessment follows a very similar concept. To do that, again, the effort is to make the mitral annulus horizontal in both views. What you're trying to do through a volumetric assessment of a native valve, or potentially even a prosthetic valve, is to find the narrowest portion. So we use these sort of X-plane lines. You identify the level that you want to draw the area. You draw the area trace, and here it is in this particular case, 4.1 centimeters squared. So without taking you through sort of a 5-minute example, that's the bottom line of how you do a mitral valve diastolic area determination at the level of the tips, not at the level of the annulus. Something to recognize is that we have several different post-processing ways to look at the valve to adjust the light shadows and the shading. Just as we learned when we started to learn how to look at the JVP, you can use tangential lighting to bring out shadows and help you see things a little better. Some of this is stylistic. Does it really offer new data compared to the classic 3D view on the top, these adjustable light source data? So I think that's to be determined. There's certainly a personal preference in how they look. The quantitative value is sort of being determined, I think. Finally, the aortic valve, we still have to look at that from time to time. Very similar principle. The idea there is you set up a long axis view, a simultaneous short axis view with the X-plane feature, and again, set a small volume data set. Don't capture the whole left ventricle, don't capture the whole left atrium. Capture what you need, and the tip is you capture just enough other stuff to be able to orient yourself. So on the aortic valve, you want to capture just a little bit of the anteromitral leaflet, or potentially the appendage, or the septum, something that you can tell up from down. And when you do that, you can capture an aortic valve. Not as frequently as a mitral. I would say you get good mitral imaging probably 95% of the time in most patients. Aortic valve imaging is more like 60 to 70% because there are patient-specific factors, particularly the relationship with the ascending aorta to the esophagus. But if you take the time to set the shot and making the ascending aorta about as horizontal as you can generally get a very nice view of the prosthetic leaflets. So these are the take-home points. Really figure out what it is you're trying to accomplish with 3D. You have to put the effort into making the 2D look good before you hit the 3D button. So set up the shot with the volume of interest. When you're using color volume, consider increasing the filter if the color signal is overwhelming. And that's really the short tips I wanted to share. Thank you.
Thank you very much, Steve. That was very educational. I almost feel like I can see one, do one, and teach one.
Good.
But the reality is it's not that easy. And I encourage everybody, when you're doing just regular TEs, you don't practice this, then when you have to use it in the real patient, it won't work. So what I like to do is show you one case to emphasize, again, some qualitative and quantitative aspects. This is a patient with a member of mitral regurg and progressive dyspnea up to class 3 presenting. So I'm going to show you, this is the way we look at echoes in our lab. This is the format that gives us multiple views, and then we can, of course, look at one view individually. So we're going to scan through it. You might be able to see already or not, this is a big ventricle, and we'll get to that later. Watch the heart, make your own judgment of what you think ejection fraction might be. Look at the mitral valve, and immediately you see this very eccentric mitral regurg jet. Certainly not mild. The question is, are we talking of moderate to severe, or severe? Because it's so eccentric, you know that the PISA would not necessarily be that good of a method for quantitation, because it would exaggerate the severity. TR, we can already see that there's a high velocity of TR, so there's going to be some pulmonary hypertension. Short axis view. Again, you can see the eccentricity. And watch this clip right here and look at the anterior leaflet and posterior leaflet and see what you think in terms of the dynamics of motion of those two leaflets. Short axis is very helpful because you see that this MR jet is spanning the entire circumference of that mitral valve, so that there's a lot of area of mitral regurgitation. In this, it's important here is notice that this is a 0.5 meters per second. So look at this RV outflow velocity tracing. Looks like a very lowish TVI, or time velocity integral. 4-chamber views, big atrium. Again, make your own judgment what you think is the ejection fraction and wall motion. I will open up one of these a little bigger. I think we can see that there is a much better contraction at the base, and these areas here are hypokinetic. And again, make your own judgment. We'll get to quantitative in a minute. Once again, you can see the, let me go ahead and make it bigger. You can see the eccentricity of that jet. So it was going posterior and laterally, and very nicely we can see that a little bit of that jet is sneaking to the pulmonary vein. Very nicely there. Transmittal inflow, kind of like a restrictive like high E, very tiny A velocity. And tissue Dopplers have some interesting findings. I'm not going to spend too much time in that. So just by qualitative one more thing. I think it's good to show the, this is the LV outflow. And again, notice this time velocity integral looks very diminished. So now let's do a little bit of quantitation. I'm going to just go back to clip 41 so that I can show you around here. So we're going to use this clip, and we're going to now go ahead and show you measurements. The LV outflow tract was 2.4 centimeters. The ventricle in terms of dimension, I can show it to you here, was 6.5, so clearly it's a pretty large ventricle. Shortening fraction was 20%. And we get down to the volumes, and the end diastolic volume was 274 cc's. Now, one thing we have learned in comparing echo with MRI is that we were in the past frequently tracing too much inside the little trabeculations of the ventricle. And we have learned now to be able to get results that match MRI better is to go a little bit more outside. So when using that technique, we go 274 cc's in a single plane, in end diastole, and in end systole, we got 156. And again, you can see a little bit of that better movement at the base of the lateral wall compared to the middle segment. So that the ejection fraction was 43%, and the stroke volume in that one beat was 118 cc's. Now, we also did biplane, and using biplane, we got an end-diastolic volume of 284, an EF of 44%, and a stroke volume of 124. So 124, 118, those are not that different. Those are big stroke volumes versus an integral of 9.9 in the LV outflow that, despite having a pretty decent LV outflow dimension of 2.4, gave us a stroke volume of 44. So you don't have to do any fancy mathematics to see that this is very severe mitral regurgitation, regurgitant fractions in the 60% plus. So the interesting thing about this patient, I'm going to take you back to the images, I'm going to ask Steve to make some comments, is this a case of valvular mitral regurg, perhaps a prolapse of the anterior leaflet that we're not seeing too well, with a ventricle that is going downhill? Or is this still a myocardial disease ventricle, perhaps ischemic, with functional MR, but because of the dynamics of how the mitral valve moves, this jet is very eccentric and very severe? So, Steve, what are your thoughts on that?
So thanks, Dr. Fabulous case. I mean, it highlights so many important issues. To your specific question, I think if you look at the anterior and posterior leaflet and where they come together, it's very, very telling. So, we want to see two leaflets come together and create a symmetrical coaptation zone. And there's really only two scenarios when that doesn't happen. The first is true prolapse, where one of the leaflets moves to at least 2 millimeters past the plane of the mitral annulus. If you were to freeze this and identify the mitral annular plane, that anterior leaflet does not extend past the plane of the annulus. So this is not true prolapse. What this is properly called is end-to-side coaptation. So the end of the anterior leaflet is really touching, and perhaps even in this you're not touching, but getting close to approximating the side of the posterior leaflet. It's also been termed pseudoprolapse, which is a poor term because it confuses people.
Yep.
But it isn't true prolapse. Pseudoprolapse is a term to avoid. The best description of term, this is an end-to-side coaptation. But what that means and why does the term matter? It matters because it tells you that there's tethering. There's tethering of asymmetric tethering, more so of the posterior leaflet, but probably still some tethering of the anterior leaflet, and that creates a very eccentric MR jet. Recognizing that is important on the algorithm of MR quantitation. Yes, we care about the severity, but we also care about the mechanism very much. So you have to recognize why is this happening. And in this case, if you take the time, you see end-to-side coaptation with an eccentric jet, you should ask yourself, why is there an eccentric jet? What's going on? And then more subtle than the MR in this case is the wall motion abnormality. So there are times that in trying to answer the question about etiology of the MR, you actually then secondarily identify a wall motion abnormality that might have been missed. And then there on the 4-chamber view, there you can the 5-chamber shows it a bit. I think the 4-chamber showed it even better, that there is a lateral wall motion abnormality that if you were to cath or sometimes we'll do a CMR in these scenarios, you'll see very clearly that there's regional dysfunction.
So we do not need another test for severity. The question is would we gain any more information in planning procedure or whatever by doing a 3D TEE type of assessment?
So that gets into your therapeutic choices. If you were going to, entertain a therapy for this patient, symptomatic, you would have a discussion around surgical therapy or transcatheter therapy. But you wouldn't need a TE to understand the mechanism. That's very nicely defined already. Mm-hmm. You don't need a TE to help with severity. The severity is clear, and generally TE does not give you additional severity information. You might need a TE if you were planning to do an edge-to-edge repair in this case, and this is, I would say we would probably not bring a patient in to do a TE just for this. We would do the TE at the time of the procedure because the etiology is so very clear. There's no calcium. We're not concerned about contraindications to the procedure in this case. But this probably, if the surgical risk were high, this would be I predict, a good anatomy for an edge-to-edge repair.
Great. Well, time flies fast. So this is the end of this session. I'm going to transfer over now to our colleagues.
Okay. So good afternoon, everybody, and welcome to the CT reading session. I have Dr. Leipzig with me and Dr. Chamsi Pasha. And we're just going to go through a couple of cases and show you how CT may be helpful in your general practice. So I'm going to have Dr. Pasha present the first case, and we'll kind of go from there. Okay, I'll tell you what. Why don't I show you a case, and we'll go from there. So first of all, let me share my screen.
Would you like me to go first, Dr. Mahmarian?
Yeah, go first.
Yeah, sorry, I just joined.
Yeah, go ahead and I did the share screen, but it didn't seem to work. Okay, go ahead.
Okay. Okay, let me take off the, are you guys able to see the screen?
Yes, now I see your screen. Go ahead.
Okay, so good afternoon, everyone. We're going to go over an interesting coronary CT case. Read with the expert session. Glad to be with Dr. Mahmarian, my mentor, along with Dr. Jonathan Leipzig, a phenomenal CT expert. So this case basically starts with a 39-year-old male gentleman who has had a history of asthma and a prior COVID-19 infection. He basically came in with retrosternal chest pain one day after the second dose of a COVID vaccine, and we're not going to tell you what vaccine he got. His risk factors, basically, he's a former smoker, quit many years ago, no family history of coronary artery disease. His blood pressure, his vital signs are stable. His exam is unremarkable. His EKG shows normal sinus rhythm with no STT wave changes. His troponin initially was 3 at the point of care, was basically had bumped up to 8. And this is the old troponin T, not the high sensitivity, with a nanogram per milliliter is the unit. And his LDL was mildly elevated at 118. He had an echocardiogram for chest pain evaluation and basically showed normal LV systolic function and no wall motion abnormalities. So the decision-making, basically what this guy who had quote-unquote low pretest probability for coronary artery disease, and to proceed with a coronary CTA, giving the high negative predictive value of this diagnostic tool. So the scanner, we're lucky to have the dual source Siemens CT scanner, which as you can see has 2 sources, an X-ray sources or slices of detectors, multi-detector, almost 192 is the number of detectors we have on the Siemens scanner. And the way we decided to image this patient because of his young age and to minimize radiation was to use a high-pitch ECG-triggered helical CT. So what we do basically is that the X-ray beam is always on in a spiral fashion, very similar to what radiology do. And this is a single cardiac cycle acquisition with very great temporal resolution in the 60 to 80 milliseconds and a very low radiation dose, close to a 1 millisievert. We're able to image the entire heart with a single heartbeat. This is basically what the Siemens call the high pitch mode, where basically the table feeding is actually very fast, and actually the scanning speed is at 87 centimeters per second, and we're able to acquire all the data in a single cardiac cycle acquisition. This was the axial view of the patient. So this is the ascending aorta. This is the main pulmonary artery. You can see here the beginning of his coronary start with the left main, which actually looks patent, and it basically bifurcates to an LAD and a circumflex. And you can actually notice here in this proximal LAD, he has a calcified plaque in this proximal LAD, and then the circumflex is going to continue all the way down. And there is you can appreciate that there is a little bit of blurriness in the not only in the right coronary artery, which comes off here, but also in the circumflex. And that usually occurs in the setting of coronary motion during the single phase acquisition. If you notice and follow up the circumflex down here, you actually notice that there is an area where the lumen becomes severely narrow. And if you notice that the right coronary artery here, you also have an area where almost you lose the contrast resolution in this distal right coronary artery. So what we did, basically, we actually created a curved planar reformat. So this is the aortic root, left sinus of Valsalva. This is the left main. This is the stretch of the LAD from the ostium all the way down to the distal segment. You can see the mild calcified plaque, but really no significant stenosis in the LAD. This is actually actually his circumflex was reconstructed in this phase. You can see there is a little bit of motion in this proximal segment with this blurriness extending across the vessel, but he looks like he has a high-grade luminal narrowing actually in this mid circumflex, which actually we did look at it at another phase on this patient where he had kind of two flashes, and we actually still appreciated this high-degree stenosis in his mid circumflex after the obtuse marginal. This is actually a kind of rotating curved planar reformat of the circumflex image, and no matter angle what you look at, you actually appreciate the high-degree stenosis right after obtuse marginal. This is a three-dimensional volume rendered image of his circumflex, again showing basically the tight lesion after the first obtuse marginal. And to add more to the complexity of the case, this is a stretch out of his right coronary artery in a curved planar reformat. And we actually noticed that he actually has a subtotally occluded distal right coronary artery along with his high-degree stenosis of his circumflex. This is, again, a curved planar reformat of the right coronary artery, largely non-calcified plaque with a very spotty calcium within this lesion, all denoting high-risk plaque features because it's all lipid-rich plaque. The CT-FFR was done on the LAD and basically showed the normal value. And basically, he had the totally occluded, subtotally occluded right coronary artery for which the CT-FFR was not available. Notice that he had a small diagonal with an FFR of 0.85. The invasive coronary angiography correlated really well with this coronary CT. He has a large circumflex with large obtuse marginals, almost 4 OMs. And right after the origin of the second obtuse marginal, you can actually see the 99-degree or the 99% stenosis in this mid-circumflex lesion. And he also was noted, along with what we saw in the CT, a subtotally occluded distal right coronary artery. It was felt basically because the circumflex, what was the culprit vessel? The decision was to proceed with a stent of the circumflex because the large caliber vessel, the guy did not have a large troponin elevation, suggesting that the right coronary artery might be a silent disease rather than an acute culprit unstable plaque. And basically, that was the decision to treat that circumflex with a synergy stent, drug-eluting stent 3.0 by 16 millimeter. Ischemia-guided management to look at the right coronary artery was performed, and we can actually see a small size, medium severity, basal inferoseptal, completely reversible perfusion defect. Incidentally, he also has a completely reversible small size perfusion defect in his mostly mid-anterolateral segment, as we can see on this PET perfusion imaging, where the stress is on top, the rest is on bottom. So he clearly basically had ischemia in his diagonal along with his RCA. The total perfusion defect was 15%, of which 13% was ischemic. With PET, we're able to calculate myocardial flow reserve, and it was actually reduced to 1.8 in the region of the RCA perfusion defect. Hence, he underwent a stent to his distal right and was discharged home. On relook of his diagonal was a small vessel, which looked like had a 50% stenosis, and the decision was to treat it medically. This resonates with what Dr. Leipzig shared with us in the grand round a few days ago about the 2021 chest pain guidelines, and really what favors the use of CTA to rule out obstructive disease, detecting non-obstructive disease. Usually people who are young, they'll have less calcified plaque, and or if you really need to look at other compelling indications for people with chest pain like pulmonary embolism or aortic dissection. And basically, this is where people with acute chest pain, coronary CTA has a class 1 indication if you do not have any prior testing. And basically, if you have an obstructive CAD, then you actually would decide if this is a high-risk coronary disease or frequent angina. These people will go directly to invasive coronary angiography. If not, you can consider either a functional testing or a CT-FFR. Both were done in this case. And obviously, if the patient has significant ischemia, then invasive coronary angiography for further management would be indicated. So the final teaching point and final slide is coronary CTA can be used as a first-line tool to rule out obstructive disease. Still, common things are common, and myocarditis would be a rare side effect from COVID-19 vaccine. And I thank you for your attention and happy to take any questions.
Maybe Mohammed, I could ask, that first of all, very elegant study, nice case. The technology obviously allows for, the high pitch helical acquisition and significant radiation dose reduction. I think as you highlighted, though, separating those areas of abnormality for motion very elegantly, highlighting that the presence of atherosclerosis, which you could confidently identify in the circumflex, I think was very telling. What was the heart rate of the patient? Because there was a fair bit of motion. What is your threshold heart rate above which you will not use high pitch helical, where you would want to go to a different scan acquisition?
So I remember his heart rate when he was at the scanner was 60, but some of those young patients with the contrast administration, with the inspiratory breath hold, their heart rate do go up. So it will flash. So we basically get the first flash in a systolic, so around 30 to 35% RR interval, which is right at the isovolemic relaxation time. And then we acquire another flash. Basically, we go the opposite way, so caudal cranial at a 65% RR interval. So if we have motion in one segment, we're hoping that the second acquisition would be of a less motion, but his heart rate was variable because he did have sinus arrhythmia. Historically, we've done flashes with decent image quality in the heart rate between 60 to 70, but obviously the slower the heart rate, the better for a diastolic flash image.
Thank you. John, you're on mute if you're...
I think Dr. Mahmarian, you're muted.
Not anymore. Okay, so I tell you, technology, right? But I totally agree with your comments, Jonathan. I mean, motion is always contentious, and I tell you, I am very hesitant to use flash technology unless I'm really pretty sure this is going to be a normal patient, or I'm pretty sure that the rate and the rhythm are extremely stable, because a pitch of 3, you're extrapolating a lot of data. And, in a case like this, I probably would have actually done intervals over the T wave and had a more comprehensive exam, because when you run into motion artifacts like that, it becomes very difficult sometimes to determine what's real and what's not. And of course, it affects, and if you don't have good images, it's very hard to really assess from a FFR point of view or from any point of view in terms of even just visual interpretation. So, it's in one way you may save radiation, but in the other way, if you don't get the answer you want, it makes things difficult. Okay, well, very nice case. Let me attempt to share my screen again. Yes. Okay.
Yes.
So this is a case of a 65-year-old patient. She actually had a CT because she was going to go for a mini maze procedure. She had atrial fibrillation, and her BMI was 40. So again, a kind of a difficult study to maybe interpret. The whole purpose of the study was to be able to look at her left atrial appendage, potentially look at her coronaries if possible, although she did have a prior stress test about 6 months earlier that was normal, and clear her for basically having a mini maze procedure, which, as you all know, is very minimal in terms of just it's all robotic, and it really is a minimal surgical endeavor. So this is her CTA. I'm bringing up the systolic phase because it was probably one of the better ones. And what I like to do when I look at a CT is first go through the axial images and kind of get a feeling for things. So first of all, when we look in the axial images, here are the lungs on each side. Here's the aorta. And, on every single case, of course, we always measure aortic sizes and such, which we can do here too, a normal aorta, normal distal descending aorta. The pulmonary artery was minimally enlarged at 3.1. This is the superior vena cava here. You can see this is the left atrial appendage. We did do a delay on this patient, which we always do, a 20-second delay just to make sure everything fills in. But this actually appendage looks pretty clean here. So that all looked good. This is her left main. She has some plaquing in the LAD. I'll show you some other pictures of this. This is her LAD. And this is a small circumflex over here, the right coronary. And of course, one of the things we always look at when we do CT, obviously, is where these coronary arteries come off to make sure they're in the right place, to make sure there are no anomalies. And the left main comes off the left sinus, as you can see here, and the right coronary artery comes off the right sinus, as it should. And just coming down here, this is the left atrium. This is the septal wall. You can see that it's intact. There's no evidence of an ASD. This is the ventricular septum. It looks intact here. This is the mitral valve. I tell you, I think CT is getting very good at being able to look at structures like this as well by thickening the slices. And I mean, we can usually get a pretty good look actually at the mitral valve as well in terms of how, oops, let me see if I can move this a little bit. Here we go. You know, usually we just manipulate around the valve and are able to get a fairly good visualization of the valve leaflets.
Yeah, especially if you use, as you mentioned, a minimum intensity projection and you
exactly.
Yeah, so you can accentuate the leaflets, and obviously we use it routinely for timber planning and annulus segmentation.
Yeah, Jonathan, I think CT is extremely helpful in this area, and this is in systole, and the valve is basically closed. And so it's actually a pretty nice, considering our BMI and everything, we got pretty nice pictures. This is actually the tricuspid valve over here, as you can see. And there's a pacing lead going through. And let's go back. We also can look very nicely at the aortic valve. And obviously, for TAVR procedures, we do this routinely. Again, this is a systolic phase. And I think you can see very nicely the outline of the aortic valve. And again, pretty nice pictures considering the size of the patient. There's no evidence of aortic stenosis. And what we typically do here is we planimeter the area, just to kind of give you an example. We go around here. This is going to be very crude and quick. But as you can see, the valve leaflets are wide open. The area is like 3 centimeters squared. So totally normal valve. And so this is even before we do anything else. I mean, we kind of look at all these things. So the ventricular septum, the right ventricle is over here. You can see that pacing lead going through the tricuspid valve. And it didn't look like there was actually, this is systole. When we were looking at that, it didn't look like there was any leakage. It looks like the valve totally closed, as if there was no tricuspid regurgitation. And of course, then the last thing we look at is the pericardium. And over here, we see an effusion. Okay, and it turns out that that's about 30 Hounsfield units in terms of the size of it. So that's kind of an overview of the morphology. Let's see. You can see up here. So here's the RV lead. And it sure looks like it's going out into the
epicardial space.
Exactly. So yes, indeed. So just to make a long story short, this was on a Saturday morning. I read this and I called the surgeon. She was supposed to have surgery on Monday morning. And she was supposed to have a mini maze. Instead, they decided to do an open thoracotomy, a sternotomy. And when they opened up the pericardium, she had like 250 cc's of blood in the pericardium. And that lead was poking out into the pericardial space, right where we said on CT in the right ventricular outflow tract. And I just want to highlight this case because, frequently with CT, we see many, many things besides what we're actually looking for. And it's imperative that we keep our eyes open because basically, CT shows everything. It's just a matter of us being aware of what we're looking at. And in many respects, this study was incredibly important because it changed her entire procedure. and the lead was taken out, and the puncture hole was fixed, and she got her mini maze. So any other comments about this case? Can you all still hear me?
Sorry, I was on mute. I was on mute. No, I mean, I think that as we were discussing before we went online, and I know we're wrapping up here,
yes.
That CT is an anatomical test. So if you have an anatomical question, there's, in my humble opinion, no better tool to answer such questions, whether it's a mass, whether it's an infective endocarditis, with implanted devices, whether it's obviously structural heart disease, transcatheter aortic or mitral valve, or in these cases, we see them. These are challenging, though, as you point out, John, because of the significant beam hardening, as you can see in the streak that relates to the tip. And so, I think it's really, I'd be curious your thoughts, and obviously Mohammed's as well, but the integration of both the clinical presentation, so not overcalling these findings, in the absence of pericardial blood, in the absence of device malfunction. So really integrating all the information. I think the way you handled it is exactly, it's thoughtful. It's not in isolation. It's a combination of findings.
Absolutely. I think that's incredibly important point, that the fact that, it's never just about images. It's about putting everything together and making a clinical decision when you have cases like this, because, I mean, you're making a major change in how these patients may be evaluated and treated. So, but I think it does show the point, and we see this, like I said, we see this all the time where we pick up a lot of different things that are clinically relevant on CT that really were not the major reason why the study was done.
All right. Jonathan.
So I think I'm going to leave it at that.
And then from an imaging standpoint, I mean, I've been.
Well, Jonathan and John and Shamsi Pasha, great. Thank you for a great session.
One comment,
here.
Dr. Mahmarian, but
thank you for a great session. I have with me here Dr. El-Talawi, Carlos El-Talawi, one of our multimodality imagers. So we're watching actually your sessions, and at the same time we were watching your questions. So whenever you send us some questions, I think it would be great for us to relay them to the discussants. Our next topic is cardiac MRI, and will be discussed by Dipan Shah, Michael Salerno, and Dr. Faisal Nabi from our team here. So over to you, Dr. Shah, Dr. Salerno, and Dr. Nabi. Great to have you again.
I think we're just waiting for Dipan.
The mic.
Yeah.
One more time.
I'm lost in cyberspace.
Can you ask him to start one more time?
Yes, go ahead and get started. I think.
Can you guys see us? Can you guys see us right now?
See you, and we can hear you. You'll come up. Here you go.
Okay, I don't think we have Dipan right this second, but I could share my cases first then.
Sounds good, Dr. Salerno.
I don't know why we all right, let's see. All right. Can you guys see my screen?
Yes.
All right, perfect. So I'm going to go through a couple of quick cases here. This is a 58-year-old female that presented with to the emergency room with dystonia exertion, orthopnea, PND, lower extremity edema. She had JVD and 3+ pitting edema to the thigh. Her total protein was elevated, borderline elevated in troponin and BNP. So here is her echocardiogram, and the echocardiogram, you can see she has pretty normal looking LV systolic function. Here is the measurement for global longitudinal strain, which was all normal in the high 20s. So she went on to have an MRI, and here's her cine MRI images. Her LV function looks pretty normal. If you look very subtly, you can see a couple of things of note here. There's a little bit of a pericardial effusion. And if you look here, you can see that there's left atrial wall thickening on this two-chamber image. And here is her native T1 was elevated, although not very, very markedly elevated. Our normal is around 950, so this is about 100 milliseconds long. But really notably, the ECV was quite high, measured at 0.49, and her LGE showed diffuse, a pattern of diffuse fibrosis, as well as atrial late enhancement. So she went on to have a SPEP-UPEP that showed a spike in the IgA lambda monoclonal protein. She had proteinuria, and her renal biopsy showed 66% plasma cells, consistent with lambda restriction and AL amyloidosis. So this is really a case where the echo was really kind of unrevealing. I think they got referred for the MRI because of the elevated protein and a question clinically of whether or not this could be cardiac amyloid. So just along with this case, CMR really should be a first-line test in evaluating patients with suspected amyloid, and it provides unique diagnostic and prognostic information not available from other modalities. Guys, any comments on this?
Yeah, so, this is a very interesting case. And I don't know if anybody's actually reported this or looked at this systematically, but, this is a case where there's not a whole lot of increase in wall thickness, even on the CMR scan. And probably the global LV mass is not that increased. And it seems most of the time when I've seen this, where you see this LGE pattern, it turns out to be AL, amyloid. Whereas I think ATTR tends to give you much more of the classic, increase in wall thickness and all the echo findings as well. So I think, again, this is, as we're seeing amyloid much more often, I think we're learning more about it as well.
Yes, I think it goes with that, having a really low level, really high level of suspicion and low threshold to get it. And that's been my experience also. A couple of cases where we weren't really sure that didn't have much wall thickening. Most of them had an elevated ECV, and even the LGE wasn't super, super impressive. The couple of these cases have turned out to be AL amyloid. And what we've done when we've read them is essentially said that, to consider the rest of the workup for amyloid.
Yeah.
The other thing I want to show kind of really quickly here is really a follow-up to Roberto's comment yesterday about his case. This is a 77-year-old male, history of ischemic cardiomyopathy, antiphospholipid antibody syndrome, who presented with an infarct. His brain MRI showed multiple acute strokes. Here's what we saw in his echo. So there was a mass that was along the area near his papillary muscle. And by MR, this is actually a post-contrast cine. You can see that right next to the pap muscle, there's something that lights up really bright, even on cine. It was dark on first pass perfusion imaging. And then when you look here on late enhancement imaging, it's very bright. And so that's pretty characteristic for what you would see with a papillary fibroblastoma, although really odd location. So given his strokes, this was actually removed and showed up to be a papillary fibroblastoma. And then about basically a month later, we had another case, 57-year-old female with a history of Sjogren's disease, melanoma, cancer, and she presented with right-sided paresthesias and had multiple infarcts as well. And here was her echo. And again, much more like that case that was shown by Roberto yesterday. There's a very subtle mass here, kind of attached in on the papillary apparatus. And it was thought to maybe be thrombus, but she was sent on for an MR. In the MR, it's actually very subtle to see. You can see part of it here attached to the apparatus. You can see another little piece of it here on this pap muscle. And without the echo, it'd be very hard to see. You can see another little piece of it here and there. And then when we look at the late gadolinium enhancement, again, there's a very focal, very bright area adjacent to this pap muscle. And again, this one turned out to be a papillary fibroblastoma. So these were just two cases of for people presenting with a stroke, we usually think about these as being on the valves, but much less likely they can be in the ventricle. So again, guys, any comments about this?
Yeah, no, I think these are great example cases, and I think it kind of highlights the fact, with MRI, the ability to do this tissue characterization in patients that come in with stroke, I think oftentimes can give you a lot of additional insights. And it can help because oftentimes if you find there's thrombus, you can just simply treat with anticoagulation and prevent the patient from having to go for surgery, altogether.
I like these cases. I have a very similar case to show you with tissue characteristics that are very different. So it'd be nice to show to show everyone.
That's awesome. It was good. After seeing one of a very rare thing, this other one happened. It must be 3 weeks later. And I was like, I know what that is. It's a capillary fibrillation.
These masses
that was my moment in the sun.
Seems like these masses come in series,
Yeah.
Okay. So let me. So I'm going to present a couple of cases here, and I think one of the things I want to kind of touch on it, and I think Michael very nicely showed, is this ability to do tissue characterization by MRI, which I think is made possible by this unique ability to image both viable myocardium, as you can see black here, as well as image myocardial damage, as you can see here in these bright areas, is I think what sets MRI apart, I think, from most other imaging modalities, is this is one unique feature I think the MRI has. And then the ability to have the resolution that you have with MRI, where you can actually not only identify that there's damage to the anterior wall or the septal wall, but actually localize whether it's in the middle of the myocardium, as in this case, whether it's epicardial, or whether it's subendocardial, but it doesn't fit a coronary perfusion territory. So these are the things that you want to look at when you look at MRI images and when you look at delayed enhancement images. So let me start off with a case, and then I'm interested to get commentary from Faisal and Michael on this from a management standpoint. So this is an 18-year-old gentleman who was admitted to an outside hospital with chest pain, which he noted to happen about 2 weeks after he had a viral illness. At that hospitalization, where he was just kept for a couple of days, he had a peak troponin of 13.57, and this was a troponin I. This is a case from about 4 or 5 years ago, so this is not the ultra high sensitivity assay. The echo was reported to be normal with the EF of 55 to 60, with some mild left atrial enlargement and mild MR. And this was the EKG that I was able to get a hold of from that hospitalization, which again really doesn't show any significant abnormalities. So then about 2 weeks after his discharge, his cardiologist there referred him for a CMR scan. And I think what they were concerned about, I think, was obviously, MINOCA, I guess, myocardial infarction with normal non-obstructive coronaries, because he did undergo a CTA there just to exclude, any epicardial coronary disease. The Sydney CMRs are shown here, and you can see that really, whether you look all across, all of these sequential slices, LV function looks quite normal. There's not any focal areas of Walmosh abnormality. And from a global standpoint, his EF is 62, his LV size is normal. His RVF is a little bit on the lower limits of normal, and his RV is a little bit enlarged. But again, this is a young person, as you always want to be careful in calling RV enlargement in young people. But here's his delayed enhancement MRI, and you can see these areas of high signal, this hyper enhancement here in the inferior wall, both in the basal short axis views, as well as on the long axis 2-chamber and the long axis 3-chamber view. And again, this is not something that would fit with myocardial infarction, which should start in the subendocardium and work outward. This is more of an epicardial pattern and doesn't really fit with a coronary artery distribution. And therefore, the presumptive diagnosis in this young patient was that of myocarditis. Now, with normal LV and RV function and myocardial LGE in the inferior wall. And this is a gentleman who's planning on starting college in a month. So this was somebody that we saw over the summer. So the question really, I think, for Faisal and Michael, here's the issue. We're in Texas here, and football is a big thing. This guy was a football star at his high school, quarterback, and he had a scholarship at a Big Ten university to play football. So the question he's coming for a second opinion to ask, can I play football? So I'm curious how you guys approach a case like this. Faisal, you're unmuted. Do you want to go, or Michael?
Well, at least my thoughts are this is a difficult situation, no doubt. And I'm glad he came to your clinic and not mine. But, yeah, I mean, there's a risk. He has scar. The myocardium is no longer normal. And, there could be a risk of an arrhythmic event. Now, that risk we all know is probably likely very, very low. And this can be a career-changing, diagnosis for him. And the implications of it can be very life-changing for him. So, I'm not up to date on what the most recent guidelines are. I don't know if we should exercise him in the office, try to get a feel or put a monitor on him, see if we can pick up non-sustained VT. These would be some of my initial thoughts.
Yeah. I think taking a lesson out of what, a very large athlete study with respect to COVID myocarditis. Now, again, it's different, but I would probably re-image this guy in a few months, in maybe about 2 to 3 months. I would consider whether or not to monitor him. Maybe in these days, something like a Zio patch that you could have on him, and probably have him take a little bit of time for acute recovery of this. Fortunately, this is a fairly small amount of late gadolinium enhancement, and some of these, when the inflammation and scarring gets smaller, they'll have quite a small amount of residual scar. So I'd probably have him take a little bit of time off, plan to monitor him, and re-image him, and then make a decision.
Yeah,
we've seen cases like this as well, and it's always very tough when they're an athlete on a scholarship, which is, I always feel a little bit like, when we have to image one of them, that might find something.
Yes, exactly, and that's exactly what our thought was. And obviously, we had to sit down with him and talk to him, and then his kind of primary cardiologist, because he came from a ways away, to say, based on this, clearly we know that there has been some myocardial damage. At least we made a diagnosis. This looks like myocarditis. There has been some myocardial necrosis. And so what we ended up doing with him was, his primary cardiologist did a stress test on him at that time. He had some occasional PVCs, despite the fact he had pretty good functional capacity. He got a 48-hour Holter monitor, which again showed a small PVC burden, so not a huge amount. And then he had a follow-up troponin level that was done. This is probably about a month now from his index event, which was normal. So it gave us some reassurance. But again, I don't think any of us were comfortable saying, yes, he could go and play Big Ten sports. So we kept him out for that first semester, the fall semester. He came back for follow-up imaging when he was here on his fall break. And his MRI showed no progression in the LGE. His biomarker stayed normal. And on follow-up exercise and Holters, he had no further PVCs. So at that point, then we released him. This is the follow-up scan, which looks very similar to the original. And what you're really looking for is that there's not any progression in the amount of LGE from baseline. So in the absence of arrhythmic evidence at about 5-6 months after his index event, and the absence of biomarkers, he was then released to go back to Big Ten sports. And we haven't heard from him since then. So that means, I think, hopefully he's doing well. And I think, this was a case from a few years ago. Fortunately, there are some guidelines now that are out there. These are European guidelines from 2019, which really, I think, basically say the same things as what we talked about, which is that, in these competitive athletes, you may want to do 3 to 6 months of a duration of withholding, aggressive exercise or competitive sports because of a concern for arrhythmic events. And then I think in his case, the good thing was his LV function was normal. He had, some mild RV dysfunction, but again, in these athletes, oftentimes they can have kind of an enlarged RV with kind of low normal EF. And then, for his case, again, reliance on EKG monitoring, exercise stress testing, and then biomarkers. And now, especially now that we have these very high sensitivity troponins, I think if those are normal, you can be pretty confident that there's not ongoing myocyte damage. But again, I think these are the types of cases that always are a challenge, not only to make the diagnosis, but also to figure out how to manage the patient. So this next case I'm going to go through really quickly here because Michael presented a very nice case of this yesterday.
One quick second,
Sure.
Just as a final comment about that is really the fact that I'm sure you've learned and been humbled before that when people come in and they have a troponin elevation and you don't figure out the answer on cath or CT, MRI is really indicated, and which is now actually in the new guidelines for MR to look for Minoka and also to look for myocarditis. But go ahead.
Yeah, I think you're absolutely right. I mean, because I think right now it's the most sensitive imaging test that we have to identify myocardial damage. Okay, so next case I'm going to go through really quickly. 44-year-old woman who, with no past medical history, she presented to the emergency department with 2 episodes of syncope, notes and progressive dyspnea for 6 months, was bradycardic on exam, but otherwise normal. EKG here shows complete heart block. And I'm just going to show you quickly all of the MRI images where you notice a few things. One is there's increased wall thickness here in the septum, increased wall thickness here in the anterolateral wall. And also, if you look at the RV, there's increased wall thickness in the RV as well. On the LGE images, you see hyperenhancement here in the septum, hyperenhancement in the anterolateral wall, and also hyperenhancement in that thickened area in the RV as well. And on T2-weighted imaging, you see increased signal in those 3 areas. This, coupled with extensive mediastinal adenopathy, really, I think, leads to the diagnosis of cardiac sarcoidosis. And so this constellation of findings, we said, suggests cardiac sarcoid. This person actually went on to get a biopsy, and the biopsy did confirm, in fact, finding consistent with sarcoidosis. And I think, as Michael touched on, yesterday, it's important to keep in mind, especially in a young patient who presents with syncope, VT, unexplained heart block, or heart failure, that you want to think about sarcoidosis. And again, the way that we see these patients in the MRI lab is sometimes there are people that have known extracardiac sarcoid. They're sending them to you to say, is there cardiac involvement? But oftentimes it's patients that are just coming in with new onset cardiac symptoms. And really, it's our job to kind of be tuned into this. And then oftentimes it's the MRI lab that's actually raising the possibility of cardiac sarcoid. So that was a case of syncope. I want to present now another case of syncope. This, again, is a young woman, 50 years old. And she comes in with new onset 2 episodes of syncope. She also has no past medical history. Her initial EKG is shown here, which, other than maybe a little bit of an incomplete right bundle, doesn't really show much. There's no significant T wave or ST abnormality. She has a workup that's scheduled. And again, this is a patient who's being seen by an outside cardiologist. He orders an echocardiogram and a 7-day Holter monitor and plan to see her and follow up in a few weeks after that. Here's her Holter, which, obviously, whenever these Holters show abnormalities like this, the office will get alarms beeping. This person obviously, went in to see the cardiologist right away based on evidence of episodes of ventricular tachycardia, multiple episodes, some as long as 18 beats, and a total PVC burden of 6%. So at this point, she hadn't got the echo yet. The cardiologist called me up and said, "Hey, can you get her worked in for an MRI? Because I'm, concerned about structural heart disease or RV dysplasia." So here's the MRI scan. And so I'm going to show you the entire scan here. So again, these are a series of short axis views that we have, and then the standard long axis views. Right off the bat, what you want to look for is, what is the overall ejection fraction, which in this case looks pretty normal. And are there any kind of focal or regional wall mush abnormalities, which in this case also I think would be hard pressed to identify any clear-cut wall mush abnormalities in this patient. And RV size and RV function also look relatively normal as well. But there is obviously one finding here that's not normal. And that is, if you look at the mitral valve, one is there's a mitral regurgitant jet that you see here. And you'll notice this jet is a temporally variable jet. It starts off very little, and then it accelerates and becomes much more. And also, if you look at the mitral valve leaflets, if I show you this view right here, you can see these leaflets are actually billowing both the posterior as well as the anterior leaflet. And you can see this also in the 4-chamber view. And then you will notice, if you look very closely at kind of the subpapillary apparatus, it does look like maybe there is a small little wall mush abnormality in this area right here. And you almost, on this 3-chamber view, almost looks like there's a tiny little microaneurysm or an outpouching here. So when we scroll down to look at the delayed enhancement images, what you notice is there's hyperenhancement here in the anterolateral wall. You can see it in the short axis views at the base. You can also see it on the long axis views here on the 3-chamber view, as well as on the 4-chamber view. So you put all of this together, obviously I think this, scar can be a substrate for ventricular arrhythmias, but I think more interestingly is the fact that what is the underlying valvular abnormality here? This is a person with bileaflet mitral valve prolapse. And so let me go back to the images. I'll show you how we quantify the severity of the regurgitation as well. We looked at the LV stroke volume in this patient, which was 109 cc's, and then the aortic outflow was 79 cc's. So that difference represents about 30 cc's of mitral regurgitation, regurgitation fraction of 28%. So really kind of mild to moderate MR, but obviously you've got a patient who's got scar in this area right here in the infralateral wall. And then also if you look at this 3-chamber view right here, you notice there's almost a paradoxical motion of the papillary muscle, right? So normally the papillary muscle should descend down towards the apex, and instead the papillary muscle in this case during systole is actually getting pulled up by these large billowing leaflets. And then the other question obviously is, there's actually a volume of blood that's in this kind of what we call the prolapse volume right here, where it's not actually transecting into the left atrium, but it's clearly being pushed by the left ventricle. It's just that it's not going out the aorta. Instead, it's just kind of being harbored underneath these leaflets. And that blood volume then is going to be circulating back and forth. So, I think, based on these findings, it looks like this is a patient that has a condition that we shouldn't miss or forget about when you're evaluating patients with syncope, because oftentimes we think of sarcoid or myocarditis or some of these other conditions. But I think mitral valve prolapse also does have a malignant phenotype. And there's data showing that it can be associated with myocardial scar and maybe a marker for arrhythmic risk. So this person actually, based on the extent of arrhythmias that she was having, she went on to CEP, underwent a prophylactic ICD placement, and then it turned out within about a year after the ICD was placed, she's recorded as having a true episode of monomorphic VT at 193 beats per minute that was successfully terminated with ATP. And then she's had no recurrent syncopal episodes since then. She was put on beta blockers at the time of this index syncopal episode to begin with as well. So I think, for this case, I think, a couple of things I want to point out. I think there's now several studies in the literature, this one from Cristina Basso and the group out in Italy, which really showed that in patients that died of sudden death under the age of 40 who had no other cardiac pathology other than mitral valve prolapse, they noted the presence of fibrosis in these patients. And again, fibrosis was in the segments adjacent to the posterior medial pap muscle. In fact, in this autopsy study, they found the prevalence of fibrosis was almost close to 90%. In a human series that we looked at, we found that prevalence really was ranging anywhere from 10% in patients with a small amount of regurgitation to as high as 50% in patients with significant mitral regurgitation, so that there may be some relationship with severity of MR, or maybe again related to kind of the severity of their prolapse. But in this series, we also found that patients with mitral valve prolapse who had evidence of scar detected by CMR did have a higher arrhythmic risk than those patients with prolapse without detectable scar, or a control group of patients with mitral valve prolapse without scar. So I think, again, this case, I think, highlights the unique ability of MRI to look directly into the myocardium and identify myocardial damage, which I think can help us to kind of refine the way that we manage some of our patients. So with that, I'm going to pause. I'm going to thank you for your attention, and I'm going to turn it over to Faisal. If you want to get set up, Faisal, and also any comments from Michael or Faisal regarding these last two cases.
Yeah, I think it's somebody asked about mitral annular dysfunction and mitral regurgitation, and I think obviously the presence of scar raises the risk for these patients with mitral valve prolapse regarding more a worse phenotype.
Okay, I will do at least one case, and I'll try to get through two if we have time. This is a 38-year-old female with a history of hypertension, and she's been having progressive shortness of breath. Here's her echo, and images were a little bit tough, but I think we'd all appreciate in this 4-chamber view that the right side of the heart looks enlarged. For this reason, she was referred for a cardiac MRI. You have the cine images on top, followed by the LGE images on the bottom. And I hope you'd be able to appreciate that, at least in these views, the RV does look a little bit generous. Now here we need to quantitate volumes before we decide what's big or not. But in general, if you look at the RV over here, it does kind of look generous. And if you look at the 4-chamber as well, I think you'd appreciate probably that right atrium is enlarged as well as the RV. And if we look at the LGE, there really is no evidence of scar. So, the next step really is to trace the ventricle from base to apex. And here we can see left ventricular size and ejection fraction are normal. However, if you look at the right side, you can see the RV is at least mildly enlarged, and whereas the function is normal as well. And if you were simply to look at these numbers, and if you compare the stroke volumes of the two ventricles, you'd see that there is at least a 4-liter difference between the right and the left. So the next step is to find out why that is the case. And one of the first things we do is really create a stack of 4-chamber slices. And you can see by doing this, we're able to very nicely identify a secundum ASD. On the same token, we can then also create an orthogonal view to the view I just showed you and create a stack of that as well. And I hope you'd be able to appreciate where I've left these arrows, that you can see there's a defect in the septum and appreciate the left to right flow. If it's a little bit hard to see, it's okay. This becomes a little bit easier with phase contrast CMR, which is our Doppler equivalent. Those are those same two orthogonal views, the 4-chamber here, and that short axis of the both atria. You can see the flow here going through this septum in these two different views. And we use these two different views. The next process then is to calculate a QPQS. Here we're quantitating the flow through the right side, and you can see here the net pulmonic flow is 8 liters per minute. And when we compare it to what's happening on the left side at the level of the sinotubular junction, you can see the aortic flow is 4 liters per minute. So this is a QPQS of 2 with a total of 4 liters of shunting. Very similar to what we had seen with our left and right stroke volumes. One of the things we can do with CMR is we can create an orthogonal view through the septum and actually create an en face view of the intraatrial septum. And so this view right here is that product, and you can see very nicely that this is the ASD en face through the septum. And we can make measurements here for device sizing. You can tell the relationship to other tissues, which can be very important. But equally important is we can measure flow directly through what is the ASD. And here we only measure 2 liters per minute. If you remember, the net flow difference was 4 liters. So here we were only accounting for 2 liters through this ASD. So this right away told us that there's more likely another source of an intracardiac shunt. And for this, we performed an MR angiogram. And for the sake of time, I hope you'll be able to appreciate here, there was a left superior pulmonary vein that was draining into the innominate vein here and was contributing the remaining 2 liters of the total left to right shunt. So there's publications on how to go about creating this. It can be very helpful to create these en face views, not only for sizing, but to look, you can identify fenestrated ASDs, which would be surgical indications rather than for percutaneous closure. It's been shown that en face views correlate better than the QPQS when it comes to invasive oximetry. And it's also been shown that when it comes to device sizing by CMR has been shown to be better than simply by doing it with ice. Do we have time for another case, or?
I think we're at our time, but that's a great case, and I think it points out always, the direct assessment is important, because again, that tells you if the numbers don't match, there's got to be another shunt somewhere else. And with congenital heart disease, the one rule is if you see one defect, you got to look for others, because there oftentimes can be others associated with it as well.
What
so
a great
Faisal
session,
and Michael, thank you very much. These are great cases, and I know we're out of our time. So I'm going to turn it back over to Carlos and Bill in the studio, and I guess we'll move on to the last session, which is on nuclear cardiology.
Yes, Dipan and Michael and all, a beautiful session. Can you answer a very quick question, less than a minute, both of you? One is, do you report an mitral annular disjunction in patients who don't have mitral valve prolapse? Do you mention anything, or you just leave it alone?
Yeah, no, so right now we're not routinely mentioning mitral annular disjunction. And again, I think we talked about this yesterday. There's it can be challenging to identify whether you're seeing truly disjunction or you're just seeing the posterior leaflet kind of hugging against the left atrial wall. So I think there's still a lot more that needs to be learned about that before we start making management changes and decisions.
And Michael, a quick one on amyloidosis.
Yeah, I agree. Only when I've seen the very clear prolapse where you can clearly see a separation between where the annular plane is and where the myocardium is. Sometimes we'll mention it.
The other question to you, probably Michael, in amyloidosis, what's the sensitivity and specificity for MR for amyloidosis, and early amyloidosis? I mean, we're talking in the high 80s, 90s. What do you think?
I think the data is in the. It depends on which data you look at, but the data actually, when you look at the area under the curve, the study I showed yesterday with the combination of T1 and T2, although it's from a referral center, the areas under the curve are in the sort of 0.9 range. I showed some of the data yesterday in terms of the sensitivity and specificities. Earlier disease, we see some cases where we'll just see an abnormality of ECV, as we were mentioning in this case, and that my experience has been that more of those have been these AL cases rather than ATTR. But I think you can't just do MR. You need to. I think it's important to do the PYP and to do the SPEP, BPEP, and light chains.
Excellent. Well, thank you all. An amazing educational session. Great cases also, and great discussion. Thanks again. All right, we'll turn to our last Meet the Expert read session, and it will be on nuclear and PET. And it will be co-moderated with Dr. Al-Mallah, Mouaz Al-Mallah, and Dr. David Walensky.
Live, and we're excited to be the last, but probably one of the best sessions, and to show you where nuclear cardiology adds to the management of our patients. So I'm Mouaz Al-Mallah. I'm the Director of Cardiovascular PET at Houston Methodist, and it's a great honor to introduce Dr. David Walensky, who's the head of nuclear cardiology at Cleveland Clinic, Florida, and he's going to share with us some interesting cases about nuclear cardiology, mainly SPECT and amyloid imaging. David, take it from there.
Thank you, Mouaz. Thank you all for hanging in there. I'm sure it's been a long day today. Hopefully this last half hour will be valuable to you. These are my disclosures. So first case is a 74-year-old male with a 8-year history of non-ischemic cardiomyopathy. Etiology was alcoholic versus burnt out hypertrophic cardiomyopathy. Normal coronary arteries, EF longstanding 30 to 35% with an ICD. And after stabilization, he was heart failure class 1 for many years. 2 years ago, he had recurrence of symptoms, non-obstructive coronary disease, mitral regurgitation on echo, LVH described on echo, and he actually was referred up north to the main campus, actually to evaluate for a mitral valve procedure. At that point in time, his EF was 44%. He had 3+ holosystolic mitral regurgitation and a new wall motion abnormality in the distribution of the circumflex. Interventricular septum was 1.4, posterior wall was 1.2, and repeat coronary angiography was unremarkable. I know I'm a nuclear cardiologist, but I will just put a little bit of echo here just to kind of show you. Ejection fraction is down. Certainly the mitral regurgitation is not overwhelming. Probably not enough to explain the symptoms that he had, but he underwent MitraClip in the fall of 2019 with clinical improvement, and then he returned to the west coast of Florida. And he did well for 18 months, and then he had recurrent shortness of breath and heart failure, multiple hospitalizations. They called Cleveland. Cleveland said, go to Cleveland Clinic, Florida on the East Coast. He came to us with the plan to have another MitraClip, but his initial TEE only showed mild to moderate mitral regurgitation. Right heart cath showed relatively normal resting hemodynamics, but a very, very stiff ventricle with V waves of 26 and a reduced cardiac output, which is not what you would expect for a guy who was doing relatively well at rest. Go back to the history. He had a history of bilateral carpal tunnel repair, lumbar stenosis, status post surgery, rotator cuff injury. So here is his strain. And although it's not classic cherry on top, you certainly can see a gradient from apex to base. So at this point, we were contacted and sent him to get a PYP scan. And this is his whole body planar scan, and certainly looks positive, but it kind of looks like there's a hole here. And I wasn't quite sure exactly what to make of why I saw that hole there until I looked at the SPECT images. And you can see here in the SPECT images are very, very positive. But in the area of that wall motion abnormality, clearly has had somewhat of an event, and it may very well be that was responsible for his deterioration. At that point in time, we started him on disease-modifying therapy, but he continued to deteriorate over time, and really within 6 months, he ended up in hospice and passing away. I bring this up because I've now seen, well, let's go on just a little bit. We talk about aortic stenosis and amyloid, and we tend to look for that with about 1 in 7 patients undergoing TAVR having evidence of amyloid by testing. Well, what about mitral valve disease? What do we know about this? There's not a lot written about it. This is a case by Mass Hannah, which was the first case of MitraClip placement for a flail leaflet. Dr. Tajik reports 2 cases in JACC imaging, and there's another case of advanced amyloid cardiomyopathy unmasked by mitral valve replacement. There's a lot of mechanisms for this, and I bring this up because I've now seen 5 patients in the last year and a half who came to me, and I made the diagnosis of amyloidosis after them undergoing surgical mitral valve repair or MitraClip that failed to respond. So there's certainly amyloid involvement in the tissue. Flail leaflets are not uncommon in this situation, or mitral regurgitation just from dilated end-stage cardiomyopathy. So at least look at the rest of the echo besides just looking for mitral regurgitation. And certainly if the patients do well, think about the possibility of some other concomitant disease. Next case, 62-year-old male with no past history. He bikes 25 miles a week. He comes to the ER. He's got a 3-week history of recurrent retrosternal chest burning with effort. He came to the emergency room because his health insurance was running out, and he wanted to know what needed to be done during December because he had paid his deductible and he wasn't going to have insurance next year. This is what we see in Florida all the time. EKG was normal, but even though he was pain-free and hadn't had any recent pain, they drew a high sensitivity troponin, which was elevated. Standard troponin was negative. So what's the best way to evaluate this patient? And the questions are, would you discharge him and tell him to see a cardiologist, do a coronary CTA, keep him for an MPI, or keep him for a coronary angiography because maybe this is acute coronary syndrome? And of course, it's usually on a Friday. I want to talk about when functional testing is really helpful in the emergency room. First of all, most of the studies were done using TIMI scores, not heart score. Cleveland actually put together a big paper showing the low overall yield, but it was done with the heart score, or the TIMI score. Paul Kramer and I tried to redo the study looking at heart score, but we didn't have enough information on it. But if you have TIMI 1 or TIMI 2 or low heart score, the likelihood of having ischemia that you'll do something about is minimal. But once you get to a moderate to high TIMI score or a moderate score and a heart score, then the prevalence of ischemia that you'll do something about, which is greater than 10%, increases enough that in the symptomatic patient, it is probably justified if that's your algorithm that you use in your emergency room. The other thing that's worth looking at is the relationship between troponin and predictability of an abnormal myocardial perfusion scan. And there are two things: an elevated HS troponin or doubling of the troponin are associated with an abnormal SPECT scan. If not worth doing. So in this case, he underwent a stress rest myocardial perfusion imaging. I think what you can see here, if you look, is there is a decreased perfusion of the apical septum and the septum that appears to reverse. There's also a question of decreased perfusion of the inferior wall and apex, suggesting right coronary artery disease. He had a stress test when he did the Bruce protocol. He did 13 METs. He had no chest pain and no EKG changes. So the question is, where do you proceed from here in a patient who has an elevated troponin and an abnormal scan? So one of the questions you ask, is it left main? Is it LAD? Is it LAD plus right coronary? Is it right coronary? Or do you need more information? And I'm not sure what any of you would answer, but I would actually say that you need more information. And so when you look here, we added prone imaging, and we do prone imaging on everybody who can lie down. And the inferior defect really reversed, and that relatively left you with an LAD defect. So it's interesting when you look at the total perfusion defect, if you calculate it based on the stress only, it's significantly elevated at 14% of the myocardium. So here's his coronary angiography, which he went to because he had abnormal stress test, and he had positive chest pain, and he had troponin, he had a lesion in his LAD that was fixed, and the right coronary artery was normal. So I think when you're dealing with patients, you really need to do either attenuation correction, or if you do inspect, you need to do prone imaging in just about everybody. This happens to be the indications for revascularization, and this patient doesn't really fit into anything. If you can say he's got unstable angina, well, stress testing doesn't really fit as a criterion because you don't stress people who are unstable angina. If you want to look at patients who have stable ischemic heart disease from that guideline, then they certainly do have what appears to be perfusion defects of greater than 10%, but unclear whether you count the prone imaging or the routine supine imaging. So he did undergo revascularization of his LAD, and he's done well. And we haven't seen him again because he doesn't have any insurance, so we don't know what happened to him. I think prone imaging, again, can reduce diaphragm attenuation. It moves the heart anterior and away from the diaphragm, but it does not, and it should not be used to eliminate anterior or left anterior standing artery ischemia.
I mean, this is a very interesting case, David. I think this highlights some of the challenges with SPECT that I mentioned yesterday in my talk, and important that if we want SPECT to continue to be relevant, I think prone imaging and CT attenuation correction should be a routine in these protocols. Otherwise, we will be overcalling a lot of attenuation artifacts as ischemic defects.
Yeah, and we routinely prone everybody who can be proned. Now, it's a question of how hard the technologists try when we ask them to do it. But I think you'd be surprised on how many people that you don't think can prone really can prone, and the images really help quite a bit. We'll be switching to PET in about 5 months for these patients, so we won't have that issue.
Excellent.
And I'll do one more case. A 55-year-old male with a history of hypertension, hyperlipidemia, and diabetes presents to the emergency room. Headaches and cramping left arm pain, markedly hypertensive with a non-diagnostic EKG, but an elevated total troponin. And in our emergency room, it is random whether they draw troponin or a high sensitivity troponin. There is no rhyme or reason how they do it. But the patient was admitted to the observation unit. And actually, cardiology wasn't called right away. But cardiology was called in the middle of the night for ventricular tachycardia. And he kept having these runs of ventricular tachycardia. They're obviously artifact, but that's the only reason that cardiology was called for that. But having been called, they then said, what would you like to do? And the question is now stress echo, exercise MPI, pharmacologic MPI, exercise treadmill testing, or coronary angiography. So this was during COVID, so we were doing only pharmacologic stress at this point in time. So we underwent pharmacologic stress testing, unremarkable with respect to ST segment changes, and we look at heart rate response in everybody, but we did not see any significant heart rate response abnormalities. And you look at the images and you see what appears to be decrease in counts in the septum, decrease in counts in the apex, and some decrease in counts in the inferior wall at this point in time, most of which reverses. The prone imaging didn't add anything. If you look here at the raw data, you don't see a lot of attenuation here. This really does not seem to get in the way when you look at the spin all the way around. So then what do you do at this point in time? Single vessel disease, optimal medical therapy, single vessel disease, cath, multi-vessel disease, cath, doesn't matter. There was ischemia and positive troponin and cath. And I bring this up because we always have to go back to the history, because once you start an algorithm in motion, you're often likely to head down to a place that you don't want to be. You have to start with the history, and you have to start with patient first, patient-oriented, patient-focused management of what information you need to know for the patient. You cannot do the same thing for every patient. You cannot make the same choices for everybody. So again, we look at the images, we look at it as quantitation, and I rarely look at quantitation until afterwards. But here, because of the borderline areas, I do see that there's evidence of reversible ischemia in the LAD territory, reversible ischemia in the right/circumflex territory. There's not a lot of it, but I cannot rule out the fact that this is two-vessel coronary disease. So based on that, we made the recommendation that he be referred for coronary angiography. He had three-vessel coronary disease. He was referred for cabbage. So this is how I use quantitation. We then use the quantitation to help generate our structured report. But I look visually, I qualitatively assess, and then modify the bullseye plots as necessary. And I think for the sake of time, I'll skip the last case and turn it over to Dr. Al-Mallah, and we can always do this if there's time.
Sure. If you can stop sharing, David, so I can share my screen. All right. So I'm going to just show some very quick cases to illustrate a few quick points. So this is a 61-year-old who just happened that the BMI of the patient is the same as the age. Another BMI of 61. And the patient came in with chest pain, referred for testing, and at the BMI of 61, you're probably going to be very limited in the options that you can do. And you can see the image quality. And I'm just trying to show you this because we've done so far nearly 100 patients with BMI above 50, actually 150 patients with BMI above 50. And you can see the diagnostic image quality that we are able to get. Just to give you a sense of the precise problems with these BMIs, this is the CT we get. And you can see the amount of soft tissue that's there. Technically, I mean, I don't think CT is an option in this patient, and I'm not sure the patient would even fit in the MRI scanner. But what was interesting, we also do calcium score. It's going to be a very challenging to do a calcium score on this patient. And you can see calcium score is 1,936. Now, ejection fraction, again, despite this, and this is using a digital PET scanner, and this is still about 1.5 to 2 millisievert study. So 2 millisievert study for a BMI of 61, that probably doesn't exist. And you can see excellent image quality. The echo, by the way, they could not even estimate the ejection fraction. And we got the ejection fraction for this patient from nuclear, 78%. And looking at the flow reserve, you can see that her flow reserve is normal flow at rest. It went up and almost doubled. So we are sure that despite this high calcium score, there is good perfusion, and this was a good test for this patient. And we were able to answer all the relevant clinical questions for this patient. Presence of atherosclerosis, normal LV ejection fraction, and obviously there is need for urgent weight management issues. I'll show you another case, and the theme from SPEC that you just heard from Dr. Walensky, that sometimes nuclear may struggle in differentiating single vessel from multi-vessel disease. So this is a 66-year-old male, again, came in with chest pain, and you see a very dense perfusion defect in the distal anterior wall, mid to distal anterior wall and apex. So there is TID at 1.09. The biggest question is this a single vessel or multi-vessel disease? Looking at the ejection fraction, it actually went up by 3%, nice image quality. And looking at the calcium score, you can clearly see that we see calcium, but the calcium is mostly in the LAD, 115. Now, that doesn't rule out other vessels being affected, but we have to look at physiology and the flow reserve. Now, I see that the flow reserve is reduced at 1.58, but look at the flow reserve in the right corner. It's almost 2.4. Look at the flow reserve in the circ, 2.1. So we are pretty sure that this is single vessel disease, and for the sake of time, you take my word for the coronary angiography. This was a single vessel disease patient, and this is a clear case of a patient having single vessel disease. And then the second case I'd like to show you for PET perfusion is this case, which was referred by one of our cardiologists. Now I'm looking at the perfusion scan that, I mean, maybe you want to call a subtle inferior perfusion defect, maybe, maybe not. A 75-year-old lady who came in, but this is a patient that there is transient ischemic dilatation. The cavity looks bigger with PET perfusion. Looking at the ejection fraction, there was an increase from 39% to 50%. But looking at the flow reserve in this case, her resting flow is 1.39. It did not even go up. She was hypertensive, so even if you correct for that, that's still below 2. And this is a patient who has reduced myocardial flow reserve. And her ejection fraction, we already mentioned that. The calcium score in this case was 1,230. So we know that there is severe atherosclerotic burden. So this is not a low-risk scan by any mean. Maybe if we are not looking at the overall picture, we're going to say, oh, small perfusion defect, let it go. But this is not a normal low risk because we have high calcium score, high atherosclerotic burden, severely reduced myocardial blood flow. And this patient actually, she went for the cath lab and she had severe three-vessel disease. So these are three clinical cases that I clearly showed you that the value of flow and PET-derived myocardial blood flow, which is very routine now, does not add any radiation exposure to the patient. It is reimbursable and it is very helpful in the clinical decision-making for these patients. In this case, for example, the flow made a low-risk scan, or technically a small perfusion scan, make it look high risk because of reduced flow. This is another scan that I just showed you where a large perfusion defect, but we know it's a single vessel disease. And this is where flow helped us in the assessment of a patient who has an extremely elevated BMI. I want to finish up with a case that Dr. At-Tilawi actually was fascinated with when he was during his fellowship days, and I want to finish up with this case. And in fact, Dr. At-Tilawi went ahead and published this case as a case report. So this is a 65-year-old male who came to us because this patient has been shopping around and people looked at his management because he has heart failure with reduced ejection fraction, coronary angiography was normal, and they just could not figure out why this patient has reduced ejection fraction. So part of his workout management, he had a CRTD, and this guy was getting a lot of shocks. I mean, he told us when he came that he had in one day 30 ICD shocks. They put him on all type of antiarrhythmic therapies, and that didn't help him. Part of his workup, I'll show you the MRI for the sake of time. You can see his ejection fraction is severely reduced. This is not our regular MRI images. We got much nicer images, but this is a device protocol. So this is done while the patient has an ICD. And you can see the amount of delayed enhancement or late gadolinium enhancement. This is a burned out LV. And this patient, before he came to us, actually already had a biopsy, and the biopsy came as non-specific fibrosis. And this is not unexpected because this patient has severe degree of late gadolinium enhancement, and this is more of a burned out LV. So there were a lot of concern whether 41% scar, is this all scar induced VT and shocks, or this is like something else going on. And this was when we just started our cardiac PET programs, like, can you try your new toy in this? Maybe you can help us. I'm going to skip some of these slides for the sake of time, but go ahead more to the PET scan that we did for this patient. And this is one of our very first PET scans that we did for inflammation assessment. And on top, you have the perfusion images. In the second row, you see the FDG images. And you got fascinated by the amount of inflammation we see in this case. There's a perfusion defect here, and there's significant FDG uptake in this area. But what was also interesting, even as you get to the left atrium, there is severe FTG uptake in the left atrium. So these areas kind of matched with the areas that had the intensity of late gadolinium enhancement. And just to kind of help you also see it more with the fusion imaging, it will kind of help localize it. So a lot of LGE in the of FTG uptake in the area of LGE in the septum, in the apical inferior wall. But also the new finding here is that it is a lot in the left atrium. And if you go to his ICD shocks, most of them were inappropriate because he was having a lot of atrial arrhythmias. So we told them at this time that this is a patient who's having severe severe inflammation in his myocardium, and I think the best way to stop these ICD shocks is to really put him on anti-inflammatory, because he's already maxed out on antiarrhythmic, and that's not helping. So he went ahead and had treatment, and to the surprise, I mean, there were not much improvement in the LV. So this is his second PET scan, and you don't see much uptake in the LV, difference in the uptake in the LV. But what was interesting is that his uptake in the atrium almost went away there. So there was no uptake, and if you talk to the patient, he will tell you that the scar burden went, the shock burden significantly decreased, and now he's not getting these 30 and 40 ICD shocks a day. Lucky enough, this patient actually, a few days after the second PET scan, he actually was called in to get a heart transplant during the pandemic, and the explanted heart does show non-caseating granulomas. So 2 biopsies that are negative, but on the explanted heart, it did prove that this patient did have actually sarcoidosis, and now we follow him by PET for actually to look for transplant vasculopathy. So this is a clear case that shows you that PET adds a lot of diagnostic and also health management in these patients with complex cardiomyopathies and suspicion for inflammation, most commonly sarcoid, but also other connective tissue diseases. I think we are on time, and we got our 30 minutes used very efficiently, so I'll hand it back to Dr. Zoghbi and Dr. Al-Talawi.
Thank you very much, Mouaz and David. Really fascinating to end our session on amazing cases, nuclear cardiology, PET, and it just demonstrates the power and at times some of the limitations even of biopsies to be able to come to a diagnosis, and particularly this last case that you showed. So I want to thank you, thank Dr. Al-Talawi, thank our audience to be with us, and hope you enjoyed today. And we look forward to seeing you half day tomorrow morning till noontime, and wherever you are in the world. This will be adult congenital heart disease and aorta and peripheral vascular disease. So look forward to seeing you again tomorrow. Bye-bye.